All right, good morning, everyone. We are going to call to order the Human Services Committee public hearing for Thursday, February 27th. And we'll get right to it. And so is Commissioner Andrea Barton-Reeves with us. All right, come right up.
Good morning. Morning. Good morning, Chairs Lester and Gilchrist and Ranking Members Harding and Case and distinguished members of the Human Services Committee. I am Andrea Barton-Reeves, Commissioner of the Department of Social Services, and I am pleased to be before you today to offer remarks on behalf of regarding several bills on today's agenda. I will start with Senate Bill 1359, which is an act concerning various revisions to statutes concerning the Department of Social Services. You do have our written testimony. I will not torture you by reading all of it. I will just highlight certain parts of it that we would like to bring to closer attention. So Section 1 allows our child support enforcement system to be automated with respect to administrative enforcement of interstate cases, which is required by federal law. Notably, federal law does require us to cooperate and assist other agencies with the seizure of certain assets with respect to overdue child support payments. We need to have a legislative change in order for us to be able to comply with this federal mandate. And this will remove the statutory barrier that we have that will allow our Office of Child Support Services, which we refer to as OCSS, to provide the support that's needed to other states so that we can comply with the federal law. Section 2 of Senate Bill 1359 also allows us to conform with federal laws regarding the modification of child support orders. Right now, those orders have to be based on the obligor's current income and ability to pay. And the federal laws do not allow for incarceration to be considered as voluntary unemployment, which is a practice that we have in our state. So therefore, an incarcerated individual should be able to have a downward modification of their child support payments based on a loss of income and their inability to work because of incarceration. But we do need a statutory change in order to do that. So going to Section 3 regarding assisted facilities and the postings of the notices in those homes. Right now, they are required to post in what we like to consider a prominent place, what is known as the Residents' Bill of Rights, including how to get in touch with the Department of Public Health and the Office of the Ombudsman. This would also allow for the adding of the number and ways in which you can make a report regarding DSS protective services, which is currently not included on the report, on the postings, that would allow a person to report on suspected abuse, neglect, exploitation, or abandonment of an elderly person. Section 4 requires us at DSS to begin staggering SNAP benefits starting on March 1 of 2026. It also provides for a report as of April 1 and annually. What we're respectfully asking here is that after we've staggered the report, that the annual report be changed. So because there really wouldn't be anything to report after the staggering unless there's a specific issue with the program. So we're asking if we can continue to work towards the staggering as we are now, while maintaining maintaining the requirement for the initial report after implementation. Moving on to Section 6 regarding the autism waiver. And this is one I think from my past experience is really particularly dear to my heart. So the way that the statute is currently drafted is this, that if you work for the Department of Developmental Services, you have access to the Abuse and Neglect Registry, which allows us to determine whether a person is on that registry and therefore should be barred from providing services to a vulnerable person. But the only agency that has access to that registry is DDS. So when we're looking to do the kinds of reviews that we believe are appropriate for providing supports for elderly persons and other people that we support, including autism, we don't necessarily have access to that registry. So we rely on the other background information that we can get. We would very much like to have a change to that. When the registry moved from DDS to DSS, that was one piece that for some reason did not move statutorily. We believe it's extremely important and would like to see that happen. Now, moving to Senate Bill 1360, an act requiring legislative confirmation of the appointment of the Department of Social Services Medicaid Director. We do know that this bill would require the commissioner to nominate a director for appointment and go through the confirmation process. We are opposed to this bill for a number of reasons. The first of which is that a politically appointed medical director does not lend itself to the stability and consistency that the Medicaid program really needs. We know that it can lead, sometimes the appointment process can lead to a declination of that particular candidate. And in addition to that, prolonged vacancies or interim leadership due to changes in administration can often lead to administrative and confirmation delays that can hinder the implementation of the program. What I wanted to note here is that prior to our to our current Medicaid director and the brief time that our other Medicaid director, Guy Wilson, was with us, who was excellent, we had a Medicaid director for quite a long time, Kate McAvoy. She was excellent, as we know. And she was here during different administrations and different governors. We know this from the Medicaid landscape analysis that we're one of the best states when it comes to overall the quality of our Medicaid program. That happens when you have consistency in leadership. And so in our own state, we have a perfect example of why this consistency is important and why there is a possibility that could be compromised if we went to an appointment process. Additionally, we do believe that the politicization of Medicaid could undermine the impartiality that is needed to balance federal compliance and state priorities and diverse stakeholder needs. And it could potentially prioritize political alignment over expertise and discourage qualified civil servants who prefer less politicized positions. So for all of these reasons, and those that are continued to be listed in our testimony, we respectfully and strongly oppose Senate Bill 1360. Moving to Senate Bill 1358, an act concerning equitable compensation for state contracted human services providers. This would require DSS and the Office of Policy and Management, to conduct reviews of the bills of services provided by human services providers to determine whether those rates are adequately compensate the providers. And it would also require that purchase of contract services be paid no later than 30 days after the services are delivered. This section of the bill requires all state agencies to make payment to private providers no later than 30 days after the receipt of these services. The challenge that we have here is the primary challenge here is that this really isn't feasible. So services are provided on such a varied basis over so many different not-for-profit providers that 30 days after the delivery of service means something different for every single provider. It is administratively burdensome, and it is also it's not necessarily necessary in order for providers to be paid. So providers already have a process through which they are paid. That process is working, and moving into a 30-day process for every provider type that we have that fits into the not-for-profit space is really, it is a burden, not just for DSS, but for DDS and every other agency that pays providers. So we're respectfully asking that this not be passed and that we oppose this legislation. Moving to Senate Bill 1122 regarding performance audits for Medicaid funded programs by the auditors of public accounts. The point that I'd like to raise here is that these audits are already happening. We have all of our programs audited on some particular schedule through the state auditors of public accounts already. So they are already performing these audits. This has been happening through our Protective Services for the Elderly program, which was just recently audited, our assisted living facilities and other programs. In addition to that, as you know, the APA already audits the entirety of DSS as it does every other state agency. While we don't have any particular concerns regarding the audits, we would like it to be noted that they are quite laborious and they do require a significant amount of staff resources. We do this in addition to our statewide single audit and our biennial department audit, both of which are done pursuant to Section 2-90 of the general statutes. So in essence, we don't believe that this is necessary because audits are already occurring and happening. But if the bill were to move forward, we would respectfully request that the language be revised to place a cap on those audits to 4 per year, given the current resources that we have both at DSS and at APA. Moving next to Senate Bill 985, which would require legislative approval for changes to the Husky Health Program reimbursement and delivery care model. The primary focus of this bill, as we read it, is to make sure that changes to the fee-for-service Medicaid payment model to a managed care payment model do not happen unless they are legislatively approved. Well, the issue here is that not only from our perspective do we believe this is very broad and overly vague, that these types of changes, particularly changes from fee-for-service to managed care, are considered a significant change to the way in which we deliver services, which means we would have to change our state plan amendment. And the only way the state plan amendments change in this state legislatively, as we know, is through legislative approval. So there is already a very significant stopgap and protection that's already in place that would not necessarily make this bill a necessary one. In addition to that, I would like to bring to your attention some programs that we've already brought and made changes to. They've already been brought before the Human Services Committee and the Joint Committee with Human Services and Appropriations. And this is in my written testimony, but I did believe it was worth reading out loud. For example, our PACE program, which is known as the Program of All-Inclusive Care for the Elderly, that is a it is a federally sponsored evidence-based program that provides holistic support for people who are 55 and older who are dually eligible. It has a managed care component, and that includes provider sites that receive a capitated payment. PACE has been an exceptional program in this state and in others. If we were to be limited by the ways in which the statute is currently written, we would not have been able to pursue the PACE program. And that would mean that there would be individuals who would not be able to get access to that level of care. Also, the broad wording of the program could also be interpreted to limit DDS's ability to explore and implement other payment models. So for example, when there was an ask throughout the advocacy and other communities, our primary care community, to look at our primary care model as an example, we did that through a multi-year stakeholder-driven process that developed a primary care model centered on key domains and specific performance measures. When the call came very recently within my tenure, this is something that was started before I came and had continued, and we do need to start it again, to take another look at how the primary care model might work in this state. Those same stakeholders and others were also convened, and that process was done with a lot of transparency. And hopefully we had a transition in our Medicaid director, so we haven't picked that up again, but the intent is to continue to do that. So the work that we're doing there and the work that we'll continue to do will build on specifically the person-centered, what we know as PCMH Plus, the Person-Centered Medical Home Plus program. That was the intention of the work that was being done by the primary care work group. And that's the kind of work that we can continue to do. And my final example here is that when we were making our way through the pandemic, and lots of laws were relaxed during that period of time. But we found that some of the processes, and I'll ask some of my staff to join me to give you more specifics, were really very beneficial to the people that we served. And we wanted to include them in our SPA. We did not do that through policy, although some of them we had the power to do through policy. Instead, we brought them back and said, we want to change our state plan amendment and make them permanent. And we did that under the current existing statute, which is why we'd like to continue to have that flexibility to do so. We are very open to feedback on how we can do this better. But respectfully, we do oppose this particular bill. I will move on to House Bill 7024, an act concerning Medicaid coverage for allergy prevention. We do oppose this bill because there are a number of reports and research that suggest that the early introduction of the actual foods themselves, rather than the powders and the other kinds of substances that might be available, can always that's a process that's always available to families. They don't have to have the resources to buy these specific packets. This is also something we're very sensitive to, that while it may be available to families that are within certain income brackets, it's not available to all families at all. So while we understand that it's important to make sure that children stay safe, that they are not exposed to foods that may cause them to have a very severe allergic reaction. I will read a small part of my testimony where an article that was published in Pediatrics states that while these particular substances and programs, and I'll just stick with the word substances, are, excuse me, are made available and marketed across the world, Caregivers may be led to believe that these commercial products are necessary to avoid food.
I want to look back at the last 5 years. 82.
Representative Stewart. Oh,
It's okay. Thank you. They're not necessarily safer than giving actual food to infants. Obviously, they can be given in very small amounts, and these materials actually they contain the actual food that the child might be allergic to. So it adds a layer of confusion and mixed messages. Again, this is from the Journal of Pediatrics. This is not our personal testimony, that parents have to navigate as they try to understand and incorporate food allergens into their infants' diets. There's also a significant cost of $3.3 million to these dietary supplements that would be added to the budget that is not currently contemplated in the governor's budget. So for these reasons, and particularly for the reason that families can be educated, and so all families would have access to determine whether their child is allergic to a particular food, we do respectfully oppose this bill. Now, moving on to House Bill 7026, an act concerning exceptions to the nursing home bed moratorium. This state has had a moratorium since 1991, and its primary purpose has been really to make sure that we have what we know as a balancing of the number of nursing home beds that we have with the number of people that we believe will need them over time. Well, a number of things have happened, as we know, many, many things have happened since 1991. And we are at a place, as we recount today, where we have maybe we have as many beds as we have people who may want to move into a bed as we're moving through the aging process in our state and aging population. So that might necessarily mean that we may need to lift the moratorium so that we can have enough beds that are available on an as-needed basis. And that's what this bill is asking for, that to allow the department, as the need arises over time, to be able to lift the moratorium on an as-needed basis so we can create capacity in the system for people who will need to have the higher level of skilled nursing home care. It's not a full lift of the moratorium. It just allows us to do it on an as-needed basis so we can meet the needs of our aging population. So we were looking for that flexibility. And we would only authorize them under extreme need and circumstances. Moving to House Bill 7023, an act concerning Medicaid reimbursement for substance abuse coaches, I may ask one of our team, Fatmata Williams, who is our Deputy Medicaid Director, to join me to add more information if during the questions you may have more. But right now, we are currently supporting community health workers or peer models in a number of areas. PCMH Plus, our substance use disorder residential treatment program. We're also exploring community health workers and peers under home visiting, the nursing program, the home visiting nursing program that we do in collaboration with the Office of Early Childhood and the Office of Healthcare Strategy. It is also already built into our justice involved waiver, which is currently pending approval. And it's also built into the care coordination and inclusive of chronic disease care management models with our, what we call our CCBHC, which is our Certified Community Behavioral Health Clinics model. We were approved for the planning grant for that model, and we're working on that as we speak. Furthermore, DSS is in phase 2 of the testing of the effectiveness of the community healthcare working model in what's known as a test and learn initiative, which Deputy Director Fatmata can give you more details about during the question period. But we strongly support the concept, but we're already working on this concept. But at this moment, we would ask that either the bill be not passed in this session or give us an opportunity to continue to do the work that we are doing right now as it relates to the peers and the community health workers. House Bill 7021, an act concerning funding for nutrition assistance, appropriates $10 million to DSS in FY 2026 to support the Supplemental Nutrition Commodities Assistance Program. So while we appreciate the legislature's intent and commitment to this program, there is only $900,000 that is currently in the governor's budget that is directed to food share in 2027. And the 10 million is not included in the governor's recommended budget. So we respectfully cannot support that legislation at this time. Discussing House Bill 6937 regarding an act concerning Medicaid coverage for medically necessary children's diapers. We do know that this bill is deemed to provide diapers where medically necessary. We actually do, and I think that the committee may be familiar with the report that that was provided regarding the medical necessity of diapers. We do cover diapers under Medicaid for children who are age 3 and older when those diapers are medically necessary for the management of incontinence that is related to a medical condition and based on the individual needs of each member, and that is consistent with the Medicaid regulations. The Medicaid regulations also limit the supplies to those who are, quote, required to address an individual medical disability, illness, or injury. While there are other states that may have covered these, they have done that in a more comprehensive way under an 1115 waiver, where they have been able to redirect resources under a larger umbrella of other services that they have provided in order to cover the cost of the diapers. That is not the case here in Connecticut. So the gross total expenditure would be 31 million with an approximate state share of 16 million. So because that is not in the governor's budget, and it could potentially cover all children under age 3 as currently drafted, and that cost is actually more like $123 million with a $64 million state share. We respectfully oppose this particular bill. And that actually concludes my testimony on all of the bills. I do appreciate your patience. I also heard the feedback from the last session that I talked too fast, so I tried to slow down in this one and try to read them. So I appreciate your patience. And I do have many members of our DSS team here, subject matter experts, to answer questions that I cannot.
Wonderful. Thank you, Commissioner. I know a few folks have questions. I'll get us started. So with Senate Bill, and thank you for all your work and for being here. Senate Bill 1359.
Yes.
Could you speak a little bit more to Section 2, what the current law is and what we need to change to be in federal compliance?
Yes, I can, but I'm going to ask Deputy Commissioner Hadler to come up and give you the very
Thank you.
specific detail around this bill.
Thank you. Good morning. Peter Hadler, Deputy Commissioner at DSS. So let me just pull up the Section 2, if you don't mind, and I can walk through this a little bit more carefully. In particular, this is an area where individuals who are incarcerated currently under state law, if they committed a crime against the family, they are not allowed to have their child support obligation reduced. However, our federal partners have indicated this is not an acceptable exception to the ability to modify child support orders. So we are really following the federal insistence that we come forward and make this change, even though obviously it's a challenging population to make adjustments for. We are really sort of just following the federal guidance that we've been provided that we can't have this exception.
Thank you, Peter. And I know I've asked the department, but I'm going to ask it here. What have we found out? What is the ramification from the federal government if we don't take action?
Yeah, the possible penalty is that we would not continue to receive Title IV-D grants, which is basically all of our child support funding from our federal partners. They fund about 2/3 of our program. So there is a risk that could be in jeopardy.
Thank you. On that same bill, just want to mention thank you for Section 6. Agreed. I think having more folks have access to that information on abuse and neglect is vitally important. And then the only other bill I have a question on at this point is the peer support. Can we hear more about the test and learn? That'd be fantastic.
I'm going to ask our Deputy Medicaid Director, Fatmata Williams, to come and speak more about the test and learn.
Thank you.
Thank you, Commissioner, and good morning, senators, representatives. I'm Fatmata Williams, Deputy Director of Medicaid. So yes, so our test and learn has been going on for several years now, and it is a partnership with Yale, and it is to encourage rigorous evidence and evidence-based data decision-making for our Medicaid program. So while we have it in several areas within our medical ASO, and we are trying to actually look at different areas within Medicaid, and DC Hadler's areas is one of them, as well as home and community-based services. But for our medical ASO, we have focused on looking at the effectiveness of community health workers in connecting unattributed members to primary care. So that is in the second phase. And hopefully when we're able to get the results and refine it, we can then be able to scale up the CHW policy to the larger population.
Great, thank you.
You're welcome.
I'm going to turn it over to Senator Lesser.
Thank you, Madam Chair. Question in the bill, in the agency bill, there's a section, section 5 that clarifies that the rate increases based on a gross domestic product deflator when funding is specifically appropriated. And I was curious, I know that they're different inflationary or metrics or deflators, and I'm just trying to understand how the department arrived at that figure. I know there's also there's MEI, there are other sort of ways of looking at cost growth, and I was just wanted to know if you could sort of walk us through that.
I'm going to call Nicole because she explained it to me. So she's the
And now
best.
she can
person
explain it
do
to us.
Yes, exactly. Okay, thank you.
Thank you for the question, Nicole Godburn, Director, Reimbursement and Certificate of Need for the department. So the gross domestic product is actually written into our regulations. When our regulations around how nursing home rates are constructed, it includes a recognition of the GDP, which is an index which is specifically designed and set by the federal government. So we're not calculating it, the Fed calculates it. And when we have the appropriation, we apply the GDP to the rate, and the GDP is specifically designed to recognize when there's changes in the cost of essentially doing business across the nation. That's how the Fed sets it. So we recognize that in nursing homes, they may have inflationary increases from year to year. We in our own households experience it. Nursing homes would experience it as well. So the GDP was written into our regulation when we calculate rates to recognize those adjustments. Again, and we only apply the GDP when we have the appropriation given to us in our budget, and then we factor it into the annual rates for nursing home, which are set on July 1st of every year.
Okay, and and you say your regulation, do you mean DSS regulations?
correct.
Okay. Obviously, you know, the question I have, I know that the appropriation is a sole separate question, whether or not we're able to do that, or we do a notwithstanding to take that out. But to the extent that, you know, my understanding is that medical cost growth has historically been in excess of CPI and other inflationary metrics, and perhaps GDP growth in the economy. So that's why I was just curious about that. And
So when it comes to how we recognize the cost growth when it comes to medical care, that's captured in our acuity system. So when in our acuity system, we're adjusting the direct care component, which is that direct cost for caring for a resident of a nursing home, and we adjust that quarterly. So that flows up and down based off of the need of the residents. But the other piece that's important to nursing homes is that they're institutions. They are the person's home. So there's other costs that go into maintaining that building, such as housekeeping, maintenance, capital repairs to the building, plumbing costs, food, etc., laundry. So there's a whole variety of other costs that are recognized in nursing homes that are not direct or indirectly related to the person's care, very important to the person's care, but not direct hands-on. So in recognition of those other costs, the GDP is the most appropriate index to apply to those cost adjustments.
right, thank you. And then with respect, that's my last question on that particular area. Thank you, Nicole. With respect to Senate Bill 1360, which requires legislative confirmation of the Medicaid director, I appreciate your concern about injecting politics into the administration of the Medicaid program. Certainly, that's not our intent. But I'm just curious how things work currently. Is the Medicaid director position, is that currently a political position?
No, it is not. It is considered a staff position along with all of the others at the agency.
So it is a classified position in
It
state
is.
service? Okay.
Yes, it is.
And then with, you know, I will just say, and we can certainly discuss offline, reviewing information from the National Association of, I think, Medicaid directors, does seem that there's states have a wide variety of different approval processes and legislative confirmation and oversight processes for the appointment of Medicaid directors. And so maybe we can
Certainly.
look at the examples of other states and sort of understand how
Absolutely.
that might
Yes.
impact DSS and sort of what would be the most, strategically wise course of action.
Certainly.
Um, so with respect to I appreciate your willingness to work with us on and your thoughtful testimony on Senate Bill 1122, the auditors, the auditing requirements, and sort of want to be thoughtful about how to best do that and not overtax agency resources, but to be strategic about what questions we're asking and how to better
Yes.
inform legislative decision making. With respect to 985, which is the change of the process from legislative oversight, I hear what you're saying about you want to be able to do PCMH plus and PACE program and have conversations about different delivery models. As I understand that bill, though, it doesn't preclude any of that. It just requires you to seek legislative approval. And you're saying that in some cases that may already be required. Is that true in all cases, that you cannot change payment models without legislative confirmation?
It's not true in all cases, but it is true with respect to large wholesale changes, right? So and I'll go back to the most obvious one that we had all been contending with in the last legislative session and moving into this one, which was the exploration of managed care. We, as an agency, knew that that was causing great concern and consternation. There was a lot of news about it that was very public. At the agency, we were able to actually, I want to think about how I want to say this, but we were actually able to then create, I think, a broader approach rather than to have a binary approach of managed care or no managed care, and look at what we believed was what were the strengths and the weaknesses and areas where we could improve in the delivery of Medicaid services. That proved to be a very, very productive use, I think, of the time and resources of the state and other vendors and vendor partners that we did that work with. If it were to have stayed a binary decision of managed care, no managed care, that change to the state plan amendment, as I said earlier, that would require a change to the state plan amendment, because that would mean that's the difference in how the entire program is run, how everyone is paid, how every provider group is reimbursed and compensated. I mean, that is an enormous change that cannot be done unilaterally. That requires a state plan. Because our current state plan amendment says we are fee for service. This is the way that we do it. If we're going to change it every other way, we need to do that. And that's how other states have done it. If they've moved from fee for service to managed care, they've also had to change their SPA. Not every state requires legislative approval to change their SPA. Some do, most don't. This is the way that our state works. We respect that. And that's the way that the process would continue to work. So even if we got to that point, it would still mean that we would have to come to the legislature.
Just one more question about
Sure.
the confirmation of the Medicaid director
Yeah.
bill from earlier.
Sure.
When obviously when Mr. Woolston
Woolston.
left,
Mhm.
was the position posted? How was that handled
Yeah.
internally?
So it was not posted because we had an internal candidate who met all of the criteria. But I will say, and I very much recognize that we're very public here today, but I will say that there was an enormous amount of vetting done of that particular candidate. He's in the room, Bill Halsey. So there was, yes, so there was and I can, because I knew that the decision was one that held great weight, that it had statewide impact. There was input from a number of advocates. I essentially called just about everybody and said, this is what I'm considering. These are the thoughts. This is the candidate. What do you think? Do you think that this is the right direction? And unanimously, that was the choice. And I would like to say, Senator, that I know that the same degree of care went into choosing Director Woolston as well. So I have an enormous amount of confidence that when we choose the Medicaid director, we do it thoughtfully, we do it with stakeholder engagement. We're very sensitive to the fact that it's a personnel decision. So, having it sort of be widely spread is something that I'm sensitive to, but understanding that that person has a lot to do with what happens in this state. So I take that responsibility seriously. So did my predecessor. And in the end, I do believe that in her choice and my choice that we did make the right decision.
I appreciate that. And certainly none of this is intended to cast any
Of course.
aspersion to Director Halsey or to his staff. what I think the question is, obviously, this is one, I think we are in agreement that this is one of the most important positions in the state. It's a $10 billion partnership with the federal government of
Yes.
enormous impact to every provider in the state, to hundreds of thousands of residents who rely on Medicaid for their health care. It's important to the state's financial security. And certainly this is probably the number one issue in the country right now is the future of the Medicaid program. And so given the, centrality of the role for, so much of what the state does and how we keep our citizens healthy and our providers up and running. That's just why I think there's a lot of interest in the position and in the operation of the Medicaid program, as you know. So I think that expresses our interest, and it's not intended as any kind of, questioning or second guessing of your decision, but more just a reflection of this is a really important thing. So when we do have a transition there, it's there's a lot of interest in your choice in making sure that we get it right, and that we're asking questions on the front end about approaches and how we're going to make sure that we're nimble in responding to stakeholder interests and making sure that we're doing everything we can to make this program sustainable and successful. So look
Understood.
forward to continuing the conversation. That's all I had at the
Okay.
moment, but I do have a lot of questions that I think some colleagues are going to ask about some other parts. So I'll turn it back to
Okay.
Madam Chair.
Thank you, Senator. Representative Vale, followed by Representative Bizzuto.
Thank you. This might take a second, so just a fair warning with your indulgence. I have questions on Senate Bill 1359, Section 2, which the chair has already asked a few questions.
Oh, the
but-
child support orders.
Yeah.
Yes. Okay. Oh, that's why you were waving at the deputy commissioner.
Yeah,
too.
yeah.
Understood. Okay.
Yes, I was trying to be efficient.
Thank you.
And again, I'm not exactly sure to start. So this section, does this exist? What is the current law regarding child support for people incarcerated for over 90 days in Connecticut?
So I just want to I'm going to give you verbatim the piece of the statute that we're looking to take out, which I think answers your question,
Yes.
which is right that a downward modification of an existing support order based solely on a loss of income due to incarceration or institutionalization shall not be granted in the case of a child support obligor who is incarcerated or institutionalized for an offense against the custodial party or the child subject to such support order.
Okay, so currently, if someone's incarcerated for more than 90 days, is that part of our statute now, the 90 days? Or no?
I wish I could answer that question off the
that's
top of my
okay.
head, but I don't have it.
That's okay. So if someone's incarcerated and they're paying child support, and say they're incarcerated for multiple years, under current statute, if the victim was either the child or the custodial parent, that they would still be responsible for the full amount of that child support.
Correct.
And what if they're not the victim, but they're incarcerated for some other reason? Are they responsible for that child support?
My understanding is those can be modified. There is a process for downward modifications for incarceration based on ability to pay, right? Because you're incarcerated, you don't have income to be able to pay the child support order.
And there's a process for that. Who do they
There
go
is.
to for that process currently?
Having been a formal advocate for children, I can tell you exactly how this works. So, because I represented a lot of kids whose parents were incarcerated in a former life. The person who is incarcerated can go back to child support enforcement, and through the child support enforcement process in our courts to the family magistrate, and ask for a reduction, essentially an adjustment to their child support obligation. And they present the reasons, and this is true for everyone. They can present the reasons why that child support adjustment needs to be made. Sometimes, let's just set aside for now, people are incarcerated, but if you've lost your job, or you have a reduction in your hours in your job, or there's some other circumstance, an illness that prevents you from meeting your current child support obligation, you can ask for an adjustment. And incarceration is one of those reasons. You have to show whatever income that you might have, and then the adjustment is based on that income, based on your obligation. There's an entire pages of charts of income. If you make between X and Y, then and you have so many children, then your obligation is X. If you make between another amount, you've got so many other children, then your obligation is Y. And this is all laid out. And it's the guide that the child support magistrates use in order to determine how much should be paid. And so there is a complete mechanism in child support magistrates, among the child support magistrates, that adjusts how child support is paid based on changes in circumstances.
Okay. In a former life, I used to be a correction officer and I actually did a lot of transportation. So I would transport people to those. And sometimes it's not always an easy situation. When someone was incarcerated for 20 years and they got out owing $40,000, that's kind of tough. Maybe there's a way but also it's not the custodial's parents' fault that that person's incarcerated. So it's not an easy thing. So all right, I got more. So, um, so what so currently what the federal government is saying is that we won't be able to use that, if the victim is the parent can you explain that to me a little deeper?
Yeah.
What's the change
What they're saying
specifically?
is that we can't have the current exception that we have in state law that says there cannot be a modification in the scenario where the incarcerated individual is responsible for victimizing the custodial parent or the child. And they said that's not an exception that we're allowed to have as a state. We have to
Okay.
be able to modify court-ordered support even in that scenario.
Okay, so we're taking that part out.
Correct.
Okay.
That's per
That-
our federal.
And that takes away some of my questions. All right. Okay. I had more, but that kind of eliminates a lot of them. This whole thing concerns me a lot. So I don't like it. I do have one quick one on 13, just a comment on 1360. You said you don't support that bill of us, basically would be the legislature picking someone in that position. I have concerns about that because
Okay.
we're the ones that have to, our constituents are going to come to us. So we directly are, that connection between you
Mhm.
and them,
Right.
right? That's our job. So when I like the idea of us having that oversight because we deal directly with them. So I was wondering why you thought that was not in the best interest of the citizens.
Yeah. I, well, so respectfully, it's not, I don't know if I would characterize my objection as not being in the best interest of the citizens, because I think the Medicaid director position is an extraordinarily important one, which is why we spend so much time vetting and asking questions and making very careful deliberations and considerations as to who should fill that role. And that happened with the previous director and it happened with this director as well. It wasn't just a decision that because the person had been there for whatever period of time that they just automatically ascend into the role. That's not the process that we use at all. The biggest challenge I have here is continuity and politicization. So because we have elections, right, and we have governors that change over time, the needs of the constituents often remain the same. So what I believe, to answer your question more directly, is better for our citizens is to have a person that is really fairly insulated from those changes that happen over time and that their focus really is on the people. So regardless of what happens in other parts of our governments, and so we have a new governor, a new lieutenant governor, whatever those offices might be, that the Medicaid director continues to have his or her focus on what's most important to our Medicaid recipients. That can often be a difficult thing to do if that person is appointed, because then their focus can then be divided. Are they then focusing on what the particular agenda might be for whoever's sitting in office, or are they focused on the people who are working in Medicaid? This really is the reason why we have the position as a classified position, so that it does allow for that level of continuity, so that you can have someone like Bill, who has been in the agency for close to 15 years, who's built up all of this subject matter expertise, who can then come and step right into the role and have a more smooth continuation of how the program is run. I do understand the concern of how important this job is, but our agency, along with lots of other agencies, have lots of important people who are doing really critical work that affects many, many people. And not all of those positions come before the legislative body for approval. For example, I have two of my deputy commissioners who are sitting here today, one of which oversees that $10 billion budget. The other one oversees all of the eligibility operations for this agency. They are chosen extremely carefully, and I think every commissioner does that. So to a certain extent, it is not about, I think very much to Senator Lesser's point, I'm not taking it personally. I don't think any commissioner does. I do completely understand that. But there is also a point where the continuity of those services and supports, particularly because the budget is so big, and right now, because we are in such a very difficult time, and we see that it's really critical that that position be really insulated and from that type of political swinging, and really be able to just sit and be protected and just do the work of the people. That's why that position is where it is now, and why it is classified, and why I do have significant concerns about it being subject to appointment.
And I would probably share your concerns. I don't like politics involved, believe it or not, and things that we could make there's a lot of judges I could get appointed that
Understood.
for another time.
Right.
But that's for your reasons are actually the reasons why I kind of support the bill, because certainly when we come up here and we have that, we have directs, again, our boss is the 3.6 million people live in the state of Connecticut.
Right.
And so it's important for us to have that say over that. And certainly a commissioner like yourself, we're going to listen to your input. Absolutely. So it's not like you're going to be excluded from the process. We want to hear all the stakeholders, and obviously being a commissioner, you had one of the biggest stakes. So, but I think ultimately when we're responsible for what the expectation of our constituents are, that we want to have a little bit of oversight over that. Not everybody trusts the bureaucracy either. So there could be
Understood.
people that get in there and kind of, there's some people that just stay in politics forever, move from one agency to another to another.
Right.
Some of that may be because they're qualified, and some of that may be because they know people. That's the reality of it. So this legislative body, I think, should have some say in that. So I appreciate but for the same reasons you state, I actually support the bill, but thank you. I appreciate it.
Thank you. I appreciate that.
And thank you.
Thank you, Representative. Representative Pizzuto, followed by Representative Dathan.
Thank you, Madam Chair. Commissioner, thank you for being here, and Deputy Commissioner Hedler. Mine is just a technical question on SB 1359. And I think it was around the line, if I got my notes right, 298. Do you anticipate any opposition from DDS in moving or including that autism language into DSS language? In other words, if it's approved, would the language prohibit or eliminate DDS from obtaining autism data?
No,
It shouldn't,
it
right?
shouldn't.
Yeah.
No, it would
Yeah,
not.
and that was my concern. I think,
Yes.
so it was simply a technical oversight then, right?
But that's
Yeah.
absolutely right.
Which is weird. It's in the middle of a bill and they leave that out, yeah.
Yes, but that often happens because the primary focus of the bill was to move the services from one agency to another. And sometimes when you're doing that, you can lose sight of all of the technical and administrative nuances that are involved in actually administering the program. And this is one of the really important ones that we see. And we feel very strongly that this needs to be fixed. We need to have every tool at our disposal in order to vet people who are caring for the most vulnerable.
Very good. I know you made so many salient points on the other bills under review. I just thought, let me throw my technical question on it. Appreciate your answer.
that.
Thank you.
Thank you.
Thank you.
Thank you, Representative. Representative Dathan, who is on Zoom.
Okay.
Thank you so much, and apologies, Commissioner, for not being there today. I really appreciate your very thorough testimony as always. I'm going to focus my questions starting with Senate Bill 1358. The thing that kind of got me a little bit concerned was the sort of payment timing, and I wanted to get an understanding from you. What is your average days that you pay our nonprofit providers?
Yeah. It varies by provider. I can get you more specific information. Some of our providers are paid within 30, some are paid within 60 days, some are paid within 120 days. It all depends on the contractual agreement that they have, but this would require us to pay every provider within
Yeah.
30 days of their service, which would be very challenging for us. Yes, but they are often paid within those timeframes that are within their state contract.
So what are the barriers that you're referring to when you say that it's challenging?
Yes, I'm referring to the administrative barriers and the fact that we only have so many people who can pay the hundreds and hundreds of not-for-profit providers that we have. So to pay all of them on a 30-day basis would mean that we would have to have many more staff than we have now and increase capacity in our current payment system in order to be able to do that. The other piece of the bill, though, respectfully, Representative Dathan, is that it calls for payment no later than 30 days after the delivery of services. There are all kinds of services that are delivered by agencies in general. Let's say it's a behavioral health agency. So they have a mission to deliver behavioral health services, but then does services mean 30 days for every individual that's being serviced? Does it mean 30 days for a particular category of services? So that vagueness also makes it very challenging to administer the bill as it's currently drafted. And our providers are paid within the time frame that is within their contract.
Right. You know, I, as an accountant, you know, based on payment of service, receipt of service is kind of difficult because you don't necessarily have an invoice that might summarize and also be good for CMS for matching purposes in certain situations. So I understand kind of that aspect, but I guess I'm more concerned because, you know, when I meet with our nonprofit providers, they're actually having to borrow money and on a line of credit, which they have to pay interest for, in order for them to make their payroll for their staff, that many of whom are making just above minimum wage and really living paycheck to paycheck. So those staff are relying on those payments, and our nonprofits are relying on our payments from the state to make their payroll. And in order for them to make those payments in a timely manner for their employees, they need to borrow money in a lot of instances because a lot of our nonprofits are really don't have a lot of financial runway like, you know, a corporation or other large providers. And so what I'm concerned about, and excuse me, my battery is running low, and apologies. It's costing them money. So I have asked a couple of providers to highlight how much they have paid in interest charges because of some delays. Now, I haven't talked to any nonprofit provider that gets paid in 30 days. I have heard 60 to 120 is sort of the norm. And so that's really what gives me concern. While I do understand that, you know, the receipt of services might be difficult without the valid invoice, I do have a lot of concerns that we're not paying our nonprofits in a good time. So you're going to hear from me in another bill that I'm working on in government oversight, where we are talking about this as well. But I would love if we can manage it in this committee, it would be fantastic, because I do think it is a huge issue. I do want to understand what sort of payment services that are causing issues, if it's needed, like an update in IT services, and I know there's been the consolidation proposed for IT. If that sort of consolidation is going to help our nonprofits to be able to receive money quicker, I think it's interesting. I've belabored this point, and I can tell that I don't want to lose you, but I do feel that this is a significant issue. My next question is on Senate Bill 1122 regarding the performance audits. When I look at the auditors of public accounts, I have seen one audit in January 24 in the last sort of 24 months. I've only seen one performance audit done. And it was done on a program called Community First Choice in the
Yeah.
compliance report. So I'm kind of trying to understand how we have periodic performance audits and our programs. I've only seen the one in the last 2 years. I have not seen any recent audits on protective services for elderly. I have seen the oversight of the assisted living facilities, but I guess I'd like to get an understanding of which programs are subject to performance audits and when they're being done, because I don't see it on the auditors of public accounts. I do understand that, the audit is a laborious process but, surely I haven't seen anywhere even near 4 that are done on an annual basis, for the agency. So I'd really love to get an understanding of that, if you could.
Yeah, so thank you. We do have the report. I've seen it myself from that reviews our protective services for the elderly program. So we can certainly get that to you. That has been done. And then, of course, we have the overarching audit that's done of the agency itself and all of its policies and procedures and the findings that are associated with that. That's done on a semi-annual or annual basis. So we can certainly get that to you as well. I don't have access to the schedule that the APA uses with respect to which programs it audits when. Maybe the state auditor has that, but we don't. What we receive as a state agency is a notice that says we are auditing this. Be prepared. We are coming on this day, and here are all the things that we need. And I would imagine that is the way that you want to conduct an audit. You don't necessarily want to give a lot of runway to let someone know that they're being audited, which I think makes a lot of sense and helps to maintain the integrity of the audit process. So I do apologize. I couldn't give you a lot of insight or feedback as to what that schedule is. I think the auditors might be able to do a better job of providing that information to you.
Okay, I can reach out to them certainly, because the last audit I see on the system is regarding a letter for DDS or DSS is from 2013.
Okay.
And the only audit I've seen in the biennium is the one I highlighted earlier, or on where it says Department of Social Services, the Community First Choice.
Mhm.
And I do see, as I said, the other one, I can double check, but I'd like to try to get an understanding. So I will also reach out to the auditors of public accounts, because I do want to make sure that we have some accountability and oversight, over this, because these are a significant part of our state budget. My last, oh, sorry, go ahead.
I do have our Director of Quality Assurance who oversees our entire audit department here, if you'd like some.
Okay, yeah, it sounds.
John Jakubowski, yes. And he's so thrilled that I brought him to your attention.
I'm not sure. I can't detect if there's sarcasm or not being on Zoom, so.
Oh, I'm good right here. Good morning. My name is John Jakubowski. I'm the Director of Quality Assurance at DSS.
Nice to meet you.
Oh, you too. The performance audits, there is no real schedule that we're privy to. Like our commissioner said, we get a notice that a performance audit is going to be conducted on the department. It's an entrance letter. But right now, they have the ability to perform as many of those performance audits as they deem necessary. I think our concern in the proposed bill was just having a cap on those. It reads as proposed, not less than 2. We're not in direct opposition of the bill, but we would just want a stipulation there of a no more than. And I figured that 4 would be a good number. It's 1 per quarter. It's definitely a greater number that's being conducted on us right now. And it is true that we are underneath a lot of scrutiny from the state auditors already. The commissioner described the multiple audits that we go through. The statewide single audit's done every year. The departmental audit's done every 2 years. We are one of the only state agencies that the state auditors have permanent residents in our building. They never leave. They actually have a spot on the second floor where they sit year round. So there is no schedule to answer the question, but they have the ability to pick and choose what sections of the Medicaid program they'd like to look into in a little more detail. I don't know if
Okay.
that answered your question.
Yeah, because the overall audit for DSS was for the years 2019, 2020, and 21, where there are 27 findings, 18 repeat findings. And so I'm just trying to kind of understand that to make sure that we're in compliance. So I appreciate you answering for this committee on that, and I may come back with some future questions. But thank you for introducing yourself. I do have one last area that I'd love to ask about, and this is probably going to be for Fatmata on House Bill 7023 for Deputy Commissioner Fatmata.
She's making her way out.
Great, thank you. And again, I'm sorry I'm not in the room to be there today. My dog's getting surgery and I had to make sure that she's okay. Hello, thank
I'm
you.
here. Hi, Representative Dayton. Nice to
Nice.
see you.
Nice to see you. I know how hard you all are working on the peer support, and we've had some great conversations over the last couple of years. Really, I wanted to try to understand, right now this reimbursement is only for residential patients rather than community peer support services. Every study that you read from national organizations talk about how peer support services on an outpatient basis can reduce the amount of admittances into residential programs. And I think, what we've seen here is with the current coverage is that it is talking about residential, as I mentioned, but talking about the community health workers. And I know how valuable they are, especially with the, care for kids, substance use disorder, but we don't really talk about sort of the mental health aspect as part of what's currently covered. So I'm trying to get an understanding, what sort of analysis are you doing to kind of think about this and being able to provide those services on a outpatient basis and in a community environment?
Thank you for that question, Representative Dayton. So I do agree that some of the peer supports are limited to the residential services, but we do have quite a bit that are outpatient and also addressing behavioral health services. The Certified Community Behavioral Health Clinic that the commissioner mentioned in her testimony, that's going to be one of the areas where we're going to have community health workers or peers that are going to be working with members who are outpatient. Also, CHNCT, their community health workers also do outpatient with our members, trying to connect members who are unattributed to primary care providers. And I'm sure in those conversations, because they do different outreaches, some of it may be telephone calls, some of it may be actually visiting members, and some of those members may very well have behavioral health issues that may need to be addressed, as well as trying to connect them to primary care. So this is a working study, but I don't believe that the approach we're taking is just going to limit us to those services being provided in the residential care settings.
Yeah, because I guess the concern then is what I got from the commissioners, these were going to be limited to certain locations. And if we can't offer this in all parts of the state, I have a little bit of reason for concern. As I said, I have heard from organizations in my community that there is such a need for this, and it really would be an investment. My last question is, you talk about the phase 2 testing of the test and learn, when is that going to be released?
So we are currently in phase 2. And to your,
Right.
I'm just going to piggyback on what you said earlier. So when the test and learn is completed, that gives us the data that we need to make evidence-based decision in terms of how we scale up community health workers and similar, personnel to the rest of the Medicaid population. So our phase 2 will conclude the end of this year, December 2025. And based on the results, we may be able to scale up or refine. But that's what we're currently waiting for, because that will provide us the evidence that we need.
Okay, so a report will be issued early 26, you're saying?
The end of this year, December.
Right, but the report, when will the legislature receive the report?
Well, we would hope that for the first quarter of 2026.
Okay, so it might be difficult for us to make legislation in 26 with that. On average, what are you paying for a residential bed on a per diem rate for somebody who's getting residential care?
I don't know that I don't know that at the top of my head, but my counterpart, Bill, would you know?
Do you know what we pay on a per diem basis for the peer support services within the residential?
It's included in the per diem rate
Oh,
overall.
okay.
And we do expect that the providers and practices are, hiring and utilizing peer supports for the residents they serve. So I cannot.
Yeah, I have one more question for you that is around, does CMS require any sort of, for the peer support services that are in residential programs, does CMS have any sort of licensure or any sort of requirements in order to get that coverage? I understand it's a bundled rate. But do we need to share with CMS any sort of type of licensure or any sort of requirements for that?
I don't believe that there's any specific requirement within CMS, Representative Dathan.
Okay.
It is just part of the bundled rate or the per diem rate, and we determine and look at what processes or what criteria we want to ensure that the providers meet to hire peer supports.
Yeah, I would love, I mean, you don't have to provide it today, but I'd love to understand what the per diem rate is for residential services. And then I know my concern is for like unattributed members that aren't part of PCMH Plus that are trying to get these community services. It seems like there is definitely a gap there from what I'm reading in the commissioner's testimony. Is that what if you have an unattributed person who's trying to get services, how can they do that under Medicaid currently that are not in residential?
So the unattributed members, that's the test and learn that's going on. CHN is working. Those community health workers that I just mentioned, they are working on that population to ensure connection to primary care as well as behavioral health. So that's one of the ways that we're addressing unattribution within Medicaid.
Okay. And that study will have the amounts that the cost per diem or part if it'll be a fee for service then as part of that report what we get next year. Is that right?
This is under the administrative work. So it's part of that what we pay our medical ASO CHN. So I'm not sure that it's going to be passed out in terms of fee for service payments.
Okay, well, I'm looking forward to seeing that and I really appreciate it. I'm sorry I took so much time, Madam Chair. But these are super important to me, all of these bills. So thanks so much. And thank you, DSS, for your testimony.
Thank you.
No worries at all. That's the point of a public hearing. Thank you, Representative. Representative Johnson.
Thank you so much, Madam Chair, and thank you so much for your testimony and all your work. Going on to House Bill 7026, the hospital where you're giving a break in terms of the limitation on nursing home beds.
Yes.
the act concerning exemptions to the nursing home bed moratorium. To be
Yes.
more specific. Um, I have a couple of questions. First of all, how did this come to be in terms of your look at this and in your discussion and your testimony? Have there been a number of people being discharged, say, from hospitals who have had to wait a very long time to try and find a Medicare certified bed?
Not in my recollection, but the challenge that we're facing now is that we have a number of nursing homes that have closed, right, over a fairly short period of time for a variety of reasons. And that is really the primary driver that we're seeing. We want to be proactive in being able to have that moratorium lifted in a very thoughtful way, particularly geographically, where we know we've had to close homes for, as I said, some of those reasons have been very public as to why those homes have had to close. We had one, as you know, very large provider in the state that's closed a number of homes over a very short period of time. Where there is a dearth of homes of beds, I should say, that aren't available, we would like to be able to, again, in a very thoughtful way, on an as-needed basis, to be able to say, this particular geographic area needs 50 beds. And here's why. It may be because we have a number of hospital discharges. It may be because our statistics and our data that we use are telling us that in the next year and a half, we're going to have so many people who are going to need those beds. That's a lot of the work that Nicole Godburn, who you've heard from earlier, and her staff do. Along with one of our vendor partners, we actually keep track of the number of people who are aging year over year and the number of nursing home beds we think they'll need based on the acuity of their need. And we are at a tipping point right now because we had a number of homes closed that were not necessarily part of our longer term plan, which is why we necessarily think that this legislation is appropriate at this point in time.
Very good. And so when you look at the catchment area, which is approximately 15 miles surrounding, say, a hospital,
Correct.
when we're looking at that, is that regulation going to be changed? Is that something that at one point in time, the reason that the catchment area was a good thing was because family members could come and visit. They'd be able to create a situation for the person who was in the skilled nursing facility, an opportunity to, have that little bit of a charge so that they want to get out, get home, that kind of
That's right.
thing. And so if the catchment area is expanded, it may have a problem in terms of a lot of the hospitals are in urban areas, and maybe a lot of the family members are in those areas too. Just wondering if there had been any thought about the 15-mile catchment area.
So this legislation would not necessarily change the 15-mile catchment area. It's really designed for us to look at that 15-mile catchment area to see which homes might remain available and how many beds there are. I keep saying homes, but I mean beds, the number of beds that are available within that catchment area. And if there are too few based on the population need, then this would allow us to lift that moratorium and create more capacity, whether it's within a 2-mile, 5-mile, 15-mile radius. Right now, as things stand, we don't have the capacity to do that. And we've heard feedback about the 15-mile radius, particularly since we've had to close a number of homes in a very short period of time. The preference always is to have homes as close to family and community as possible. It's not always feasible. But one of the ways that we can counter people going 15, 20, 30, more than 50 miles away, 20, 30, is to create more capacity where it's possible in the towns and cities where they are. And lifting the moratorium on an as-needed basis allows us to do that.
And so just to follow up in terms of the long-term care discharge plan, according to the Medicare and Medicaid certification for coverage, there has to be, the plan through the hospital discharge summary, and then that would be followed through. One of the problems I've seen in my district and gotten calls in other areas is the fact that access to, say, the idea of the rebalancing where home care services are supposed to be available, they actually are not available. And the other problem that we run into is the networking in terms of if there's a Medicare Advantage plan where there's not a real good network for the discharge plan for the person safe with physical therapy, that particular network didn't have the, capacity to provide the physical therapy in a home setting, then really the only thing would be to go into a skilled nursing facility, particularly, and that would be a Medicare covered thing. And I'm just wondering if we taken the chance and looked at balancing the cost when somebody is maybe returned back to the hospital, those kinds of things like the observation status, because the hospital doesn't want to admit them again, because if they have someone go back within a certain amount of time from the first hospitalization to the home care situation that didn't work out, which caused the rehospitalization, now maybe the person's on observation status. And I had some legislation passed a few years back on observation status and the reportage of that. And I'm just wondering if that's the case and the person really needs a nursing facility, is that something that we're looking at in terms of balancing when people go back and forth between the hospital, not having access, and looking at how the Medicare Advantage plan isn't actually coming through with what they were required by federal law to do?
Yeah, so it's one of the factors that we are considering. Absolutely. And we do hear more than anecdotally, particularly depending on where you are geographically within the state, that the discharge planning is done very well, but the reality of where the services are actually available, right, and where the beds are that a person can go to, that's a very different thing. And that is the reason why over time we've seen this, and it's been a very short period of time, maybe, a year, where there's a more acute nature of that happening. So people are going further outside of their catchment areas so that they're not in the hospital on observation for long periods of time, which is so deleterious in so many ways that I know you and I and other people who do the work of supporting people understand. And that affects families and that affects health. So one of the ways that we thought within the tools that we have available to us to address that is to lift the moratorium so that so where there can be capacity to create more beds so that people don't have to be on observation status for long periods of time, longer than they should be. They don't have to remain in hospitals longer than they should. People can return somewhat close to their community. This would allow us to do all of those things. So everything that you discuss is this would be a book if we were to put in every single reason, why we think every piece of legislation makes sense. But those really, what you spoke of is one of the primary factors that we've considered, on top of the fact that our skilled nursing facility landscape has changed so quickly in a very short period of time.
Thank you for that. And then finally, I'm looking at the proposal for the greenhouse nursing facilities,
Yeah.
the little ones.
Yes.
So I've got a two-part question for this. First of all, what is the standard for creating a Medicare Medicaid certification for such a facility?
I don't know if I can answer that. I can see if Nicole might be able to, and here she comes.
Okay.
Thank you.
7026.
Good afternoon. So the process to be certified for Medicare and Medicaid, it's a dual, as you know, a dual license. So when someone is opening a nursing home or taking over ownership of the nursing home, they must go to Medicare, fill out the paperwork essentially, and apply for their certification, go through the entire background check. You cannot become certified in Medicaid for a nursing home unless you're also certified in Medicare. They must go hand in hand. So someone must first go to CMS, be approved under Medicare, then come to us and then go through the process of being duly certified under Medicaid. And so when it comes to opening a new nursing home, back to the moratorium or expanding beds or something along those lines, that person will have to still go through the entire process.
Excellent. So I just wanted to make sure that, and this is done through the public health department.
So there's the federal there's the federal component under Medicare. So that's the
Right.
federal piece. And then when it comes to someone new coming into the system in Connecticut for Medicaid, correct, there's the dual agencies. Us and DPH work very closely together because a new nursing home owner will have to go to DPH, go through the background process, be approved to be an owner, to have the licensure, et cetera, and then also come to us and be approved for Medicaid. And that requires fingerprinting, background checks, etc. So we work very closely with DPH when someone new is coming into the system to make sure that they check all the boxes.
What would be the advantage of having a smaller facility?
There's a lot of good evidence out there that smaller, they call them kind of community, small home style, nursing homes. There's a lot of good evidence that it creates better outcomes for the resident. When you're creating a community, that person is just much more engaged. I mean, just think of it where you'd like to be yourself. The image of a nursing home, of more of an institutional type setting, that's not somewhere that I would wish to be, but being in a community style, and the physical layout of these types of buildings is designed to invite engagement between you and other residents, to allow staff to have better lines of sight to folks, and so they can have better. You're just not putting someone into a room and then forgetting about them. You're having that person being engaged in the community. And the concept behind those homes is everything from the physical plant layout to even the programs that are given to residents who live in these buildings. The programs must be designed to engage the person and give that person full quality of life.
Have you found this to be something that other states are doing?
This concept is very popular in other countries. It's starting to catch on in our country. Many states are supporting it in various ways, and they're expensive to build. So often it's the money and the financing around them that is the hindrance, but it is something that I think, as generations are aging and looking towards nursing home care for their loved ones, being in that old style of institutionalization is just not somewhere where folks want to be. It's really about consumer preference. So states are very much paying attention to this and how they can best support the industry in changing.
So one of the things that I know I've asked before in some of the different meetings we've had to do with the fact that rest homes seem to have a lot of what you're talking about. They just don't have they just don't meet the certification requirements for being able to provide the physical therapy and all the different types of therapy, the 24/7 nursing care that is provided in a skilled nursing facility versus a rest home. So hence the different certifications. So a couple of things. One is, as was mentioned just now, numerous nursing facilities are closed. And so a lot of people in the housing committee are looking to create housing there. And I'm wondering, some of these closed nursing facilities, and this is a twofer question, some of the nursing facilities might want to create, redo how they are. It might be less expensive, plus you've already got the place there. And then the second part of the question has to do with the fact that there could be more than one certification. So one part of the nursing facility, and this isn't new. I mean, this is like Masonic Homes does this. They have certain areas that are set up like for housing. Then they go to the rest home style. Then they go from that to the skilled nursing facility / nursing facility certification. And so they have a transitional thing. And I'm wondering, have we thought about trying to redo that sort of thing?
We have. So I'll answer the first part of the question. We certainly have, and it's a natural thing. You see the buildings are vacant because the home has closed in the way in which it currently operates. It's a bit more complex though, because many of these properties have HUD loans on them, and they have restrictions in the manner in which the property can be used, and it can only be used for more institutionalized nursing home settings. So you either have to get a special dispensation from HUD to forgive that loan, or to change the purpose under which the loan is used in order for you to change the purpose for which the property is used. That is not always a very easy thing to do. HUD is I would say very focused on the way in which that property had originally been used, and you really do have to have a super compelling reason to change it. And so in exploring that with a number of the homes that have already been closed, that's been the challenge. Some of the other challenges are when the homes are privately owned, sometimes the property itself is owned, but the land is leased. right? So that's part of the challenge that we face as well. So even if we wanted to convert the property, we're now dealing with two owners, right? The person who owns the property and the person who owns the building and the person that owns the land. And sometimes the land lease does not run concurrent with the ownership of the lease. You can tell I've spent a lot of time with this, right? So this
Excellent work.
process works, right? And so that's why it's been more challenging to convert those homes into housing than you would think, because they're there. You see that the opportunity is there. That doesn't mean, and I have to give an enormous amount of credit to our housing commissioner, Commissioner Bruno Mascaro, who really has taken a lot of time to explore where that possibility exists. I think she's had some success with one or two. The others she's continuing to explore, but those are the challenges that we've faced so far in converting those properties.
Thank you so much for that. That is really interesting, and it's great to hear all the work that's being done in this area, because as you know, and as probably most everyone in the room here knows, we're having an increase in seniors not having a place to go, especially after a discharge from the hospital or a nursing facility. So there's no place for them to go.
Right.
And if there are, I know that there's been complaints over the year about nursing facility, how many empty beds do we have? And I'll ask this again, but what about the swing bed? So they do a swing bed situation, or they used to have swing beds in more rural areas where they can swing from hospital certification to, say, skilled nursing facility certification, and then maybe go from that to rest home certification. And is there a way for us to do, there's nothing in federal law that we can
No, federally it's prohibited. Because the level of care in a residential care home and the level of care required in a nursing home are very different. They're very, very different populations, similar in many ways, but also very different populations. So the licensure must be separate. But that's not to say, to your point, though, that we don't have in Connecticut, because we do have many examples of where both licenses can live on the same campus. So we have many cases where, for example, there's a residential care home that provides services to that particular population. And then as that population ages, they can age in place on their campus and then shift over to the nursing home as they need it. Leeway, gear, we have several examples of that here in Connecticut where that's possible. But they must be distinct, and that's a federal requirement. Both those locations, even if on the same campus, must be distinct and separate from each other. And we work very closely with the ombudsman in identifying those possibilities and trying to expand that capacity. I know the ombudsman is very much in support of that concept, and we work very closely with her on that. But again, we have to adhere to the federal requirements that they must also be distinct, even if on the same campus.
Great. And then finally, just a thought in terms of listening to a discussion about the HUD liens on the property, and also on the Senate Bill 1350 with respect to the debt that might be owed by somebody who is incarcerated, but yet has a court order to provide, the childcare costs. Is there opportunity for discharge in bankruptcy?
Of the child support
Or
obligation?
both the HUD liens, and also if there was a way for some of these things to be addressed through bankruptcy?
So
Especially because we have such a housing need, and
yes,
get it through the
yes.
bankruptcy court, and it is a federal question, so maybe I'm out of step
It
here.
is, and
So-
I'll answer it as best I can, but I'm not a bankruptcy attorney, so I can only just
Me either.
tell you anecdotally that I think unless the private entity, our experience has been that unless the private entity is actually filing for bankruptcy, then it's eligible to be on the list of creditors. I don't know whether a HUD loan is eligible for discharge. I would imagine that HUD, and we know this, would probably be at the top of the list of creditors, right? And they may be asked to compromise how much they're owed or paid. But I don't know for sure whether or not it could be discharged. With respect to the child support obligation, I'm not sure whether that can be discharged in bankruptcy either. Usually under back child support that's owed, people can enter into payment plans that can be approved by the court to catch up on their child support. It's really discouraged to try to discharge that obligation altogether because of the nature of how the money is used and spent.
Agreed. And I just thought, if somebody's incarcerated for 40 years, the opportunity to be able to even come back with a small amount, unless there's some way for the person to earn money while incarcerated. That might be
Yeah,
enough reason.
well, the opportunity to earn is so limited in
Yes.
incarceration, and then the amount paid is so small that it's really hard to amass anything that would come close to meeting anybody's financial obligations under child support.
Mhm. Well, that might be a thought. Anyway, thank
Absolutely.
you so much, Commissioner.
Thank you.
Thank you, Madam Chair.
Thank you, Representative. Thank you, Commissioner, and thank you to your team. That appears to be all the questions we have for today. So thank you so much. Have a wonderful afternoon. We have gone past our first hour, so we will now begin to go between the public and state officials. And so next, I'd like to call up Jennifer Chadu-Hewitz. Hopefully I got that. Followed by Commissioner Amy Porter. You just have to push the button and the red light. There you go.
Yes, there we are. Thank you so much, Madam Chair and members of the committee. My name is Jennifer Chudukowicz. I am a citizen of Cromwell. I want to say goodbye to my friend Bill Halsey back there. I'm not testifying on 7023 today, which is a shocker. My name is Jennifer Chudukowicz. I'm a citizen of Cromwell. I'm the Chief Strategy Officer of the Southeastern Council on Alcoholism and Drug Dependence, known to most of you as SCAD. For 58 years, SCAD has provided a full continuum of care for substance use disorder withdrawal management in New London. Through residential programs, detox in New London, Norwich, and Lebanon. We also offer outpatient services, IOP, primary care, hepatitis C, high Senator Lesser, MAT services at every level of care, and we also have recovery housing. We are a DEMAS-funded agency licensed by the Department of Public Health and funded through payments via DSS Medicaid. We have 213 employees living in Southeastern Connecticut, and we serve about 5,000 Connecticut citizens a year. The most important hat I wear here today is that of a woman in long-term recovery. I'm in my 36th year of recovery, and that is due to attending a long-term treatment program, residential, just like SCAD's Lebanon Pines program. So treatment does work and recovery is possible. Thank you for the opportunity to testify in support of Senate Bill 1358 with a little tweak, an act concerning equitable compensation for the state contracted nonprofit human services providers. SCAD requests that you include substitute language that would index the nonprofit funding to inflation. With that language, this bill would help our community at SCAD, my friends at Reliance Health here today, and provide additional services to the state's most vulnerable populations. SCAD is grateful for the increases the legislature has been able to provide through a variety of sources over the last few years, but they haven't been enough to meet the needs of the people that we serve. As one of the largest DEMAS-funded providers of residential substance use treatment in the state, we have faced exorbitant increased cost related to technology necessary for compliance with clinical documentation for state and federal funders, CMMS. We are burdened with the cost to aggressively secure our organization's data from bad actors every single day. Behavioral health staff who are hard to acquire and quick to turn over due to the shortage of behavioral health professionals, which somebody else spoke to. The cost of living increases we experience in a primarily residential program are the same that all of you experience in your own pocketbook at home. Food, medical supplies, bedding, cleaning supplies, laundry detergent, fuel, snow removal, maintenance and repairs of 9 program locations with 22 buildings. The list could go on. Substance use disorder impacts 1 in 4 people. We care for your fathers and mothers, children, grandchildren, employees, neighbors, and loved ones. And I'm sorry I'm getting emotional, but I'm very passionate about this. These are individuals who are trying to save their lives. Let us remain the experts on treating substance use disorder, caring for your family and loved ones and the good citizens of Connecticut. If the budget for nonprofits is updated, indexed to the cost of living increases, and passed, our agency could hire the necessary workforce to maximize our revenue opportunities. And I can explain that further if you want. Eliminate burnout, provide competitive wages and benefits for our 213 employees in Southeastern Connecticut, and repair and maintain our 22 buildings in a sustainable way. I urge this committee to support Senate Bill 1358, an act concerning equitable compensation for state contracted nonprofit human service providers with the requested substitute language the Nonprofit Alliance has provided. Thank you for your time and consideration, and I'm glad to answer any questions.
Thank you, Jennifer. We are so fortunate to have people who are as passionate as you doing the jobs you're doing. Representative Santiago.
Thank you, Madam Chair. Thank you, Ms. Jennifer, for being here today
My pleasure.
and talking about your program. There's a couple of things.
Mhm.
In order to get into the program, there's criteria, right?
That is correct.
So you can either do it on a volunteer basis or you can be court ordered.
Well, so I want to answer that question very carefully. We do have a contract with the Court Support Services Division, CSSD is the acronym for that. And yes, we do have a contract. So some of our individuals, I believe it's 10 beds at our Lebanon Pines facility. That's a 98 bed facility. So 10 of those beds are a CSSD contract, correct?
Okay, and then the reason I'm asking is because I know by personal experience, someone in my family that went to that program, and you
Okay.
guys did a great job.
Thank you. That is so good to hear. How are they doing?
They're doing really good.
I'm very
I think
glad
it's
to
going
hear
on
that.
8 months now, recovery.
Yes. That's
So,
awesome. That's great.
the only concern that I have is, and what she expressed was
Mhm.
that there aren't enough beds, I think, for women.
That is
So I
correct.
think that's something that eventually I want to work with you on that.
I would be glad to. In fact, we have some ideas that we're working on right now, so I'll reach out to you and get your input on those because there aren't. In fact, if I could give you a little information.
Yes,
So
go ahead.
we have a level of care called withdrawal management. It's been called detox for years, but we don't like to say detox
Mhm.
because some people are doing medication assisted treatment and that's not necessarily detox. So withdrawal management level of care, women come into that care. Theoretically, the next level of care would be a long-term residential program for those women. We don't have that level of care in our continuum. So women have to leave the SCAD continuum, go, I want to exaggerate and say halfway across the state, away from their family and children, and they don't do it. So they go home. The next level of care, that we have is a low intensity residential treatment program for women. And it's not always the proper care that they need. So we lose them. We would love to be able to provide that level of care. But I want to be very, very frank, especially as a woman in long-term recovery. Women that need recovery and want recovery, but have young children at home are loath to let their children go into the foster care system while they go get treatment. They will not do it. They will go through the cycle of, maybe falling off their recovery pathway and ending up back in a position where they need a medically managed withdrawal process and leave the kids with mom and dad for a few days, but that's not sustainable. There are models, and the state of Connecticut was the first state in the country to have this model of a women and children's program. I worked there. I opened the program for the Connection. I was an employee there in 1989, and it was wonderful. But that funding structure where it's DCF funding and DMIS funding and DCF licensing and DMIS licensing and DSS licensing, believe it or not, it wasn't enough money. Foster parents get more money than that model receives for children's care in that program. I hope I answered the question.
No, you have, but I just think that, again, we need to work on women's recovery beds and getting more funding for that, because a lot of the funding is going for more men.
It is.
For recovery.
Yep.
And programs like that are more important, especially when you have children, that you don't want to leave your kids behind. So, just, keep up the good work and
Thank you.
Please, let's connect afterwards.
I will absolutely do
And then
that.
we can work on looking at some funding and some other programs that we can work together to make it a better program, especially for women.
I
Thank you.
appreciate that so much. Thank you.
For being here.
My pleasure.
Thank you. Thank you, Representative Santiago, and please keep me posted on those efforts. Myself and others are interested in that as well, so we'd love to all partner. Representative Dathan, please go right ahead. She's on Zoom.
Thank you very much, Madam Chair, and thank you for your testimony today. I think you highlighted some really important points that we need to continue to look at as a committee, and I commend Representative Santiago for really wanting to dig in. One of my questions really was about the payment terms, and it was something I talked about with the commissioner. And as I've said, I've heard from agencies, in terms of when you get payments from DSS for reimbursement, what is the sort of time frame? Do you know? And is it kind of in line with what your contractual agreements are?
Representative Dathan, thank you so much for the question. I would love to answer that question for you. In fact, when I heard the commissioner giving her responses to you, I was texting my office to try and get that information because I wanted to be prepared to share it. I don't know what our contractual terms are. I do know that when I spoke to our finance office a couple of weeks ago, I was testifying in front of the government committee that we are, with the exception of one contract, on time for our payments. But then I will also say that we do have a line of credit to carry our payroll for our 213 employees so that we can fill in the gaps on those payment terms that maybe aren't as expedient as what we would anticipate needing.
Do you have any indication about how much in interest your organization incurs as a result of these payment terms that are, long? I understand they're contractual and, their DSS is paying you within those contractual obligations, but I guess my more concern is your organization doesn't have a huge amount of cash sitting around. And like you said, you have to fund payroll for over 200 employees, and you're having to pay to make sure that you can deliver services, but not getting payments in a good, timely manner, which is costing you all money. Do you have any indication of that?
I don't, but I did write the question down during the commissioner's testimony because I wanted to get that information to you. So
okay, that would
I did.
be
Yep.
awesome.
I'll email that to you. And
Actually, just send it to Brianna Clifton, who is the administrator clerk on this committee, and she can share it with everyone. But thank you for what you're doing. And I do hear so often how many women of all ages are really suffering through substance use disorders, and the lack of services, I think at every level we're seeing is a big problem. So thank you for your advocacy, and thank you, Madam Chair.
Thank you, Representative. I don't see any other questions. Thank you so much for being here today.
My pleasure. Thank you.
Have a great afternoon.
You too.
Next, we'll hear from Commissioner Porter, followed by Patricia Donovan.
Good afternoon. Good afternoon, Representative Gilchrist and distinguished members of the Human Services Committee. My name is Amy Porter, and I'm the Commissioner for the Department of Aging and Disability Services. Within the context of our educational services, I'm here to offer our strong support of House Bill 7025, an act concerning updating the staffing methodology for teachers of visually impaired children. To begin, I want to thank the committee for raising this bill, which is our agency's only legislative proposal this year, and the only bill I'm going to be talking about this afternoon, unless you have other questions. But as a bit of background, Connecticut's local school districts with enrolled students who are blind or who have visual impairments typically have three options for providing an accessible education for those students: either hiring their own certified teachers of the visually impaired, or TVIs, outplacing students in a a private provider facility, or requesting TVI services from ADS through our Bureau of Education and Services for the Blind. In this current school year, our Children's Services unit of 30 incredible TVIs are providing services to 757 students, and we have another 24 who have been recently referred and are awaiting intake. Additionally, there are some individuals who are served, as I said, by the schools themselves, so we do provide some consultation services there. The process we have right now for assigning caseloads and adjusting those caseloads to balance the diverse and evolving student needs and with our staff capacity is very labor intensive, and it's something that requires us to look at it through the year. This bill would eliminate reference to an outdated statutory formula that only considers whether or not the student is a Braille learner. Since Braille learners only make up about 10% of the students that we work with, we're seeking to modernize the approach. Our new replacement language aligns with our current practice. It has us looking at the instruction levels that are established in either the student's individual education plan, their IEP, or their 504 service plan. It looks at geographical location and other management factors so that we can identify the right number of teachers needed to serve the school districts. We think that considering multiple factors rather than just the Braille learning piece that are relevant to the unique needs of students who are blind or have visual impairments, looking at those plans, it allows us for a more realistic determination of teacher workload, allows us to more efficiently utilize teacher capacity to effectively serve as many students as we can within the resources that we have. So in closing, again, we appreciate the committee raising this bill in support of Connecticut students with visual impairments, and we hope for your continued support should the bill move forward. And as always, happy to answer any questions you may have.
Okay, thank you so much. I see a question, Representative Butler, go right ahead.
Thank you, Madam Chair, and thank you, Commissioner, for being here and sharing this. Of course, we want to do everything we can to actually help the visually impaired children. And you spoke of the formula being revised would help for you to assess the amount of new staff you need on board to address the students in the state. Do you have any, baseline idea of what that would take to address what's out there if we change the formula?
Yeah, thank you for the question. So what we've been finding in using this formula, we've had a fairly consistent level of students who need our services. We've had a fairly consistent level of teachers, but the teachers are feeling more and more overwhelmed. And we're finding that that's because they're dealing with students who have more complexity. They might have multiple impairments aside from the visual impairment. They might be experiencing, like all of our students, some of the impacts of COVID. So there's a lot of factors that they're also dealing with. So it's a great question, and it's why we want to move away from the formula of only looking at points for Braille learners and then points for non-Braille learners, because we think that we really need to be able to look at all of these factors to effectively answer your questions, and also to make sure that we have the right mix of teachers. Right now, it would look like we didn't need any more, but we know that the way that our student population is changing, that there's just a more diverse set of needs that we want to be able to account for.
Yes, and I certainly agree with your assessment. I just wanted to get to, estimate, if you will, of what you think we need to staff up to be able to address these students out there. Because, I'll totally agree with you if you say that only 10% of the students out there have this Braille designation. That's that's woefully inadequate in terms of servicing this community. So do you have a ballpark figure of what we may need going forward?
I don't, because this has been the formula that we've been using, and we want to be able to move away from this and look at what those, how to incorporate those factors, how other states might use it, and then allow our our unit supervisors, our supervisor for that program, and our director at BESB have really been working hard to make sure they can distribute the caseloads appropriately. But I think we want to be able to have the data to answer the questions that you have. And because we haven't been required to do that, we don't have that set of data yet. So we will be collecting that. We have been collecting it over the last year in preparation for this, but we don't have those answers at this time.
Thank you. Thank you for your answer. It sounds like something we need to do urgently. Thank you, Madam Chair, for allowing me my questions.
You're so welcome. Thank you, Representative. I don't see any other questions. Thank you so much for your testimony. Next, we will hear from Patricia Donovan on Zoom, followed by Daniel Beam, our long-term care ombudsman manager. Go right ahead, Patricia.
Good afternoon, Madam Chair and esteemed members of the Human Services Committee. My name is Patricia Donovan, and I'm here today as a food allergy advocate in support of HB 7024, an act concerning Medicaid coverage for allergy prevention. The two most important words in that title, and something we families have all been dreaming of, is allergy prevention. I am testifying today with the experience of having raised children with multiple life-threatening food allergies. My two younger children, now young adults at 21 and 23 years old, developed allergies almost from birth. We were instructed by our doctors to strictly avoid their allergens: peanut, tree nuts, eggs, and dairy. And as if that was not enough, my children also presented with acute eczema and later developed asthma. This is commonly referred to as the allergic or atopic march in allergy world. Managing my children's health for the last 20 years has been a full-time profession, and its impact has been keenly felt by the entire family. Food allergies impact everyone and everything you do, from what you eat in your house to whether you can participate in extended family events, how you travel, or if you dare to travel, if your kids are invited to birthday parties and how they can safely participate, to trying to attend summer camp and whether you can go back to work full-time. Our lives revolved around keeping our children safe and healthy and educating everyone around us about food allergies. Additionally, I have been testifying before the Connecticut legislature for the last 10 years, advocating for policies that support families and children with food allergies in schools, in restaurants, on school buses, and increasing access to medications. The fact that we are here now talking about an early introduction allergy prevention bill and making it accessible to our most vulnerable populations, those dependent on Medicaid, is truly amazing. It's a paradigm shift. My story is not unique, though. As food allergy prevalence among children has been increasing for decades, it's truly a silent epidemic. Food allergies increased by 50% between 1997 and 2011, and again by 50% between 2007 and 2021. What we often forget is that these children grow up into adults like mine have, so food allergy among adults has also risen. Today, 33 million Americans have food allergies. That is 1 in 10 adults and 1 in 13 children, or 2 per classroom. Children with food allergies are also more likely to develop asthma. What if this early intervention also positively impacted our asthma rates in Connecticut? As written, this bill has great potential, but it still needs fleshing out. I asked the committee to include definitions so that we know how this bill will be implemented, and to include the most important piece, language on education. This bill would be so much stronger if it included language that asks the Connecticut Department of Public Health to help coordinate an educational one-pager for families and doctors on how to safely introduce allergens into their babies' diets, and to ensure it reaches those healthcare providers and clinics who serve Medicaid-dependent patients, and frankly, all healthcare providers. I believe several of the doctors in support of this bill have stated that they are vested in helping create this educational piece. I am happy to support a bill that could potentially reverse this childhood epidemic and ease the burden on children and families. And I ask that you support early introduction with amendments and add an educational piece to this bill. Thank you very much.
Thank you so much, Patricia. This is a very helpful testimony, and I'll be sure to go back and see what you've submitted for the recommendation. Representative Comey.
Hi, Tricia. It's great to see you. Thank you so much for coming out. Missing you here in person, though, but glad that you were able to join by Zoom. We have been working on this bill for a little bit and talking about what it might look like as far as implementation, right? Because that's where the sort of rubber meets the road, as they say. I appreciate the fact that you brought up about the education piece. And I'm wondering how, in your experience, the health department, I'm wondering if you can expand on the role, the guidance that maybe the health department could give. I guess we were talking about pediatricians
Right.
to manage this, and you could expand on that. Thank you.
Sure. Well, I thank you very much for asking that question. You know that I have been trying to activate the Department of Public Health on food allergies for many, many years. We tried to introduce a task force to study food allergies and anaphylaxis in the state, but it never went anywhere. If you actually look at the Connecticut Department of Public Health list index of disease and things like that, there is absolutely nothing on food allergy, yet it affects 6 to 8% of our child population, almost as many as children have asthma. And many times food allergy and asthma is a comorbid condition. So the fact that we're not talking about food allergies in the state, that we're not putting educational pieces out there is extremely unfortunate. And with the new dietary guidelines, they came out, I think, in 2021 on early introduction. I think it's really valuable for the Department of Public Health to put out educational pieces that are available to all healthcare providers so that the healthcare providers who are so busy have the confidence to counsel their patients and then give something to the patients that they can take home so that they can actually implement it in their homes safely.
Yes, thank you. I agree. I think, there are less and less large organizations or even grassroots organizations that are providing information for families. And I think that there's definitely a gap there.
Mm-hmm.
As you know, my child also has food allergies and asthma as well. I was wondering if you would be able to talk about the economic impact of food allergies on families, particularly as your experience, and
Sure.
maybe educational systems as well, because you work a lot as an advocate in schools.
I do. Thank you. So the economic impact is huge, and it has takes many different avenues. For instance, I was not able to go back to work when I had my children with food allergies 20 years ago because there was no way I could leave them in the care of someone. No one knew much about food allergies. And when you were diagnosed 20 years ago, you were given an EpiPen and a flyer and told good luck and sent out the door and said, just don't eat these foods, when there is so much involved. We spent a ton of time at our doctor's office, not just the pediatrician's office, but the allergist's office. There were hospitalizations, ambulance rides. I had a high deductible insurance policy, so the epinephrine cost us many years ago $685 per 2-pack. I have 2 children who needed 4 EpiPens each. That came out to almost $3,000 a year just for EpiPens. And then we had asthma medications on top of that, which usually ran around $200 a month. And when they were babies, we had hydrolyzed protein for their dairy allergies, which many people know that specialized baby formula is very expensive. So our costs for special foods and doctors and medications was huge. And it made a huge impact that I couldn't go back to work as well.
Yes, thank you. Those excellent points. Thank you so much for coming out today and being an advocate for this important bill. Thank you, Madam Chair.
Robin, can I address the commissioner's question about supplementation or dietary supplements? I know she has reservations about using dietary supplements, what we call dietary supplements, which would be perhaps peanut powders or egg powders. There's no reason why that has to be mutually exclusive with whole foods. Whole foods are always best, but supplements, dietary supplements could be an option for families who are pressed for time, who want something that's non-perishable. Powders last a lot longer. So it would be an option for families to use. It might make it easier and give them more confidence in dosing. And so that's just something to think about, that it's not exclusive. It's an option for families to make it easier for them to stay the course. Of course, the early introduction feeding time is between 4 to 6 months and 1 year. So it's short term.
That's right. Thank you. Excellent.
Wonderful. Thank you. I don't see any other questions. Thank you so much for your testimony and your time today. Next, we will hear from Daniel Beam, followed by Robin Sharp.
Good afternoon. Representative Gilchrist, Senator Lesser, Representative Case, Senator Harding, and distinguished members of the Human Services Committee. My name is Daniel Beam, and I'm the Community Ombudsman Program Manager here on behalf of Mairead Painter, the State Long-Term Care Ombudsman, and thank you for the opportunity to testify today. The Long-Term Care Ombudsman Program is mandated by the Older Americans Act and the Connecticut General Statutes to provide services to protect the health, safety, welfare, and rights of residents in long-term care facilities. And on behalf of the State Long-Term Care Ombudsman, it's our responsibility to facilitate public comment and represent the interests of residents to recommend changes to laws, regulations, policies, and actions which fit the residents' quality of life and quality of care. So on behalf of the 30,000 residents in Connecticut's skilled nursing facilities, residential care homes, and managed residential communities, as well as individuals in the community receiving home and community-based long-term services and supports, I'd like to testify regarding my support of House Bill 7026. While we support the provisions allowing non-traditional, small, home-style nursing homes to be developed in areas of identified need as outlined in the right-sized strategic plan, we strongly believe that any facility seeking to expand or relocate under this exception must meet stringent quality and regulatory benchmarks to ensure that only high-performing providers are approved. Expansion should not be granted to owners or operators that fail to demonstrate consistent quality care, regulatory compliance, and strong resident satisfaction. So in order to uphold these standards, we urge the committee to require that any owner or operator seeking to add or relocate beds under this legislation first meet specific performance criteria, such that the owner and operator should have a minimum of 3-star rating for the CMS or Centers for Medicare and Medicaid Services Nursing Home Compare System, ensuring that the demonstration shows the acceptable level of care and oversight at the federal level. Additionally, any organization applying for expansion must be in good standing with the Department of Public Health, meaning none of their own facilities have received an immediate jeopardy level deficiency within the last year. This requirement ensures that providers with a history of serious violations cannot expand while still struggling to meet the fundamental safety requirements of their current residents. And further, resident and family satisfaction must be a key determinant in eligibility. Using the Core Q survey implemented by the University of Connecticut Center of Aging annually, the results rating for the facility must be at least good or excellent. This ensures that any expansion is not just meeting the regulatory minimums, but also aligning with the needs of the residents and families that they're serving. By implementing these protections as a state, we will better be able to ensure that this legislation supports only high-quality, small-house nursing homes in areas where they're truly needed, rather than enabling expansion by owners or operators with poor compliance records or inadequate resident experiences. We respectfully urge the committee to incorporate these standards into the bill to safeguard the well-being of individuals relying on long-term care. Thank you again for the opportunity to testify and happy to answer any questions.
Thank you so much, and I'll be sure to look at the testimony. It's very helpful to have that feedback. Representative Hughes, go right ahead.
Thank you. Thank you to Mairead as well for bringing forth that excellent person-centered and family-centered protections. Really, I see that as absolutely critical to assuring expansion. So under your suggested language, there couldn't be a new operator. They would have to have a history of performance, right?
Yeah, under the outline of our proposed changes would ensure that any operator that's coming in would already have to have a proven track record of good compliance, meaning that they're meeting the federal standards and in good standing within the state as well.
Okay, I appreciate that. The other thing is there anything you want to add about residential councils or family councils as being part of that?
Yeah, no, and I think that's why it's so important to include specific evidence-driven family and resident-specific information as well, because there's regulatory compliance minimum standards outlined by the CMS and by DPH, but that's why the inclusion of the Core Q survey is so important, because that is a reflection of the residents and families and the services that they feel are being provided within that facility. So I think that really rounds out and makes a more holistic approach to DSS's continued consideration on what homes they would allow.
Finally, through you, Madam Chair, I think the only opposition is that the smaller models are not economically feasible for operators. Do you have anything to say around that?
You know, certainly I think the challenge is, and of course not pulling the purse strings for the state, but or the private facilities, but I think it's a moral obligation, and the trends are leading for smaller, more person-centered, community-based homes, whether it be individuals wanting to age in place in the greater community, or even operators that are hoping to better integrate the individuals that they're serving into the greater community. And so while it may be more challenging than a traditional institutional setting, ultimately you're providing a better quality of care. And I think that's going to show in the individuals that are trying to apply to your home, and so may ultimately work out for them.
Thank you, Madam Chair. Thank you, Daniel.
Thank you, Representative. Thank you so much for your testimony and your time today.
Thank you so much.
Next, we'll hear from Robin Sharp, followed by Senator Slatt.
Good afternoon, members of the committee. My name is Robin Sharp. I have the honor of serving as the president and CEO of Easter Seals, Capital Region and Eastern Connecticut. We are a nonprofit organization that is deeply committed to serving the over 3,000 individuals each year that we serve across Hartford County, New London, Tolland, and Windham counties. Our services span outpatient rehabilitation, neuropsychology, career development, adult day support, and individualized home services. 3 years ago, with the help of the state of Connecticut, we proudly opened Veterans Rally Point in Norwich, a center of excellence for veterans services, which is now a national model. Our services that we provide to people with intellectual and developmental disabilities are funded through Department of Developmental Services. The career development services that we provide are funded through the Bureau of Rehabilitation Services under Aging and Disability, and also through Department of Mental Health and Addiction Services. I'm here today to ask for your support on Senate Bill 1358 with the amended language to index nonprofit reimbursement rates with inflation. At Easter Seals, we employ approximately 80 dedicated professionals, about 50 of whom are direct support professionals. These individuals do some of the most challenging and essential work in our community. They care for people with severe disabilities, feeding them, changing them, assisting them in volunteer and vocational activities, and ensuring that they can engage in their communities at the highest possible level. The responsibility is immense. A simple mistake, such as providing food with the wrong consistency, can have catastrophic, even fatal consequences. Yet these critical roles are being devalued year over year. 5 years ago, my direct support staff earned $4 per hour more than minimum wage. That wage gap was at least some differentiator that helped us to attract and retain dedicated staff. Since then, we have raised salaries by 17%, some due to state mandates, some by choice. In only 2 of those years was there funding for those wage increases. Meanwhile, our reimbursement rates have failed to keep pace with rising labor costs and the many financial demands of operating a nonprofit. Today, our staff earn less than $1 per hour more than minimum wage. And in some cases, my staff that are providing job supports are earning less than the program participants that they are supporting. So for the more than 30 years that I've worked in nonprofit management in the state of Connecticut, I have never come to this committee or any committee and said we need to raise rates, but I am here now because we just can't keep pace anymore. I've always believed that it's the responsibility of nonprofit providers to manage our finances, control our expenses, and to make things work, but that's just not sustainable at this point. We are grateful for the funding from ARPA and other sources that the state has allocated over the past 5 years, but much of that money was temporary, one-time allocations tied to specific uses, and we can't continue to operate sustainably under those circumstances. The people most affected by this are the ones who need us the most because they are staying on waiting lists because we cannot afford to serve them. I deeply appreciate your service to our state. I know the decisions that you face are not easy, especially in this uncertain federal funding landscape. Now more than ever, we need you. We need your bold leadership. And I'm asking you to continue demonstrating that courage by fighting for our most vulnerable citizens.
Thank you so much, Robin. Thanks for your expertise and for being here. Representative Hughes?
And thank you so much. I know you represent a whole bunch of nonprofits, not just Easter Seals, which do such a great job. I recently had the privilege of touring a group home with very high needs individuals that need 24-hour care, and their loss of direct care staff because they just can't pay them. And these are folks that need to be highly trained, like you said, with such sensitivity to all kinds of things, aspiration and, falling, all those kinds of things that could result in hospitalization. Can you talk about your organization's turnover in staff due to the, lack of funding basically for direct care?
Just this year, typically our turnover rate has been about 30%, which I expect in a direct support role. This year alone, it's closer to 60%. So this staff increase, this workforce shortage is absolutely impacting our ability to provide services. And so we need to have that differentiator to be able to attract and retain our staff. Absolutely.
Yeah, well, from the trenches of the nonprofit group homes myself, I know that, we love the work, but it's also difficult and very challenging work, requires a lot of training, including de-escalation and behavioral health training. And that is a level of professionalism that we need to reflect in our pay. Otherwise, like these group homes will close.
That's exactly right. Thank you for that.
Thank you.
Thank you, Representative. We do have one more question on Zoom. Representative Dathan.
Thank you so much. And thank you for all the work that you do at Easter Seals. It's such a wonderful organization. I had to step out for a call, so I missed part of your verbal testimony, but I did want to ask the same question I've asked a few other folks in regards to, payments and, receipt of monies from DSS for your organizations that you're working with and your ability to pay for your employees and things. And basically the question is, are the payment terms that you all get, are you all able to manage your cash flow with the payments that you need to make? And if not, what is the sort of sticky point for you all?
So we also have a line of credit that we use for short-term borrowing when we need to. For us, with the state agencies that we're working with, our payments come quickly and they come regularly. So I really can't, no complaints about that. I understand the commissioner's concern about the 30 days of service. Just for example, in the way we bill DDS, we bill monthly. So getting payment from 30 days or day of service might give them 1 day to pay us. So there probably has to be some work around that language. My larger concern this past year was there was a rate increase with Department of Developmental Service that took 9 months for them to implement. So while our monthly payments were coming regularly and on time, those increases sometimes take a long time to get implemented. And so we're in the position of kind of floating the state, which we're not really able to do.
Yeah, that's actually a really good point. I'm glad that you brought that up because that is something that I have heard from another agency as well. And I agree with you. Getting things paid within 30 days of service is not necessarily adequate, because if you think about, if you provide services on the, your employee does services on the 1st of the month, but then you don't bill them till the end of the month, which is the 31st, they're already late at paying, even though they haven't even received a bill. So, I agree, but we might need to kind of rethink some of that language. But more of the point is, I get concerned when I hear that our small nonprofits, which are doing work for our state, are basically, as you say, floating cash flow. And I'm hoping that, I hear from other folks here that are nonprofit providers, what this sort of impact has on them. Because if you have a line of credit that is really for trying to manage, bigger purchases, it shouldn't be floating your operations for paying for cash flow for paying employees and other things. I appreciate your testimony and thank you very much. Thank you, Madam Chair.
Thank you, Representative. And thank you so much for being here and for the work you do. Next, we'll hear from Senator Derek Slapp, followed by Rebecca Atkins.
Good afternoon, Representative Gilchrist, and good afternoon to all of you, to all the members and ranking members and vice chair. My name is Derek Slapp, State Senator from the 5th State Senate District. I'm here to testify in support of House Bill 7021 to help fight hunger in the state of Connecticut. And I have with me an expert on the subject, so I'm going to hand it over to Jason Jakubowski, who is President and CEO of Connecticut Food Share, to talk a little bit more about the issue and about why this bill is so important. Thank you.
Thank you very much, Senator. I appreciate that. Representative Gilchrist and members of the committee, great to be here with all of you. As Senator Slapp said, I'm Jason Jakubowski, President and CEO of Connecticut Food Share. We are the statewide food bank serving a network of 650 pantries here across the state of Connecticut in every legislative district. And like Senator Slapp, I'm here to urge you to pass your own committee bill, House Bill 7021, to increase the state's support for this Connecticut Nutrition Assistance Program. CT-NAP is a 20-year-old bipartisan food assistance program created by a Republican governor and a Democratic legislature, led because when you're hungry, nobody asks or cares who you voted for in the last election. Under both the existing statute and the provisions of this committee bill, the monies appropriated to Connecticut Food Share can only be used to purchase food in bulk for our local pantries. We can't use the money for overhead. We can't use the money for salaries. We can't use it to buy trucks. We could only use it to buy food for local pantries. And in this proposed bill, we are also requiring that 15% of the state's appropriation to CT-NAP be used to purchase fresh, local food from Connecticut farmers. That's not only a win for the pantries we serve, but it's also a win for the Connecticut agricultural industry. Last year, Connecticut Food Share distributed 44 million meals and purchased 1.4 million pounds of food directly from Connecticut farmers. Unfortunately, even 44 million meals is not enough here in the state of Connecticut. Despite being in statute for more than 20 years, CT-NAP remains funded at only around $850,000, representing only about 1.7% of our total annual distribution. The state has an opportunity now to make a meaningful investment in CT-NAP, and it will help our partners and providers provide an additional 22 million meals yearly to people in across every legislative district in the state. And I know that the commissioner was here earlier and talking about the appropriation. While we appreciate the fact that the governor is doubling our appropriation in year 2 of the bill, in year 2 of the budget, or his proposed budget, 2 responses. One is that while we do appreciate that, 18% of the total what we need is still not enough, and we need the relief. The agencies need the relief now, not in year 2 of the budget. They can't wait 18 months in order to get relief. Food pantries and meal programs across the state are seeing attendance rising to levels we last saw during the COVID-19 pandemic, and we need to work together now to provide this much needed resource for our neighbors. So again, I thank my Senator Slapp, and our entire Connecticut Food Share team. I know you'll be hearing from one of our board members later, and I know a number of folks, including more than 70 members of the public, have submitted testimony to you all online about this particular bill. And between this bill and the its companion bill that was introduced previously, we have more than 50 co-sponsors, both chambers, both parties. Because again, there is no ideological divide here. I think everybody realizes that this is a dire need here in the state of Connecticut. So thank you.
Thank you so much, Jason. Thank you, Senator Slapp. And yes, looking at our list, there's quite a number of co-sponsors. Just a few questions, and then I'll turn to some colleagues. You mentioned the governor's budget. What is your current state funding? What is the governor and what is the governor proposing in year 1 and year 2?
So we basically, right now, we have approximately $900,000 from the state. That has been the same for the last 20 or so years. The governor is proposing, obviously we asked the administration, and we had Secretary Beckham out to our facility. We asked for $10 million, which is what this bill has. So what we received in the governor's proposed budget is $900,000 in year 1, which is status quo, and $1.8 million in year 2. I know that it was mentioned in several of the press briefings on the governor's proposed budget that they are quote unquote doubling our funding in year 2 of the budget. And again, that is technically accurate, but that is in year 2 of the budget, and it still falls woefully short of the 10 million that we need. By the way, the 10 million is not a made up number. We were asked by legislators in the last session, particularly Representative Cavros DeGraw and Senator Berthel, what do we need? And we did an in-depth analysis. We need $10 million. I mean, that's what the local pantries could use. So.
Thank you. And when we've spoken before, you've discussed how we are unique in our low funding compared to other states. Can you speak a little bit?
You're not going to be happy. You're not.
It's not a good unique.
In terms of yeah, well, yeah. It's. I mean, sometimes Connecticut is a very good unique. I love this state like you all do, but this is not a good unique. The state of Massachusetts, for example, $35 million. The state of New York, $30 million. The state of New Jersey, $85 million. So even at 10 million, we still fall woefully short of other states here in the New England / tri-state area. But we also know these are difficult financial times, and you all have tough decisions to make. But yes, we are significantly behind other states in the region.
Thank you. I appreciate that. Representative Hughes, followed by Representative Dathan.
Oh, thank you, Madam Chair, and thank you for your testimony, both of you, for standing up for so many of us. Does Connecticut Food Share have a recommendation to index appropriation to like a hunger index or a food cost index?
Well, the committee bill actually has written into it, I believe, a 3% automatic escalator every year. I mean, that's based on just generally where we see wages going and where we see inflation going. We are open to tying it to anything. I think that, I mean, and that granted, this is coming from an organization that hasn't had an increase in 20 years. But I think I understand where you're going, Representative Hughes, is that this is not a discussion we want or should be having every single year in front of the state legislature. So there is a provision within this bill to make sure that the appropriation continues to grow with the need. How you all want to word it in the end, I think we're very open, but if your goal is to avoid us having to go through this appropriations exercise every single year ad infinitum, the problem's only going to get worse in Connecticut. I mean, the numbers are only going up. And by the way, we are not unique in that respect. I mean, every state across the country is seeing the same thing.
Thank you. And through Madam Chair, I just think that, we know how many people live in the state. We know what the food costs are. And right now they are escalating. Maybe they'll come down in the future. Maybe they won't. Food supply chain, we're trying to increase through the local fresh produce and local farmers and really accelerating that or empowering that. But it's not that I don't want to see you come before us. I just think Connecticut should.
I love to be here.
No, Connecticut should feed our people. Like that should be a given, not that we should come before us, but that we should codify that into our general budget, that at least in Connecticut, we say our people do not have to go hungry.
You have no argument from me, Representative Hughes. I imagine the senator agrees as well.
Thank you.
100%.
Thank you, Representative. And Representative Dathan, who is on Zoom.
Thank you very much, Madam Chair. Thank you for testifying. I know we heard from a lot of folks last night in appropriations, particularly around the supporting Connecticut farmers. Currently, I'm guessing with the 900,000 that you're getting from the state, you are also privately raising funds as well?
Yes, absolutely. Very, very less than 5% of our total funding comes from government, which whether it be state or federal. 65% of our funding comes from individuals across the state of Connecticut, which for a nonprofit is very high. But people in every corner of the state are supportive of us. About another 30% comes from corporations and or philanthropic organizations like community foundations. So we are not wholly reliant on government funding.
That was really going to be my point, is that, it's a small percentage of what you are using overall. And you are getting money from the community, money from corporations. I'm sure you have lots of volunteers as well. Currently, with what you're spending on food, how much, what percentage would you estimate that you use with Connecticut farmers? Because I think that was one of the neat things about this bill, is that we're, kind of saying we'd like to get this much food, and particularly what we see nationally about what's happening to farmers in our country who are losing some of their government purchase contracts. I kind of like that, but I wanted to find out currently, what do you kind of source directly from Connecticut farmers?
So typically, up until maybe 4 years ago, the food bank, not only here, again, most food banks across the country, were not really in a position to purchase much food from small local farmers because the per unit price point obviously tends to be a lot higher than what it would be from buying in bulk from a large industrial farmer. So that wasn't something we had the luxury of doing. About 3.5 years ago, the previous administration in Washington, under Secretary Vilsack at the U.S. Department of Agriculture, came up with a program called LFPA to help promote local farming. And what they did was they gave funding to each state's Department of Agriculture, who then divided those funds up to be able to food pantries and to food banks and other organizations like that to basically allow us to purchase food from local farmers. That was a new program that was started about 3.5 years ago. We have spent more than $2 million of federal funds on helping to support Connecticut farmers over the last several years. And I will put in a plug. Commissioner Hurlburt and his team at the State Department of Agriculture are absolutely fantastic and have done a wonderful job helping us afford something that we normally wouldn't be able to afford. As the commissioner has said many times, that LFPA program was a win-win-win. It was a win for us at the food bank because we never would have been able to afford the price point on that produce. It was a win, obviously, for the farmers who have a guaranteed economic stimulus coming to them. And then it was most of all a win for the people that we serve across Connecticut who otherwise might not have access to fresh Connecticut grown food. Unfortunately, like with many things, the advice that we have been given based on the new administration in the U.S. Department of Agriculture is that the new secretary is not intending to continue with that program. Could it end up in the farm bill at some point? Maybe, maybe not. We were expecting to get approximately $800,000 from that LFPA program now we are not counting on, and we've had to tell our farmers, we can't promise you that we can do this. The reason for putting in the 15% into a bill like this is we know how popular the program is. We know how successful the program is. This would be a way of us in effect circumventing the federal government and ensuring that here in Connecticut, we're able to continue this program regardless of what they do at the federal level. If they give us more, great, we can do even more with it, but this allows this program to continue.
Well, you preemptively answered my question because I was going to ask what was the exposure that you have from the federal government based on those fundings. So that's really helpful. Just also wanted to say about the reason also this local produce is so important. We talked about it in Representative Foster and my work group on food is medicine. And there is, you know, opportunity for Medicaid dollars to associate with that, or I should say it used to be. Who knows if that's going to continue. But, you know, having all this information is important. The last thing I wanted to say is, you know, taking a snapshot of, you know, 2024 amount of people that are serviced by your organization in comparison to when you all maybe 10 years ago. What is this sort of difference?
I could even do you one better. I mean, we have year over year numbers that Feeding America measures for all 50 states. And in 2024, the number in Connecticut, there's about 470,000 people who are food insecure in Connecticut. That is a 23% increase over 2023. So clearly and it is a marked increase over 10 years ago. Those are numbers we haven't seen since the peak of the pandemic. Typically when unemployment is high, our numbers go up. Unemployment happens to be low right now. What happened was during the pandemic, the federal government had a number of stopgaps in place to help people. Pandemic era SNAP, pandemic era EBT. They also had unemployment insurance, moratoriums on certain payments. And obviously during COVID, the federal government flooded the emergency food system with food. Many of you may remember, many of you may have been out to our distribution at Rentschler Field. We had 2,500 cars a day out there. 90% of that food came to us for free from the federal government. Once COVID was over, that all stopped. And I think as we all know, because we all go to the grocery store and we all live in this world as well, the world didn't just snap back to where it was before. There's still a lot of families out there experiencing pain, and now those stopgap measures aren't there. So we have basically replicated the amount of need that we saw at the peak of the pandemic.
Excellent. Thank you so much for shedding light on this and all your work that you do in the state. Thank you, Madam Chair.
Thank you, Representative. I don't see any other questions. Thank you for your work and for being here. Thank you, Senator. Good to see you. Next, we'll hear from Rebecca Atkins, who's joining us on Zoom, followed by Representative Andre Baumgardner, also on Zoom.
Good morning, Senator Lesser, Representative Gilchrist, Senator Harding, Representative Case, and members of the Human Services Committee. My name is Becca Atkins. I live and work in Norwich, Connecticut. I'm the Executive Director of Artreach, Inc., home of the Second Step Players mental health sketch comedy troupe. Our DEMAS-funded program, Arts for Mental Health, offers classes and performing opportunities to adults who have experienced mental health issues and who are using these artistic experiences in the service of their recovery. We believe that recovery happens and that creativity heals. I thank you for the opportunity today to testify on Senate Bill 1358, an act concerning equitable compensation for state contracted nonprofit human service providers. Equitable compensation sounds great. I'm speaking today with a recommendation that the committee modify the bill to include language from the Alliance for Nonprofits, that the contract amounts for nonprofit human service providers be indexed to inflation. I've spoken to the Appropriations Committee twice this week about the need for the nonprofits that provide vital services to first catch up for the many years of underfunding by increasing the governor's budget for nonprofit providers. But today, I'd like to talk about the positive impact it would have to index that funding to inflation so that once we find a way to catch up, we can then keep up. Outreach is largely funded by DEMAS, but that funding alone has never covered our budget fully. Our expenses increase annually. Here is our reality. Spanning from 2007 to 2027, which is the end of our current DEMAS contract, our DEMAS funding has amounted to only a 9.1% increase. That's not annually, That's over a 20-year period. This is discounting the ARPA dollars, which appear as increases, but which were either limited to capital expenses or are simply one-shot infusions that are simply ending now. Right now, we're at the end of an ARPA infusion, which allowed us to fill in the shortfall between our DEMIS funding and our expenses for a 2.5-year period. It was great. As of December 2024, those ARPA dollars have ended, and beginning July 21st of 2025, we are back to our pre-pandemic level of funding. We're back to the same old problem we've always had, cobbling together outside grants from community foundations and other sources just to break even, and sometimes even dipping into our line of credit. And we're in southeastern Connecticut, so we have fewer of these resources than our colleagues in Hartford and the other big cities. Most of the grants we qualify are small and project-based, requiring program activity far beyond our DEMIS contracted services. Yet without enough funding for even one more staff person to do this extra work, the grants don't cover staff. Oh, sorry. All I can say is it would really help us to index to inflation. That would have helped us stay out of this problem and help us moving forward. Thank you for the opportunity to testify today.
Oh my goodness, you were doing your own timer. Would you look at that? Thank you so much for your testimony and for the work you do. And I've seen you over in a probe, so thank you for doing so much double duty.
Thank you.
I don't see any questions. Have a great afternoon. Next, we'll hear from Representative Baumgartner online, followed by Jeffrey Santo. Go right ahead, Representative. You just need to unmute. There you go.
Excellent. Can you hear me?
Yes, we can.
Fantastic. So, all right. Chairs Gilchrist and Lesser, Vice Chairs Comey and Marr, and Ranking Members Case and Harding, and members of the Human Services Committee. It's great to be with you this afternoon. I'm very proud to testify in strong support of raised bill number 6937, an act concerning Medicaid coverage for medically necessary children's diapers. Access to diapers is a fundamental necessity for families across Connecticut, including my constituents in Groton, Mystic, and Stonington, directly impacting their financial stability and their children's health. This issue is deeply personal to me. My grandfather was a pediatrician at the submarine base in Groton, and throughout his career, he emphasized the critical importance of addressing infants and toddlers' health needs. He understood firsthand the challenges families face when trying to provide the best care for their children and the stark health disparities that persist in our communities. Diaper insecurity is a pressing issue that not only affects a child's well-being, but also places immense strain on struggling families. According to recent reports, nearly 1 in 2 families in Connecticut struggle to afford diapers, a significant increase from 1 in 3 before the pandemic. The cost of diapers has risen by 22% since 2018, further exacerbating the financial challenges low-income families face. The Diaper Bank of Connecticut currently serves over 6,000 children each month, but many families still experience diaper insecurity, leading to preventable health issues such as severe diaper rash and urinary tract infections. Expanding Medicaid to cover medically necessary diapers is a common sense, pro-family, and pro-economy solution. When families cannot afford enough diapers, children are at a higher risk of severe and persistent diaper dermatitis, again, urinary tract infections, and other preventable health conditions. These issues can lead to parents missing work to care for their sick children, further exacerbating financial hardships. Additionally, these investments will help prevent more costly Medicare medical interventions and reduce economic losses from parents' parental work absences. I want to commend and support the Human Services Chair, State Representative Jillian Gilchrist, as well as the Diaper Bank of Connecticut for their leadership on this critical issue. Their advocacy for expanding Medicaid coverage for diapers will provide tangible relief for countless families and reduce preventable healthcare costs in our state. I also want to voice my strong support for HB 7021, an act concerning funding for nutrition assistance. Again, this legislation represents a critical step towards addressing food insecurity across Connecticut by ensuring sustained and equitable funding for nutrition programs that serve our most vulnerable residents. As a state rep from Eastern Connecticut and vice chair of the Environment Committee, I know firsthand the importance of supporting our local farmers. This bill ensures that at least 15% of allocated funds are used to purchase produce and other products directly from Connecticut farmers. This investment strengthens our agricultural economy while increasing access to fresh, nutritious foods for those in need. Again, adequate nutrition is a cornerstone of public health. Studies show consistently that food insecurity contributes to poor health outcomes, particularly among children, seniors, and individuals with chronic illnesses. Ensuring access to locally sourced nutritious food not only reduces healthcare costs, but also fosters greater economic stability and educational achievement. By investing in nutrition assistance programs and supporting our farmers, Connecticut is making a direct commitment to the well-being of its residents and the future prosperity of our state. And lastly, I just want to acknowledge the incredible work that Connecticut Food Share has done to combat food insecurity, particularly during the COVID pandemic. Food Share played a really critical and crucial role in ensuring that families have had access to nutritious meals during an unprecedented crisis. Their tireless efforts in coordination with soup kitchens, food pantries, emergency shelters have been instrumental in keeping our communities fed. Strengthening funding for nutrition assistance programs will help organizations like Food Share continue their vital mission of supporting residents in need. So in total, this bill also aligns with our state's broader commitment to social equity. Food insecurity disproportionately affects low-income families, communities of color, and those with disabilities. By increasing funding for nutrition assistance, we can address these disparities and create a more just, resilient Connecticut. Thank you for your time, and be happy to answer any of your questions.
Thank you, Representative Baumgartner. It's been wonderful partnering with you on the proposal for medically necessary children's diapers, Medicaid coverage. Thank you. Representative Hughes.
Thank you, Madam Chair, and thank you. I echo all of your support that you raised. This is the, I don't know, second or third iteration year that we've tried to raise the act concerning Medicaid diaper coverage for medically necessary children's diapers. And I can't remember if you testified last year or not, but can you comment on the parity with adult Medicaid patients that do have Medicaid covering adult diapers in nursing homes, but not for medically necessary children's diapers?
Actually, that's a great point. I did not testify on this legislation last year, but a constituent of mine reached out to me kind of inquiring as to whether or not adult diapers would be included. And after doing a bit of research, I learned that actually it is in some cases covered, as you've described, by Medicaid for folks who do experience or who have that level of care. But certainly, we, as we all know, with the potential precipitous loss in federal funding that we've been used to over the last couple of years by virtue of the influx and infusion of cash from ARPA, for example, we really have relied on really critical dollars. And obviously, we do have a really wonderful Medicaid program in the state, and your incredible committee is looking at identifying additional services where we can leverage or get a higher reimbursement rate. But again, we still can do more, and I think this is an area where again really honing in on medically necessary for birth to 3 is really critical, because those are the youngsters that need it most. Their health outcomes in those 3 years will largely determine their future, right? And so it's so important that every child, irrespective of their zip code, irrespective of their family income, again, has access to high quality healthcare, and that does include access to diapers.
Thank you. Thank you. And through you, Madam Chair, I just think it's critically important for those involved in direct care that they understand we should never be rationing diapers or food or medicine for the most vulnerable patients, that regardless of age, babies, adults in nursing care, because of cost. So I absolutely think that this should be foundational to what Connecticut does and what our Medicaid patients get. Thank you, Madam Chair.
Thank you, Representative. And thank you again, Representative Baumgartner, for being here today and for all your advocacy.
Absolutely. Thank you, Madam Chair. It's great to see you.
Great to see you. Next, we will hear from Jeffrey Santo, followed by Senator and Dr. Rahman.
Good afternoon. Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Jeffrey Santo, and I'm a registered voter in the city of Norwalk. I'd like to start off by thanking you for listening to my testimony today. And as per usual, I'm not even going to read from my testimony much. I usually go off the cuff. I'm here to testify in opposition to House Bill 7023. And if you told me 2 years ago that I would be sitting in opposition of a bill that would provide funding for peer support services for Medicaid, I would have said that you're way off par here. Funding for our services is essential. I believe in the value of peer support, but as this bill is written, I cannot stand behind it. One of the biggest problems that will be identified through various testimonies from some of my fellow recovery support specialists is that right now, in statute, we don't have an explanation or a definition of what a peer support specialist is. We don't have a definition for peer support services. I believe, and many of my colleagues believe, that a peer support specialist is someone that has direct lived experience. No ifs, ands, or buts. Let's say, for example, I'll give you a real life scenario. Let's say I was well versed in the law. I memorized every state statute. I knew everything there was to know about writing a bill or passing legislation. If somebody were to be elected to the legislature tomorrow and show up for work, I would be able to get them through the door and give them kind of a heading of where they need to go. But as representatives and senators, you have the lived experience necessary to explain to them how they might reach across the aisle to the other side to make a difference. You may provide them with some kind of support, knowing that they're going to face constituents who come to you not having enough to eat or having trouble paying their medical bills. As somebody who may be educated in the law, I can't give them the type of support they would need in those situations. The people in the mental health and addiction services field, the ones with the education, we refer to them as clinicians. But the type of support you can offer them, that would be peer support. And that's why we need to have a very clear, defined difference between those two things. When someone comes to me and they're experiencing suicidal ideations for the first time, they might not even understand why. A clinician may choose to have them hospitalized. But for somebody who woke up in a hospital 10 years ago, not knowing why I was still alive, I can sit and talk to them and try to help them understand how they got to the place that they are in. People don't just wake up one day and decide that they want to end their life. It's usually a series of events and things that build up and create that pressure. It's not being able to escape from a situation, whether it be something like domestic violence or being bullied at school. There are a lot of reasons why people would consider these actions, and most of it is because they can't find a way to escape. And when I share that revelation with some of the people that I work with, they wonder how I can so easily put into words what they have been trying to explain to their family and friends for months. And it's because I spent 10 years thinking about it after my attempt. That is peer support. And without the protections in the statutes that explain what peer support is and how it's supposed to function, we shouldn't move forward creating more legislation that dictate how it works.
Thank you so much. I do have a question. Would you be in support if there was this clear definition of a peer support specialist, or is that still problematic?
We would have to take a look at it. Right now, I was a part of the Yale Peer Advisory Committee that came up with the new peer code of ethics. And one of the very first items, it says a certified peer recovery professional will share their lived experience and stories to promote and support recovery, hope, resilience, and help people they serve as appropriate to the situation. Right now, we have people in the state of Connecticut that were trained as peer support specialists that have no direct lived experience. And it's kind of hard to use something you've never had. And right now, with the new peer certifications that are coming online, anyone that previously graduated from Hartford Healthcare's Recovery Leadership Academy, which allowed family members and people who supported those in recovery to become a peer support specialist, they can currently be grandparented into the new process because of what I was told as to be legal reasons.
Thank you. Very helpful. I don't see any hands raised. Thank you so much for your testimony today.
Thank you.
I messed up. I want to apologize to Senator Rahman. It's actually Representative Wielander's times, and then I'm so sorry. And then we'll go to Kellyanne Day and then to you, Senator. Sorry about that.
Thank you. Good afternoon, Chairs Representative Gilchrist and Senator Lesser, Ranking Members Senator Case, or Representative Case and Senator Harding, and all of the honorable members of the Human Services Committee. My name is Mary Wielander, and I serve in the 114th District, and I'm here to support HB 6397, an act concerning Medicaid coverage for medically necessary children's diapers. I know that many other supporters will be sharing some of the data points about how many families are unable to provide an adequate supply of diapers for their kids. So today I thought I would share a personal story about why I support this measure. When my husband was in graduate school, his program did not include a stipend that provided living expenses for one person, let alone a family of 4. I was home with our 2 very young children because we could not afford childcare, and all of our costs for rent, food, and health care were covered by student loans. We made the decision to switch from the university health plan to the Husky plan, where we received excellent care from our pediatrician, Dr. Mary Ellen Flattery Hewitt. When our son was not yet 2, we attended a barbecue where we discovered that he had inherited his father's love of bratwurst. The combination of too many brats, very warm weather, and a skipped morning nap led to a very deep sleep in his afternoon nap, where he slept through a dirty diaper. When he woke up, I was shocked by the severity of rash and irritation that I had found. In a short time, the rash became open sores. Still, I was surprised by the seriousness of the response I received when I called our pediatrician's office about it. I was told that these kinds of rashes can become seriously infected incredibly quickly, and it was so important to get it treated, to keep him hydrated, and as dry as possible, which meant constantly checking and changing his diaper. After being prescribed an antibiotic cream and going through about an entire package of diapers, we went for an in-person visit to follow up a few days later, where thankfully he was on the mend. But I remember so vividly thinking, we are spending a fortune on diapers right now, but I am so glad that we can get what we need, even if it is a student loan. In my life as a mother, this is one of the moments that stands out because of the overwhelming gratitude I felt for being able to provide what my children needed to be healthy, and simultaneously recognizing that so many are not able to do the same for their kids. No parent should feel helpless because they cannot afford clean diapers for their children. No children should be put at risk for pain and infection because their parents cannot afford clean diapers. Every year, my husband gives to the diaper bank for me in honor of Mother's Day, so we can try and prevent one family from feeling that way. This is the chance for us in the legislature to do this for a lot more families. So thank you very much for your time.
Thank you so much, Representative Wielander, for being here and for sharing your personal experience and for continuing to support the diaper bank and this bill. Yes, Representative Hughes.
Thank you so much. Thank you for testifying. It basically moves me to tears. But one of the things that the opposition will say, well, why can't they just go to the diaper bank and get what they need? And that is why I want you to address specifically why, medically fragile Medicaid children should be covered on diapers.
You know, it's funny. I literally said almost the same sentence I'm about to say in the Children's Committee just downstairs. When you are a parent with young children, trying to do anything, even in the best of circumstances, is very difficult. If you add on a challenge, such as a medically fragile baby or an unexpected rash that gets really serious really quickly, that makes it just that much harder to add in another step that you'd have to get somewhere else, get somewhere specific, that you aren't able to just take your family, you go to the store and do what you need to do to get what you need on your own and on your own time in a manner that is supportive. I I think that the less barriers we have to this kind of care, the better.
Thank you, Madam Chair, and thank you so much, because I agree that there are so many invisible barriers that mothers like yourself who I remember I was an older sister of several babies, and I learned how to, my younger sisters, I learned how to diaper them because we only had one car. My dad was a school teacher, so there was no transportation in, Fairfield to go to the store. So we learned to, cloth diaper and clean diapers for my own little sisters. But like all the barriers that largely mothers absorb and is unaccounted for and unvalued, and just been like, just go to the diaper bank is just naive. And I just want to highlight that. Thank you.
Thank you. And if I may comment just one more thing, I think we're also looking at this, especially again for the mothers who are not able to do everything sometimes on our own. It's harder for us to ask for help. And if you were thinking, I can't afford disposable diapers, so I have to stay home and I'm going to wash the cloth ones. If you are constantly cycling through the same half dozen diapers, there's no way that that woman is going to be able to even think about looking for a job, getting herself supported, and looking at very long-term issues. The longer a woman stays out of the workforce, the more vulnerable she is later in life. So we have women who are living longer than men, who have less built up in their retirement accounts. They are going to be, again, the most vulnerable population at both the beginning and the end of their life cycles. So doing this may be the boost that someone needs to be able to say, I can go out and do this. I can go back to school. I can provide for my family, because this one thing has been taken off my shoulders for just this short period of time in life. So thank you so much for paying attention to this issue. I really appreciate the committee's attention.
Thank you. Representative Butler.
Thank you very much, Representative, for your testimony. I could say that while you're focusing on young moms, long time ago, I changed a lot of diapers for my daughter, and I could relate to that rash issue. And, years later, I could say that that's one thing I want to put behind me, that experience, because the discomfort that your infant feels and actually let you know about it is something that is really prominent in young parents' minds. And recently, my daughter having her own son, I could tell you that that whole diaper and rash situation, it's like it's one of those things that's common, is so that it's not like a rare case or anything. And I still remember actually alternating from diapers. And diapers, by the way, was one of the largest expenses dealing with an infant. So my wife and I used to alternate cloth and actually disposable, just because change it up a little bit. So I just wanted to share that it's not just young women. It's like the guys change a lot of diapers too, and they're a part of this. And even when you have two-parent household, it's still a challenging situation, especially when you're looking at those rash situations and you're just a parent looking at your child that's having difficulty. And infants, you just it tugs at your heartstrings to see them having difficulty. So thank you for your testimony.
Thank you. And
thank you, Madam Chair.
That is a really good point, though, that it is mothers and fathers who do feel the same pain and frustration of not being able to care for their children the way they want to. So thank you for that, Representative.
Thank you. And Senator Lesser.
Thank you, Madam Chair. Thank you, Representative Wiehlander, for your testimony and for telling your story. I think, I was listening intently to Representative Butler, I think I am the only member of the committee, and I'm cautious here, but I think I might be the only one who's currently changing diapers. And if you see circles under my eyes, you'll understand why that might be. I certainly have supported this concept for some time. I do know that, though, reading the testimony, listening to the testimony of the Commissioner of Social Services earlier, she did say that this was very expensive. And I think the fiscal note they testified to was about $35 million. Obviously, that's an awful lot of money, maybe not in the context of a $25 billion state budget, but still a lot of money. So I assume you're willing to work with the committee to try to figure out, how do we get that fiscal note down? How do we pay for this in a way that doesn't, limit our ability to provide other essential services as well?
Absolutely. And thank you for mentioning that, because I think when we think about what we can do to support young families, we are looking at something that has one of the highest returns on investment is, access to childcare, access to, employment. And so if we are able to help, because it's expensive for the state that can buy in bulk, imagine how expensive it is for families to be doing it independently. So yes, absolutely happy to help however I can. Thank you.
Thank you very much.
Wonderful. All right, next we'll hear from Kellyanne Day, followed by Senator Rahman. I made a mistake. Your first name's MD. You're not a doctor. My apologies. I'm going to turn it over to Senator Lesser because I have to step out. But Kellyanne with us?
Yes, I'm here. Good afternoon, Senator Lesser, Representative Gilchrist, Senator Harding, Representative Case, and the members of the Human Services Committee. My name is Kellyanne Day, and I'm the CEO of New Reach, and we're an organization dedicated to preventing homelessness, providing emergency food and shelter, and creating supportive and affordable housing. Each year, we serve over 5,000 individuals. We employ 95 staff. And I appreciate the opportunity to express my support for Senate Bill 1358, which addresses critical issues faced by nonprofits. We request that you include substitute language that would index nonprofit funding to inflation. With that language, the bill would help community nonprofits stabilize their budget and provide additional services to the state's most vulnerable. I'm grateful for the increases the legislature has been able to provide over the past few years, but they have not been enough to meet the needs of the people we serve. We continue to be hit by crippling increases in our costs due in part to increases in inflation that far outpace the rate of the increases the legislature has provided. I'd like to just share a little bit of the struggles that we have here at New Reach. Over the 30 years that I have been with New Reach, I've witnessed our organization evolve significantly to meet the growing needs of those we serve. And while our services have expanded, so too has our administrative burden. In the past, we could manage effectively our reports with minimal technology, but today every staff member requires their own computer. We must have sophisticated financial reporting systems, human services, and digital platforms, to name a few. As requirements have multiplied, so have cost, for which funding is lacking. This creates a challenging paradox. We're required to meet stringent deliverables for the state without adequate funding to support that work. Our staffing issues. Social work attracts individuals who have a driven desire to help others. However, it's increasingly difficult to recruit and retain staff. Our diverse staff have cumbersome reporting that can take up half their work week. And in fact, we train and recruit wonderful staff, and then the state steals them for $10,000 or $15,000 more a year and a Cadillac health plan. Our reduced workforce leads to burnout for the remaining staff, further exacerbating turnover and decrease in quality services. Unlike private contractors who receive fair compensation, we would like the nonprofits to be indexed. And timely payments. I know there's a conversation about whether it's 30 days or 45 days, but I would like to say that New Reach has to often go into our line of credit in order to pay because the state does not pay us on time. Even though we report on time, our reporting that's required, which if I have to say so, is do as I say, not as I do. So I urge you to support this bill and index our contracts. And in conclusion, I would also like to advocate for Bill 7021 concerning the nutrition. New Reach merged with a nonprofit called Fish in January of 23 for efficiency reasons and for funding reasons. And we provide delivered groceries to over 700 homebound residents of 4 towns throughout New Haven. These folks cannot get out to food banks due to mobility issues, and we count on Connecticut Food Share for our food. Thank you, and I'll take any questions.
Thank you so much for your testimony. I think we are going to be really focused this year on finding ways to support our vital nonprofit providers and provide you the fiscal support you need to continue your mission. So we're appreciate your testimony and ways to retool this bill to better address that need. Is there any questions or comments from members of the committee? Seeing none, thank you very much.
Great, thank you.
Next, we have Dr. Rahman. I'm going to call you that going forward. You can hang a shingle in the 9th district where I represent anytime. We'll exempt you from board licensing rules.
Mr. Chairman, good to see you.
You too, my friend.
I'm here with my good friend Molly Debani. Molly and I, we are working closely, supporting and serving our community for a long time. Molly involved number of nonprofit organizations nationwide. She's always there when our food pantry or food share, anyone needed there. So today, Molly here to talk about and supporting the food share. I want to yell Molly my time today. Thanks.
Thank you very much. Thank you, Senator Lesser. I appreciate the time. I'm an MD too, so I'm not a doctor, but I'm got the same initials, so confusing all in all today. But just again, esteemed members of the Human Services Committee, thank you so much for the opportunity to testify today. My name is Molly Devaney, and I serve on the Board of Directors for Connecticut Food Share, where I also serve as the chair of the Strategic Planning Committee. In addition to this role, I volunteer every other week at the mobile food distribution site in Manchester, Connecticut at Squire Village. I have witnessed firsthand the significant growth in the number of people seeking assistance over the past year. Went from 75 people continuously over COVID, and now we're up to 150 people that visit that site every week. So significant growth there. In addition to that, I'm also a business owner in Manchester, Glastonbury, and Farmington, operating Highland Park Market, which is a grocery store. And throughout my work, I've seen a steady increase in food prices, making it very more difficult for families to afford the basics. I'm here today in support of the 1 in 8 Connecticut residents, including 1 in 6 children facing food insecurity, and urge you in this committee to pass House Bill 7021. Which would increase funding and support for the Connecticut CTNAP. The state has a critical opportunity to make a meaningful investment in CTNAP, enabling Connecticut Food Share and its network partners, including organizations like those I work with, to provide an additional 22 million meals each year to people in every legislative district. Additionally, by keeping these funds in state, we can support our local food system and the local farmers here in Connecticut. Through the purchase of Connecticut sourced foods from farmers. Currently, CTNAP is the only funding Connecticut Food Share receives from the state of Connecticut to purchase food, and it makes up less than 2% of their total annual distribution, closing less than 1% of the state's total meal gap. I appreciate the interest that the governor's office and the state have taken in this program, but I'm strongly urging this committee to move HB 7021 forward. In my experience, the need for food assistance is growing rapidly, as seen in the increasing number of families at the mobile site where I volunteer. Passage of this bill will bring Connecticut in line with our other neighboring states. I know Jason just said it, but just a reminder, other states each invest between 30 and 85 million annually in similar programs. This investment would help provide food pantries, meal programs, and our neighbors with 22 million more meals each year. I firmly believe that no one should go hungry, and this bill is critical for the steps moving forward in addressing food insecurity in our state. Keeping these funds within Connecticut will allow us to directly support those in our immediate communities who need it most. Thank you all for your time and attention.
Thank you, Senator. Thank you, Molly, for your testimony and for your work in not only feeding folks in your day job, but also making sure that we're addressing hunger in Connecticut. Now I was out of the room when Jason testified earlier. But I know obviously I was happy to see the governor put some money on the budget. I think 900,000 towards food insecurity, but it sounds like we need to consider much more. I know that Congress right now is considering major cuts and on top of everything else to the SNAP program. That's the That's obviously separate from the work that Food Share does. But I'm assuming that if Congress cuts the existing support for hungry folks in Connecticut, that will put even more strain on organizations like Food Share. Is that right?
Yes, that is. And we've seen and we've worked tirelessly, as you've seen with the merger, when we did merge the state, it became one state organization. That was incredible, resources that we've been able to leverage and to work together instead of having Connecticut Food Bank and Food Share merging together allowed us to have many more resources available, and working together as a whole team. This would just take away more from all the efforts that we're making.
Well, thank you so much. And please keep serving on that board and advocating for this important cause. And we'll look forward to working with Senator Rahman. We'll try to figure out how to see what we can do in the state budget this year.
Thank you.
Thank you so much, Mr. Chairman.
We actually have another question, Representative Butler.
Yes, it's just a quick comment. I'd like to thank you for coming forward to advocate in this issue, because it's really, really important. But I could tell you that your testimony actually takes on a little bit more credibility, because I know your commitment. Before I retired recently, I worked with folks from the IDD community and helping them with employment. And I can tell you the Highland market, actually employed some of these individuals to help make a difference in their lives. And to actually see your stores are wonderful, but just to know that it's that kind of commitment to community that you brought forward, it just warmed my heart. But it tells me that you're the type person, when you sit there and give testimony, that it gives it just a little bit more credibility. So thank you for what you do, and we're going to do what we can to help this initiative. Thank you very much, Mr. Chairman.
Thank you, Representative Butler. And we are not going to be charging Highland Market an ad fee for promoting this wonderful Connecticut business that provides such great food and jobs to folks in that part of the state. Wonderful. Good to see you both.
Thank you.
Thank you.
Next up, we have, I believe, Leonard Cipollone, followed by Christina Mera. Good afternoon.
Good afternoon, Senator Lesser and members of the Human Services Committee. My name is Len Cipollone, and I am the president and CEO of Easter Seals of Greater Waterbury. We provide residential and day supports for adults with intellectual disabilities, early childhood education, outpatient medical rehabilitation, and audiological services. Our organization employs over 200 staff and serves more than 4,900 individuals across Greater Waterbury, Meriden, and Danbury. Thank you for the opportunity to testify in support of SB 1358. I strongly urge you to include substitute language to index nonprofit funding to inflation. This adjustment will help community nonprofits stabilize their budgets and continue providing essential services. We sincerely appreciate the funding increases the legislature has provided in recent years. However, like many nonprofits, we are facing rising costs across the board, including rent, utilities, insurance, and essential supplies. However, one of the most urgent challenges is staff compensation. The gap between wages we can offer and Connecticut's minimum wage has narrowed dramatically, making it nearly impossible to compete for skilled workers without the ability to offer competitive salaries. We struggle to recruit and retain dedicated employees who make our services possible. The workforce crisis is having real consequences. We have experienced increased staff turnover, leading to gaps in care and additional training costs. We've had to limit the number of individuals we serve because we simply do not have enough staff. If the rates the state pays for our services had kept up with inflation since 2007, we wouldn't need to ask for urgent funding adjustments year after year. Inflation on the cost of our services have risen by 45%, while legislative increases have only covered about 15%. This widening gap makes it harder every year to provide the level of care our communities need. If our funding had increased consistently with inflation, we could have paid competitive wages to attract and retain skilled staff, expand services to meet growing demand, and avoid wait lists and ensure timely supports for those in need. Passing SB 1348 with the proposed substitute language would give nonprofits like ours financial stability needed to plan for the future, retaining high-quality staff and provide uninterrupted care for the people that depend on us. I urge the committee to support SB 1358. Thank you for your time and consideration.
Thank you for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you.
Thanks.
Next, we have Christina Mara, followed by Thomas Burr. Is Thomas Burr here? Hi, Tom.
It's a hard act to follow, the Highland Park show. I have to get my wife out of the store once in a while. She loves the place. Anyway, good afternoon, Senator Lesser and members of the Human Services Committee. My name is Thomas Burr, and I'm the Public Policy Manager for the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. NAMI is the largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. I've included a lot more information about NAMI testimony if anyone is not familiar with this. I'm testifying in regards to House Bill 7023, an act concerning Medicaid reimbursement for the substance use coaches and mental health counselors. You've already heard from one of the members of the peer specialist community in Connecticut, and I have no doubt you'll hear from many more. And most of them, I think, are opposing this bill. I'm not going to regurgitate their points in my testimony, but I will wholeheartedly support their reasoning and their testimonies. While I believe that the committee had the best of intentions in raising this bill and applaud you for your attempts to address an ongoing funding issue, and while I do believe that peer specialists should be paid a living wage for their work and that we desperately need more of them here in Connecticut doing this kind of work, the bill as currently written doesn't seem to hit the mark as you might have intended. Public Act number 21-35 passed in 2021 called for the establishment of a task force to study peer support services and to encourage healthcare providers to use such peer support services when providing care to patients. Such studies shall include, but not be limited to, an examination of methods available for the delivery and certification of peer support services and payment mechanisms for such services. I firmly believe that had this task force been created and was able to do its work, we'd be in a much better place today to make a steady, reliable funding stream a reality, as it likely would have addressed many of the concerns outlined in the peer community's testimonies that you're going to hear shortly. Let's convene that task force, let them do their work, and get this all off on the right foot with the enthusiastic support of all the people concerned. And with that, I just thank you for your time and attention. And since I didn't hear the dinger yet, I'm going to say that for the record, we also support Senate Bill 1358, the act for equitable compensation for state contracted nonprofit human service providers, including indexing their rates to inflation. Thank you.
Thank you. That was quite efficient.
I try.
You've done this before.
Once or twice.
So you would suggest, if we were to try to move forward on peer support coverage, that we should try to take back the 2021 bill, stand up the task force and use that to be the way forward?
From my perspective, that's probably the best way out of this. But I would certainly defer to the peers because no one knows their business better than they do.
Okay, thank you. Any comments or questions from members of the committee? Seeing none, you're off the hook. Thanks, Tom.
All right, thank you.
Next, we have Dr. Selena, and I believe she's actually a doctor, not just named MD, Dr. Selena Ose from the Connecticut Hospital Association. Not here. Okay.
I'm on
Oh, you are? Okay.
All right. Good afternoon, Senator Lesser and honorable members of the Human Services Committee. My name is Dr. Selena Ose, and I'm the Director for Health Equity and Community Engagement at the Connecticut Hospital Association. It's an honor and a privilege to once again have the opportunity to testify in support of House Bill 6937, an act concerning Medicaid coverage for medically necessary children's diapers. CHA supports this bill because it extends the current coverage for children older than 3 to children under 3, using a targeted preventive and treatment approach based on individual determinations of medical necessity. 1 in 2 families in the US have diaper insecurity, which can increase the frequency of common skin conditions like diaper rash and fungal infections like candidiasis that are the underlying causes of urinary tract infections, the most common bacterial infection related to inadequate diaper hygiene. Several studies have also found that diaper insecurity is the #1 risk factor for postpartum depression in new mothers. Yes, maintaining proper diaper hygiene, including frequent diaper changes and proper cleaning, can help prevent the diaper-related skin conditions. But what this proposed bill aims to do is to really target those for whom coverage is medically necessary and will reduce unnecessary healthcare utilization. So by passing this bill, we hope to achieve the prevention of diaper-related skin conditions and avoidable hospital visits due to more severe conditions like acute kidney injuries that happen because of frequent UTIs. We also hope to enhance economic opportunities for caregivers, like some of my peers have testified to earlier. In order to achieve the full benefits of this bill's implementation, I think it will be beneficial for DSS to consider leveraging the infrastructure that exists with the Diaper Bank of Connecticut's extensive diaper distribution network, which includes hospitals and their community partners, to help connect families to wraparound services and improve the overall well-being of families. Providing coverage for diapers when medically necessary is essential and appropriate care. It is also an effective preventive health and early intervention strategy that benefits both children and their caregivers. It's a state-specific bill that can be tailored to the unique needs of Connecticut. And so while I understand the some of the pushback we've heard so far, I think we have the opportunity here to really address diaper need as it pertains to children here in Connecticut.
Your time is complete. Please summarize.
Thank you so much for the opportunity to testify today and for considering our position.
Thank you so much, Doctor, and look, really appreciate the CHA's thoughtful support of this legislation. Are there comments or questions from members of the committee? Seeing none, thank you for being with us today. Next, we have Danielle Middlebrooks from the Blue Hills Civic Association, followed by Mag Morelli. Was Danielle with us? Yes, you are.
Hello. Hello. Good afternoon, committee members. My name is Danielle Middlebrooks. I'm a nonprofit leadership consultant, currently leading youth development initiatives with the Blue Hills Civic Association, one of Hartford's largest and oldest civic associations that aims to foster vibrant, engaged residents and leaders by promoting strong schools, culturally competent healthcare, and economic equality in safe neighborhoods. I'm speaking today to express my support for HB 7021, an act concerning funding for nutrition assistance. I support this act to increase funding for nutrition assistance and support the purchase of fresh produce. The impact of nutrition assistance programs is undeniable, and its increase is essential to the health and economic success of our state. It's overwhelmingly our youth, the future of our state, who benefit from this program, and by mitigating hunger as a barrier to success, the benefits of the nutrition assistance program are felt academically, socially, and economically throughout our state. As you've heard, food insecurity is and remains a significant issue in many of our cities and towns, and families are struggling to make ends meet. And for some children, the sustenance afforded them by the Nutrition Assistance Program may be the only they have consistent access to. As the price of eggs, bread, milk, apples, carrots, garlic, butter, etc. increase, funding to this program is essential, and I would ask you to go further and include that the mandate that at least 15% of the program's funds be allocated each fiscal year for the purchasing of produce and other products from Connecticut farmers, ensure the inclusion of minority, women-owned, and urban farming operations as well as cap the handling fee to soup kitchens, food pantries, and emergency shelters to ensure that this funding reaches without barriers the youth, families, and communities most in need. In addition, I'd like to express my support for HB 06096, an act concerning equitable compensation for state contracted nonprofit human services providers, including providing the annual cost of living adjustments to such rates. I urge you not to see these increases as just any line item, but to see them for what they are, an investment into the continued and future success of our state as a whole. Thank you.
Thank you for your testimony. And you were also extremely brief, which is great. You were within the 3 minutes. Thank you so much for those two issues. We will look forward to working with you, and thank you for your advocacy on behalf of the residents of the city of Hartford and the state.
Absolutely.
Are there comments or questions from members of the committee? If not, thank you very much. It's important.
Thank you.
Next is Mag Morelli here.
Thank you, Senator Lesser. And members of the Human Services Committee, my name is Mag Morelli. I'm the president of Leading Age Connecticut, a statewide membership association representing not-for-profit and mission-driven provider organizations serving older adults across the continuum of aging services. On behalf of Leading Age Connecticut, I'm pleased to provide testimony on House Bill 7026, an act concerning exceptions to the nursing home bed moratorium, and Senate Bill 1359, an act concerning various revisions to statutes concerning DSS. Regarding House Bill 7026, we support the objective of these proposed changes to our nursing home moratorium statutes. Connecticut has had a moratorium in place on the building or expansion of new nursing homes with very few exceptions since 1991. The original intent of the moratorium was to control Medicaid spending, but in more recent years, the goal has been to rebalance the long-term care system by encouraging a reduction in nursing home beds while enabling individuals to receive long-term services and supports in the community. Time has passed, and now we're very close to achieving our statewide rebalancing goals. But at the same time, we find that we're lacking access to nursing home care in various geographic regions of the state. 15 homes have closed since 2021, and many other nursing homes have permanently reduced their bed size. The Department of Social Services has been carefully monitoring this bed reduction through their CON process, and now there is concern regarding future access. The statutes currently allow for renovation and replacement of a nursing home, but only permit the addition of a new home under limited circumstances like special needs, such as ventilator care. Now, these proposed changes would allow the sector to address geographic needs. We support this change, but do caution that the construction of a new nursing home building is very costly right now, and access to capital for such a project can be very limited. So this may hinder any type of expansion that's expected. Now, regarding Senate Bill 1359, included in this bill is a proposal to add into the Managed Residential Community Resident Bill of Rights the contact information for the Department of Social Services, Protective Services for the Elderly. We support this, but we thought we'd take this opportunity to draw attention to the important work that is done by DSS Protective Services for the Elderly. They perform a critical service for the state's older adults by investigating reports of maltreatment and protecting them from abuse, neglect, exploitation, and abandonment. While anyone can make a report, there are 17 categories of mandated reporters who now are required to report within 24 hours. Just a couple of years ago, 6 additional categories of mandated reporters were added to the statute, which brings it up to the current 17. Protective Services has implemented several initiatives to assist reporters, including an online reporting portal and some training, but we want to be sure that they have the resources and support needed to respond timely to these many reports. Now, I want to be clear, this is Leading Age Connecticut who is asking for this, not DSS Protective Services for the Elderly. They are a dedicated staff who do amazing work, and we want to be sure that they have the resources they need to continue performing this critical function as our state population ages and more vulnerable older adults are receiving services in the community. thank you for this opportunity to testify, and I'd be happy to answer any questions.
Yeah, specifically, I'm curious about, thank you, Mag, for your testimony. In your testimony, you talked about the 15-mile radius issue and just sort of understanding what considerations we should be.
Sure, I'm raising this because it's something that's been in this statute, I think, since 1991, that when you were thinking about adding beds or reducing beds, you were required to do a 15-mile radius as the crow flies, as they say, right, around your nursing home to see how many other nursing homes are in that area. Are they full? Do they have empty beds? And that all impacts what you can do in your own nursing home. So when a couple of years ago, when all the nursing homes were asked to do sort of to take a look at what their bed needs were and to give a plan to DSS, several nursing homes who had never done this before did the 15-mile radius. Just you take a projector with a protect, and do the 15 miles. And they were like, oh my gosh, I didn't realize how many nursing homes were in my area. Nursing homes that are very much outside my service area, right? Over the river, really more attached to one city rather than the other. And yet it very much influences what can be done in your own nursing home. So what I'm asking, I'm just raising this issue since we're talking about the moratorium to say maybe we should consider this piece of the statute next time we take a look at the CON statutes and see if this still, makes sense or applies to the state.
That's a good thing for us to take a look at. And I also know that as the state has pursued rebalancing, we've also seen nursing home closures in many parts of the state. I know that, I don't want to pick on him, but Representative Butler is in the room, and I know that the city of Waterbury has been particularly affected by nursing home closures. One of my communities has been as well. Is that rebalancing split evenly across the state, or it feels like it's concentrated in a few areas? And I didn't know if you had any insight into that.
We put forward a rebalancing goal that just had numbers, right? We want to reduce beds by this amount of number. We want to increase the percentage of people that receive their services in the community by this amount of number. And we haven't really taken a good look at or planned either side. Like, are there enough community-based services in Litchfield County? Does it make sense in in Middlesex County to have this many nursing home beds? Or what? We've just sort of put out the numbers and encouraged people to do their own planning. So now we're coming to a point where we're realizing, wait, we have to take a look at this because it can be very dependent upon what the hospital practices are, the insurance, penetration in certain areas. Are you getting your subacute, short-term care? So, in 1991, the population and the practices were very different than they are now. But the nursing homes were like frozen in time, and they're exactly where they were and exactly what they looked like, give or take a few renovations in 1991. And so you see that has really affected certain areas of the state and certain nursing homes and certain nursing home chains and ownership and nonprofit entities. A lot of nonprofits have had to sell. I represent the nonprofits. They've had to sell. They just couldn't sustain a solo nursing home anymore, which it was vibrant in 1991, but it doesn't make sense. It didn't make sense for them wherever they were. So I think just time has evolved. And the world has changed around the nursing home sector. And so that's why certain areas are affected and or certain nursing homes have been affected.
Thank you for that answer. I see Representative Butler does have a question.
Thank you, Mr. Chairman. And thank you so much for your testimony. The nursing home closings are really, really devastating for communities. Not only for the people who, occupy the beds, it's their families to be able to visit them and not have to travel that 15 miles just to see their loved one, but also the staff that actually work in these facilities. So all the way around, it's been, a devastating event in the state of Connecticut. I would just ask you if, for one, what do you think is leading to all these closings around the state, and that 15-mile radius as the crow flies rule? What would you see as an alternative to replace that initiative? But really, I just like to hear your views on what's what's the genesis of all these closings? Because it's a devastating thing for all the people that I mentioned.
Sure. A nursing home closing is devastating. It can be it's very devastating to the community, to the families, to the people who have called that nursing home home, sometimes for many years. And sometimes we don't think about that when we talk about rebalancing, and we just talk about the need for community-based services versus nursing homes. Nursing homes fill a vital function in the state. We don't depend upon them as much as we did in the past, but there's still a vital need for them. So we need to support them. I can't speak to specific closures because I don't know the intricacies of what was going on there, but I do know that for many years, many nursing homes, particularly my members, were underfunded through the nursing home rate system because we never let the rate system work. And we froze rates for year after year, gave small increases. And so the buildings themselves, you know, it was difficult to, you had to invest in the home, keep up the capital, as well as you had staff you needed to maintain. And then, of course, we went through COVID, which was very costly, and it was exhausting to staff and to those who were managing the nursing homes. So we have these series of events. Fortunately, the state rebased our rates, gave us a new acuity-based system. It stabilized quite a few nursing homes throughout the sector. We're very appreciative of that. We want to maintain those rates moving forward so that the nursing homes we have will remain strong. But nursing home business is very expensive. Particularly if you're running 1 or 2 nursing homes. Staffing is expensive. Upkeep on the building, particularly if it's an older building. And as we just said, you know, after 1991, you couldn't build a new one. So most of them are very old. You know, heat, food, all of the regulations that surround a nursing home and maintaining, you know, it's just an extremely expensive and exhausting business to run. It can be very rewarding. And, you know, people that work in it are just unbelievably dedicated people who are dedicated to caring for older adults and others who are in the nursing home. But it's expensive. And if you have something that there's a very small margin for many of my members, or they're losing money on the nursing home and they have to cost shift. So I think you have to look at it individually, but I think we have to understand that it is not inexpensive to run that business. And particularly if you run it well and you want it to provide high quality staffing and you want to provide high quality food and then just your basics, keeping it heated, keeping it cooled, cutting the grass, it's all just very expensive. So if you can't staff it and if you're losing money on it, I think it leads to decisions that it's better that you leave the business. It used to be that you could sell it. I don't know what the market is right now to sell it. But there is that opportunity also and you've seen that also in parts of the state where nursing homes have changed hands and there's been change of ownership.
Well, thank you for your answer. And we definitely need to do all we can to actually support the nursing homes we currently have. But really, there's some closings, especially the latest in Waterbury, Abbott Terrace, which most of the individuals were actually transferred to Bristol, and I hear Bristol may have concerns as well. So, you know, to move people that far, and then having families have to go that far to visit their loved ones, and to face going through this again is beyond devastating. Well, I just wanted to, you know, actually reinforce your testimony about the cost, the need, and the impact on all them individuals in this process. So yeah, we need to take a look at this to see what we can do. Thank you for your testimony. Thank you, Mr.
Thank you.
Chair.
Thank you, Representative, and appreciate your advocacy on behalf of, particularly of your community, but of all folks across the state. Other questions for Mag? Seeing none. Thank you for your testimony. We're going to see
Thank you.
totally different topic today. We're going to hear from Matt Barrett next. No, it's the exact same topic.
Thank you very much, Senator Lesser, and good afternoon to you and Representative Gilchrist and the distinguished members of the Human Services Committee. I am Matt Barrett on behalf of the Connecticut Association of Healthcare Facilities, which is a trade association of skilled nursing facilities and assisted living communities. I'm pleased to have the opportunity to testify in support of House Bill 7026, an act concerning exemptions or exceptions rather to the nursing home bed moratorium. This legislation, we understand, was introduced at the request of the Department of Social Services Commissioner Andrea Barton Reeves. And I'd like to begin by thanking the Commissioner and the agency for its diligence and careful monitoring of the rising nursing home occupancy percentages and potential access to nursing home access care in our state, noting that 15 nursing homes have closed in Connecticut since 2021, and thousands more beds have been delicensed in alignment with the state's long-term care right-sizing and rebalancing goals. And I also want to acknowledge the leadership. I want to particularly call out Senator Lesser and Representative Gilchrist for their leadership in 2 years ago advancing legislation that established the Nursing Home Excess Bed Capacity Work Group. And I think you'll find, I think you're aware of this, but you'll find it interesting, very relevant and related to the bill that's before the committee, because the working group in 2024, I think it was June 2024, they issued the report after a year's worth of study, and DSS had chaired the work group. Their findings and recommendations specifically included the potential for access to nursing home care issues that were the direct result of the review done by the excess capacity work group. And I've quoted in my testimony, but for emphasis, I quote, "In this regard, the work group recommended continued monitoring of the improving occupancy percentages, both statewide and in particular regions of the state where high occupancy percentages may signal potential access to care issues in the system." In my testimony, it's in italics. That emphasis was added by me. It was in the report that way. Moreover, the Nursing Home Excess Bed Capacity Work Group observed in the report issued a year ago, and again, so on point to the proposed bill before the committee, that a reduction of less than 700 beds from the system would result in a Connecticut occupancy percentage of 90%, which would be among the highest occupancy percentages in the nation, almost 10 points above the current national average. And so what is signaled here is a access to care issue, and that the commissioner has very boldly, and frankly, I'm grateful to her for putting forward a bill. It speaks for itself. She's seeking an exemption from the longstanding nursing home bed or moratorium because there's an access to care issue that is signaled by these occupancy percentages, by the closures that have been mentioned by previous speakers.
Time
And
is
for
complete. Please summarize.
Absolutely. And though for those reasons, we're in strong support of House Bill 7026. And again, thank you so much for the opportunity to testify.
Thank you for testimony, Matt. Good to see you. Are there specific areas that you would identify as being particularly important in terms of access issues?
I would, the report that accompanied the legislation identified several areas of the state, and I apologize for not having it on the top of my head, but there are particular areas of the state, and I'm going to get to that information to the committee right away. If it weren't included in the DSS testimony, I know it was included in the backup material associated with the DSS proposed bill, but there are several areas of the state that are of particular concern. But I would sound the alarm bell for the entire state of Connecticut, and here's why. When you look at the analysis that shows us at 88% occupied, and you take out, as we have done some reviewing of the bottom 10 nursing homes, the lowest occupied nursing homes out of this calculation, you'll find that Connecticut is well above 90% occupied, extrapolating those other facilities out. That is effectively full. that is, maximum occupancy is never 100%. And in fact, we should be really grateful that we weren't 95% occupied when the COVID-19 public health emergency hit, because there wouldn't have been the capacity to handle the hospital discharges that were so important back then. But we're effectively full now. And that the excess bed capacity work group that, again, the Human Services Committee was so instrumental in moving forward. And these recent findings leading to the agency itself recommending an exception to the moratorium are telling us, I think, in loud and clear colors, we have pushed this envelope very far. And that Mag Morelli, my dear colleague, alluded to it earlier, we've completely inverted the system. 75% of our dollars in care are being spent now in home and community-based service settings. That's appropriate, and we should all be really proud of that. But I think we're at the point now, perhaps call it a tipping point, where the entire state ought to be paying very close attention to this issue. And perhaps I'm saying that and don't need to say it, because this bill is before the committee recommended by the agency.
One of the arguments that we'd heard before was that sort of separate from the number of beds that it's in Connecticut, there's a question of the necessary capital upgrades to existing facilities. And, Representative Gilchrist and I have tried over a number of years to try to get air conditioning into nursing homes and make other necessary facilities upgrades. Is there a connection between the bed moratorium and then investments by existing operators into their facilities? And if so, what's that connection?
I think what is connected here is, and they're very well may be a very direct connection that I'm able to see right at this moment. But what we've seen, and I agree with Mag Morelli also, that we're not often privy to all the exact details of why a nursing facility is closing. And however, there are public documents associated with the closing that the owner or operator has to file. And in some cases, we do see clearly that in the case of a Farmington nursing home that closed last year, they indicated the cost of the roof repair was nearly, I think, $1 million. And that had been something that was not something that they could have afforded over the years. So there was foregone maintenance on it. And that was a factor in terms of why that nursing facility had made the determination that it should move forward with closing the facility. I think I think you'd say this generally, that, for many, many years, and forgive me if I sound like I'm going to be using guardrail type language, but year after year, the rate setting included artificial cost caps. We used to refer to them as stop gains and stop losses in the system, so that the inflationary increases and cost increases that would have otherwise flowed to the nursing facilities were basically lopped off at the top. An example of that is here again in the 2-year budget that's now before the Appropriations Committee, where we're removing inflationary adjustments once more. I think maybe 20 years in a row. But anyway, this is a cost-based reimbursement system, Senator, and so that when you're not paying for the cost of care, this is definitely eroding not just the operational stability, but the underlying infrastructure, the roofs, the air conditioning. 74% of nursing home residents are Medicaid recipients, a very sensitive dial between the Medicaid rates and their ability to make these changes. And so that is lurking nearby, all this instability and closures. But I can't say for sure that is the dispositive thing that explains every single closure that we've read about in the newspapers over the last year.
Okay, thank you for your testimony. Representative Johnson.
Thank you so much, Mr. Chair, and thank you for your testimony, Jadika. We're still here.
Hi, Representative Johnson.
Hi, I just wanted to just check in with you on the. I'm pleased also with the modified bill presented by the Commissioner of Human Services to make sure that the we don't limit access to nursing home care now, and we have some exceptions to that rule. I was just wondering what your opinion was of the small called greenhouse nursing homes, and how you thought that might fit in with the current systems we have.
Well, I hold it in very high regard, but I want to state in real clear terms, I don't think it's a reality that's on the horizon in Connecticut anytime soon. And that the model is very expensive and serves very few recipients. And so, the cost of, building an infrastructure like that has only been successful in my research in the nonprofit systems where they relied on, very considerable foundation and private donations to subsidize the costs that have made it possible. And so for your typical nursing facility, perhaps in an urban setting that has infrastructure needs, I hope it's really clearly understood that the small house model is not going to address that issue in any way, shape, or form. And that if it has any possibility, it would be my concern. Now, I can't say with any certainty, but it would be my concern that that's a nursing home that's in the suburbs and not necessarily addressing the issues of high Medicaid nursing facilities. Now, I don't say that in the sense that we shouldn't try to move forward with these small house or greenhouse models. I think we should. But it's the reason why also in my testimony that whereas the agency has indicated that they would like to have a preference for small house nursing homes, I've added that we should have a preference for nursing homes that advance single resident rooms that is much more affordable and much more likely and advances infection prevention control issues that became very apparent during the public health emergency, and that many more nursing homes would be able to move forward with those kind of bed additions versus the small house model. So I think it's a great model, but I just don't think it's a realistic one, and I don't think it's going to address the broader needs of our aging infrastructure in Connecticut, Representative Johnson.
Thank you for that. I think that having a person have one room, and I think that's probably one of the things that maybe people are hesitant about when they go to a nursing facility, is that they have to share the room for a long period of time with somebody else. And I think that having their own room is probably a really positive thing and something that maybe we should take a look at as well. Thank you so much. Thank you, Mr. Chair.
Thank you, Representative. Okay, anyone else? Seeing no further questions, thank you for being here this afternoon. Is Jared Bruzis here, followed by Sheldon Tao?
I sure am, thank you. Good afternoon, Senator Lesser, Representative Gilchrist, and other members of the Human Service Committee, and our good friend, Representative Larry Butler from the great city of Waterbury. My name is Jared Bruzis, a member of the Connecticut Food Share Board of Directors, and serve proudly as the Chief Impact Officer for the United Way of Greater Waterbury. And as a former food pantry and soup kitchen provider, I've witnessed firsthand the deep impact that food insecurity has in our community. And I'm here today in strong support of the great people in our community who are 1 in 8 residents or 1 in 6 children facing food insecurity here throughout the state of Connecticut. So I am in strong support of HB 7021 to increase funding for the support of the Connecticut Nutrition Assistance Food Program, also known as CTNAP. Now, we've had a lot of other testimony this afternoon, and so I won't go through some of the data and talking points that some of my colleagues and fellow board members or Jason Jakubowski had shared to spare this committee from a little extra time with all the great work that you guys are doing here. But I also want to, come from a perspective of what it's like to be a provider, and also what we're seeing. I'm sure Rep. Butler would share with you, as we've both seen in the great city of Waterbury, the growing lines of the many folks seeking food, whether it's through Connecticut Food Shares, mobile food pantries scattered throughout the city, or the food pantries that our United Way supports through our Food Resource Collaborative, with over a half dozen members participating. The reality is every single day that our soup kitchens and food pantries are open, the long lines continue to grow. But the challenge is resources are stretched even more. This $10 million investment that we're looking for support on will ensure that folks have access to healthy, nutritious food. We as United Way of Greater Waterbury believe that food is medicine, and ensuring people, especially some of the most vulnerable folks in our community, whether that's young children over the summer that don't have access to regular food that they would be getting in schools, and or our seniors, access to healthy food is vital. Again, food is medicine, and for Connecticut Food Share, who is at the front lines of providing the majority of food for soup kitchens and food pantries through its vast network, this investment is vital. Difficult to hear the fact that Connecticut is only giving less than $1 million for healthy food, where our friends in the tri-state area are giving millions and millions of dollars of resources to ensure that folks in their states have access. But we here in Connecticut, we're not. To me, that's extremely problematic. And we as Connecticut, we know that we can do better. We must do better. And I strongly urge the great bipartisan support for this bill, 7021. I ask and urge you for its passage, and look forward to ensuring that through your great work here and passage of this bills, the bellies of our children are full, and we're supporting some of the most vulnerable in our community, the elderly. Thank you.
Thank you for your testimony, and you gave Representative Butler a shout out, and I think he wants to jump in right there. Representative Butler.
Thank you, Mr. Chairman. And I just wanted to speak to your perspective that you shared with us. And we have food deserts all around the state, but we have agencies that are trying to address this. We just need to give those agencies more funding and resources to be able to reach out and actually provide that quality food to our communities. So I certainly agree with you in your perspective and your testimony. Thank you very much. Thank you,
Pleasure.
Mr. Chair.
Thank you, Representative. There are questions or comments? Seeing none, thanks for being with us today. Next up, we have Sheldon Taubman, followed by Carrie Dyer.
Good afternoon, Senator Lesser, Representative Gilchrist, other members of the committee. My name is Sheldon Taubman. I'm the litigation attorney at Disability Rights Connecticut. We are the protection and advocacy system for Connecticut, serving individuals with a full range of disabilities. I'm here to testify today about the impact of SB 985 on people with disabilities. The 2011 decision to jettison managed care organizations was really not that hard to make because Medicaid run through unaccountable insurance companies was the source of major access problems for Medicaid enrollees statewide and major headaches for their providers. And more to the point, it was expensive, not just total outlays, but also the high administrative costs coming off the top. Following the complete conversion to administrative service organizations in 2012, no action was taken to remove the existing statutory authority that broadly allowed DSS to contract with MCOs. Particularly, Section 17B 28B and 17B-266 are like loaded weapons lying around for this governor or the next to use to go ahead and return to that failed system. And should that happen, there's no question that people would be harmed once again, and this would be particularly the case for people I represent, people with disabilities on Medicaid, because they have higher than average healthcare costs and therefore would be particularly harmed by profit-motivated denials of care under that insurance company run system. 985 would play a key role in cementing the successful move away from a system that has not worked in the past. However, the bill as drafted adds sections that would require only 2 committees to review a proposal to return to that system. It will be reasonable to require the whole legislature to act on it, just like the whole legislature did pass legislation to require or allow contracting with ASOs. The commissioner, I heard her testimony today, she does not want even 2 committees to review any such proposal. And the argument is that we don't need it and that the DSS, quote, remains committed to ongoing transparency and discussions. And also, quote, there are already many forums for these conversations, such as MAPOC. I'm sorry to say that the department has not been transparent. All the various proposals to turned to, for example, capitation in primary care was done through a select group of people chosen only by DSS. It was not run through MAPOC. The AHEAD proposal was moved forward with an application with CMS in March of last year. It was granted in July. They never told the MAPOC. So there's a real lack of transparency. The other argument made was that we already have legislation that requires state plan amendments to go before committees of cognizance, and that this would require state plan amendment. However, the statute cited 17B-8 is very, very narrow. There's very few state plan amendments that have to go before committees of cognizance. This would not qualify. So the statement that any significant SPA would go before committees is not correct. I also want to note that her comments today, the commissioner's comments that—
Your time is complete. Please summarize.
I will. If we were to go back to the proposals to go to capitation and various kinds of payment reform, putting financial risk on providers, should not be subject to such limitations. It's sort of the opposite. Those things should also be subject to review by committees of cognizance. And lastly, in terms of the other provisions in the bill, which change the MAPOC, no objections to those provisions. However, in order to be consistent with the federal regulations governing these kinds of committees and to be consistent with the existing statutory authority for the MAPOC, there's language at the back of my testimony that would make it clear that the MAPOC also has jurisdiction over any proposed changes to the Husky Health Program in the form of payment or delivery reform, which could impact Medicaid enrollees, and also a statement that any changes before they're made have to go before the MAPOC. I think most people would agree with that. Thank you very much for the opportunity to testify before you today.
Thank you for your testimony, Mr. Taubman. Just with respect to the current oversight powers that this committee has, you're suggesting that not all SPAs come before us. When do SPAs come before us? When do they not? Do you know?
Yeah, so the statute is kind of odd language. It's 17B-8. It provides that all waivers have to go before the two committees of cognizance, yours and appropriations. But on SPAs, this is what the exact language reads. SPAs have to go before those two committees for, quote, any proposed amendment to the Medicaid state plan to make a change in program requirements that would have required a waiver were it not for the passage of the Patient Protection and Affordable Care Act. So that's very confusing. It's basically saying it's this very narrow slice of situations where in the past you had to get a waiver, and then under the Affordable Care Act, you didn't have to get a waiver. And there are a few things like that. And if what you're doing is one of those little things, then yes, the state plan amendment has to go before the two committees of cognizance, but not otherwise. For example, I just learned from testimony before the Appropriations Committee that the department submitted a state plan amendment, I think it was 2 weeks ago, related to weight loss drugs, which has been a hotly contested issue, non-compliance. And that was not submitted to your committee or to Approps, and there's not going to be a hearing on it. So the vast majority of state plan amendments are just done by the department without such review.
How often are state plan amendments submitted? Because I feel like in that particular case, that was there seemed to be, well, let me ask a question that I would like to know the answer to that question, but I also want to know, my understanding is that every time a medication is approved by the Food and Drug Administration, it must be covered by Medicaid, with the exception of hair loss and weight loss treatments under federal law. And if that's the case, does every time the FDA approve a medication, we have to file a state plan amendment, or is this a little bit more irregular?
I can answer all of those questions. It is true that under federal law, federal Medicaid law, anytime the FDA approves any medication, it must be covered for Medicaid enrollees, period, with the exception of certain categories. And you've identified two of them, and infertility treatment and cosmetics. So these narrow areas are ones where the state is given the choice whether to cover it or not. The question about whether you need a state plan amendment, actually just got the answer to that from the head of pharmacy at DSS at a hearing the other day, administrative hearing. The answer that he provided is that when the FDA approves a new drug in those mandatory categories, which is almost all categories, you do not need a state plan amendment. When the state, however, is choosing to add drugs which were optional, that does require a state plan amendment. And then in answer to your first question, it's routine. State plan amendments are submitted all the time. It's an extremely large volume if you add up all the amendments.
So you're not suggesting that, although I will certainly never do anything to try to limit the power or oversight powers of this committee or the legislature as a whole, but you're not suggesting that it would be feasible for the legislature to hold a hearing on, all state plan amendments or have the requirement to approve all state plan amendments, right? That would not be feasible. Is that your?
I think that's probably right. Others might disagree on that. I think that's not feasible. However, as I alluded to previously in response to the commissioner's suggestion that she should have unfettered ability to do major changes in payment reforms of the Medicaid program without running it by committees, maybe what needs to be looked at is to suggest that statute that requires state plan amendments to go before the committees should be broadened to include certain other areas, such as any major, delivery changes or payment reform. I think that those would be appropriate to run before committees. But yeah, I mean, to say every single state plan amendment has to run before the committees would be inappropriate, perhaps, in terms of the burden. But certainly what this bill is about, which is a return to putting financial risk on insurance companies so they have a direct financial incentive to deny care like they used to, you would absolutely want to. And our position is that it really should be, this is something that really would benefit if it was the whole legislature, not just two committees, but, certainly two committees. But now that we're talking about these other major changes, it may be time to look at expanding maybe as you've drafted it, two committees reviewing any state plan amendments that involve those kinds of issues.
Thank you for your testimony. Are there other questions or comments from members of the committee? Seeing none, thank you very much.
Thank you.
Next, we have Carrie Dyer, followed by Quinn Genetti.
Good afternoon, members of the Human Services Committee. My name is Carrie Dyer. I am the Chief Executive at Reliance Health. We are a mental health nonprofit provider serving all of Eastern Connecticut. We have 18 physical sites. We have approximately 250 employees, and we serve about 1,000 people a year. We contract with both DMIS and DDS. So some of the answers to the questions we have about payments, it's different depending on who you work with. So my purpose of being here today is to comment on Senate Bill 1358. It's a continuation of the conversation we were having last year when we were talking about indexing nonprofits. It goes back to 2007. Prior to 2007, our contracts got intermittent cost of living adjustments. We don't know what they were based on. We don't know how they were determined, but they happened until 2007 and then they stopped. It was possibly just someone's good conscience to have that in mind for us, that we needed those cost of living increases. Fast forward from 2007, a lot changes. And we subsequently in 2017 had a 5% cut and then started to see some changes again in 2020 where we were able to see some small adjustments and some recognition that all of these things had happened over time. So from 2007 until 2020, a lot of things changed. We went from flip phones. We're not just talking about things like inflation, we're talking about different expectations and new expenses that didn't exist in 2007. We were not talking about cybersecurity insurance in 2007. We're talking about that now. So there are a lot of different things, wages, benefits, vehicles, fuel, all the things that we're all rattling off, and you'll be sick of hearing it, but you need to hear it because it exists. It exists for the food pantries, it exists for the nursing homes. You're hearing this theme because it's true for all of us. So the idea of building and indexing and having something concrete is real and it needs to happen. The other aspect is that our contracts ask us to do a specific activity and we are not able, if the funding decreases due to things like inflation, we are not able to adjust what we do in terms of capacity. The demand is still there and we have made the commitment to provide that service. So if we're providing a service of, let's just make up a number, 100 people that we're going to do outreach with for our homeless team, we can't reduce that number because our ability to spend dollars is going in other directions. That's a big issue. These are not projects. We're working with people and we're building relationships with people, and those things take time. And they take people who have a compassionate heart, who want to work in this field, and not being able to keep up with pace with inflation. Minimum wage is indexed and our wages are not. And we are going to run up against some true problems if they bump up against each other. I just think that there needs to be some sort of concrete mechanism.
Your time is complete. Please summarize.
Thank you. The concrete mechanism is what we need. We can't just trust that there will be something put in place. There needs to be something that we can rely on. Not being able to be reliable is an issue where we're looking for stability, and we need to then provide stable services to our most vulnerable. So thank you for your time.
Okay. Thank you for your testimony. Appreciate your advocacy on behalf of your organization and your plans. Are there questions or comments from members of the committee? Seeing none, thank you. Next, we have Quinn Janetti, followed by Sarah Egan.
Good afternoon, Senator Lesser, Representative Gilchrist, distinguished members of the Human Services Committee. My name is Quinn Janetti. I'm a registered voter here in Manchester, Connecticut, and I would like to thank you for the opportunity to testify on House Bill 7023. I work as a project manager and a peer support specialist for a DEMIS Young Adult Services program. This project is an online platform called the CT Support Group that offers connection, free peer support, and community for teens and young adults all throughout Connecticut. Peer support is rooted in shared lived experiences. It is collaborative, non-hierarchical, and built on mutual trust. The first thing that I say to people that I meet is, I don't want you to trust me off the bat. We are going to learn what that looks like and build that trust together. Peer support is not about advice or control. It is about curiosity, consent, and choice. Participants define their own goals. Peer supporters walk alongside them to move towards achieving those goals. When we operate from fear, we risk exerting control rather than fostering that trust. Authentic peer support ensures that participants always have the opportunity to consent and to choice about what they discuss, what resources they engage with, and more. Legislation involving peer support must be based on an unambiguous understanding of this role. Without convening the task force to study peer services, without centering the voices of peer supporters, any policy put forth in Connecticut risks being misinformed and ultimately ineffective. I fully support expanding access to peer support services, including through Medicaid reimbursement. However, it is essential that legislation includes clear definitions of peer support, fidelity measures for peer support specialist roles, and it also incentivizes employers to pay peer support specialists a living wage. Our work is generative, our work is transformative, and it is worthy of investment. Thank you for your time.
Thank you for your testimony and for reminding us of the importance of centering peers and hearing about how best to do this. So what specific issues do you think need to be worked out in the task force prior? Obviously, we've been trying to figure out how to do this for a number of years now, and we've not succeeded. What specific issues do you think need to be worked out, in a task force environment prior to implementing something along these lines?
So prior towards moving towards something like Medicaid reimbursement, I think the legislature really needs to work on putting statutes in place that define what peer support is, so that it is unambiguous, so that people who are stepping into these roles understand what is expected of them. And I also believe that before moving towards reimbursement, we also need to secure existing funding for peer support and not just move towards a reliance on Medicaid reimbursement. I think that puts us into a dangerous territory in terms of being able to pay peer supporters livable wages. And so without securing that funding first, without ensuring that grants that are allocated towards peer support services here in Connecticut, I really do fear that people are not going to be making living wages, and they will not stay in these roles.
I understand the first part of what your answer. I don't understand the second. So right now you're not getting Medicaid. So if we were to provide additional funding to support peers, I don't understand how that could possibly do anything but provide more funding rather than cut wages. But obviously I'm missing something, so that's why I'm
Sure. So we've seen this. There is a precedent that when states move towards using Medicaid reimbursement for peer support, that existing funding for peer support often gets allocated elsewhere because of the new source of funding that is available through Medicaid. And so we've seen this happen in other states like Rhode Island, where the existing funding that is for peer support services throughout the state does not get protected. And so once it gets allocated elsewhere, we're not seeing more money for peer support. We're seeing a shift in where that money is coming from.
Okay, I hear that. But we have a limited purview in this committee, right? Sure. And so there's an overall, the Appropriations Committee will be able to take a look, bird's eye view of the state budget. Sure. We don't have that here. We have oversight over the Department of Social Services and Department of Aging and Disability Services. Many of us know or have an idea of what DEMIS, Department of Public Health, are doing with their funding, but we don't control that. Obviously, you're worried that someone in this building will see, so we're paying money for peers and we won't have to fund it elsewhere. But those two things are not directly connected, and you may or may not lose that funding anyway. It's certainly possible somebody could cut. We get into right now our fiscal condition's okay, but our fiscal condition could change overnight, and we could run into funding challenges, and that funding could be cut for reasons completely unrelated to whether or not we stand up a Medicaid program. The advantage to Medicaid, of course, is that we do get extra funding. We got a federal match,
sure, which
we're not currently receiving, I think, though you could correct me. So I guess I don't know what kind of assurance we could give, right? If we were to say, we promise, the chairs of the committee, the rankings, we promise not to cut that program. That's really not up to us, and it's hard for us to guarantee what the appropriations chairs, the leadership could or couldn't do. And so I don't know how we could possibly answer that question, since that's beyond our purview.
Right. I believe engaging the task force that never happened, the task force that was supposed to be convened in 2021, is really the pathway towards looking at the effectiveness of peer support, looking at the offerings of peer support here in Connecticut, and then engaging the community about viable ways to ensure that folks who are in these roles are making livable wages. I think until we hear the voices of the community and we engage the folks who are familiar and understand what peer support is and what it looks like, and then put that into statutes to define those roles to ensure there's no ambiguity about them. I think moving towards Medicaid reimbursement, I think we're putting the cart in front of the horse, so to speak. I think this is something that needs to be fleshed out elsewhere in statutes and the legislature.
Thank you for that answer. And I see Representative Dathan, who's online, has some questions for you.
Sure.
Thank you so much for your testimony. Just trying to clarify, so the peer support money you get now, is that through block grants through DEMIS?
We are currently funded through DEMIS's department, the Young Adult Services Division. So that is where all of our money comes from for the project that I currently work for.
And so presumably you don't just have Medicaid patients, you have our Medicaid clients, you have a mixture of private pay, insurance reimbursed services, as well as Medicaid patients. Is that correct?
The project that I work for offers free peer support. So we do not collect any insurance money. We do not have any private pay. This is available for all teens and young adults throughout the state of Connecticut without regard to their insurance status or ability to pay.
Right. So that's my point, is you're servicing a greater population than just Medicaid patients or Medicaid recipients, I should say.
Right. I don't know the insurance status of any of the
Right.
folks I support. Yeah.
Yeah. So presumably, your services that were being contemplated here under this bill is for Medicaid recipients to have peer support services outside of residential setting in the community. I think this is just another offering of services, peer support services to a greater amount of people, particularly people who might not be close to where, you know, the DEMIS grants are going to.
Yeah, I think that, you know, that makes total sense. I really just want the definition of peer support to be, you know, put into statutes so that we know that the folks who are offering this understand what is expected of them. I think, you know, part of what we're seeing now is state funded programs are very supportive of, you know, hiring recovery support specialists. And oftentimes when they are hired, when folks are hired into these roles, they are supervised by clinicians who fundamentally misunderstand what peer support is. And so oftentimes these folks get relegated to roles like providing transportation for clients and they're not able to fulfill the role that they were hired to do, which is to use their lived experience to connect with other people. But I think until we have this sort of overarching understanding and clarity around the role, you know, pushing, you know, towards Medicaid reimbursement is, you know, I think this is coming a little bit ahead of, you know, the conversations that we should be having about this service and the roles.
Well, just for the avoidance of doubt, Medicaid does reimburse for peer support services in and mental health counselors within the residential setting. And so it's defined for residential patients, but where we're not, so there is a definition. What there isn't is their ability for the state to utilize federal dollars to help and broaden the amount of peer support services that are offered in our state. And I don't think, you know, it is something that, you know, we should only say, oh, you know, if you live near one of these organizations that provide peer support services, then you're able to get it, you know, no questions asked. But there is a huge amount of populations out there that are Medicaid recipients that are on waiting lists to get mental health support services and not able to get them. And one of the key aspects, and you know, we hear it all the time from folks from SAMHSA and other organizations, that these peer support services are vital and they can't necessarily be found elsewhere, but it is an essential role within the whole care team as part of, you know, treatment. And so it is defined for residential. It's just not defined for, we just don't offer the reimbursement to Medicaid patients. And so I think that's the sort of issue that we're hearing here. It's not just, you know, you get your block grant and then you're fine. We have a whole group of people in our state that don't have access to those services, and there's a huge need for them. And there's a huge discussion that we need to increase them. And I think, you know, it's from what, you know, it sounds like you're saying is we should just limit it to folks that are sort of get their block grant from DEMIS. And that's, why we're putting this forward, is we need to make sure that we expand them and we utilize the federal dollars where we can. So I appreciate your testimony. The last thing I wanted to ask, as part of your, your organization, are you having to allocate like time, where you would say that you're spending so much time doing peer support services and so much time doing group therapy? And I'm just wondering, would there be some sort of hesitance to do this bill because you would have to maybe be more accountable for your hours than you do have to be accountable under your DMIS block grant?
That's not something that, that worries me. That's not something that, I'm considering. I do think that definitions of the role for, quote unquote, peer support specialists or mental health counselors within residential settings is very different, I think, than the recovery support specialist role. And I think that distinction is very important. I think mental health counselors often get integrated into clinical teams in ways that peer support specialists do not. I think the distinction outside of residential settings of peer support versus clinical offerings is a lot more distinct. The line, I think, is clearer. I would like to see that reflected in statutes. And those are my hesitations. The billing of Medicaid, I would love to see the expansion of peer support. I want more people to be able to access that. And I also think that before we have clear definitions and understandings of what this looks like outside of residential settings, moving towards, being able to have access to Medicaid reimbursement and those federal dollars feels like a little, this is coming, I think, just a bit too early. I would really like to see, a little bit more work done with the community before we move in this direction.
Yeah. Okay. Well, I appreciate your opinion. Thank you very much, Mr. Chair.
Thank you, Representative. Other questions, comments? Seeing none. Thank you very much for your testimony. Next, we have Sarah Egan, followed by Tracy McDougal.
Good afternoon to the committee. My name is Sarah Egan, and I'm the Executive Director of the Center for Children's Advocacy, a nonprofit legal rights organization for low-income children throughout the state of Connecticut. We're offering testimony today in support of 7023, the act concerning Medicaid reimbursement for substance abuse coaches and mental health counselors under a peer support treatment model. I think it's a critical addition to the Medicaid continuum of care. I did understand the concern around funding from the previous testifier. But we have a dearth of substance abuse treatment services, and peer support is recognized as highly effective and necessary. I did want to point out that I think it's going to be really important to make sure that we have targeted peer support services for youth and young adults, including youth under the age of 18. Some states cover peer support services for youth. In fact, I think over a dozen do at this point, and there is CMS guidance on that. So maybe there's an opportunity to look at language to make sure that the peer support services are defined in a way, the covered peer support services are defined in a way to make sure that they can serve adolescents, including minors, and 18 to 21 year olds, of course, would be covered. This is so important because I wanted to highlight that for 18 to 21 year olds, overdose is the leading cause of death in Connecticut by a lot. So in a recent 4-year period studied by the state, there were 110 recorded overdose deaths of youth age 18 to 21 in a recent 4-year period, which was far and away the #1 cause of death for this age group, followed by suicide, for which substance use is often a factor. We have a dearth of services for adolescents, including no inpatient substance abuse beds covered by Medicaid right now in the state of Connecticut, which is a problem, which we know OPM and DSS are working on, but it is a problem that has persisted for some time without providers in the network. So can't have a dearth of services for adolescents and then have the #1 cause of death for older youth be overdose. So we need an urgent solution to this problem that goes broader than the bill, but I think it's another reason why enhancing services for this population are really important. And I would add that for kids, they have a broad entitlement under federal Medicaid law to medically necessary services to ameliorate any diagnosis, including substance use disorder. So I appreciate your raising this bill. I think it's very important and timely. And that's it.
Thank you, Sarah, for testimony, and just, trying to understand the concerns that folks have. First of all, I agree with you that, we keep arguing about this. This is not my first support hearing, and it seems that folks have been at loggerheads for some time about how to proceed. And the consequences, the real human toll, has been staggering because we are not meeting the needs of folks who are, clearly in need in every community in the state. And we have to get through the politics to solve the issue. But understanding, I think the concerns about it are we have to sort of figure out who is a peer and who isn't, because otherwise anybody could just be a peer, and then there's no, I don't know if it's consumer protections or if it's cost containment, whatever you want to say the issues are. Do you have any thoughts about how to sort through that without slowing down the process? Because we need to do this. We need to figure out how to support more access to care for the residents of the state. So how do we do that without,
Yeah.
how do we solve the issue while also not just saying, come back next year, we'll figure it out? And
Right.
I've been doing this for some time and we don't seem to ever figure this out.
Well, off the top of my head, I mean, my answer would be, I'm not sure if I'm missing something, because I don't think we have to reinvent the wheel on the definitions, because there are other states that provide this coverage. And for peer support, and peer support for substance abuse services, or who are using peer support in other contexts, right? So we know many states provide peer support coverage in their state Medicaid plans. Just thinking about behavioral health, the context of behavioral health, Massachusetts Medicaid plan covers family partners, which is a version of peer support in the children's behavioral health field. So, so I'd have to think a little bit about, is there language in the bill referencing accepted definitions? I think there is, to a large degree, that I think could ameliorate some of the concerns. I was hearing more the concern about if it's grant funded now, right? And we hear this concern in the children's behavioral health side all the time, right? The Medicaid rates for certain services are inadequate, so they're funded through a blended rate of DCF block grant funding or contract grant funding and Medicaid. And then if it only goes to Medicaid, how does that impact? So I understood that's part of what I was referencing. I understood that concern because we definitely have that on the children's behavioral health side too, right? That Medicaid's not an adequate enough payer to cover the cost of delivering the service. So that was the concern that I heard from the previous testifier, that I think is something to think about in terms of what are the strategies to ensure adequate funding for the covered service and access to folks who are not covered by Medicaid. Ideally, if you have an essential service, if the state identifies an essential service in the continuum of care for a population, i.e. people who need intervention around substance use disorder, then you want to look at strategies to make sure that that service is available to people regardless of payer, right? So, and Medicaid being one, but grant funding being the other. So they'd have to kind of be tied together to make sure anyone had access. So that was my only comment about that piece of the testimony.
Thank you. Other comments or questions, members of the committee? Seeing none, thank you for your testimony.
Thank you.
Next, we have Tracy McDougall, followed by Nathaniel Arroyan.
Hi there, I'm Tracy McDougall. I work for the Connecticut Farm Bureau. I'm their executive director. We're a nonprofit membership-based organization that advocates for agriculture in the state. I'm here to testify in support of the bill concerning funding for nutrition assistance 7021. You probably all already know this, but our Connecticut farmers take a lot of pride in producing locally grown food for our residents and friends and neighbors. And farmers are pretty generous when they see a person in need. They are apt to act on it. In fact, this past year, Connecticut farmers donated 310,000 pounds of food to Connecticut Food Share. So we are active partners with that organization. And I really thought the Connecticut Food Wholesale Distribution Network doesn't get enough credit for the donations they make to Connecticut Food Share. 70% of the food that's donated to Connecticut Food Share comes from distributors at the wholesale level, farmers, Cisco, grocery stores. So it's a very generous network of businesses and who support that. So only 1% of the food that comes donated to Connecticut Food Share is purchased with state funding. And we'd like to ask that the state partner with our farmers and our food distribution network to help make sure that there's enough food there. As you might imagine, we're particularly interested in this bill because it would require that about 15% of the funding be used to purchase food from Connecticut farmers. So it seems like a win-win for everybody, and we ask for your support.
Thank you very much for your testimony. Are there comments or questions from members of the committee? Yes, Representative Shea.
Thank you, Mr. Chairman. Tracy, thank you for sharing the information with the committee regarding, first of all, I appreciate everything that all of our Connecticut farmers do and want to help in any way possible to help keep them here. But the information that the amount of what they are donating to the Connecticut Food Bank, I had no idea. So in relation to the bill that you're talking about, information like that is important. I think just in general for the public to know, and I agree with you. I think that should be pushed out there more. Because, it's not just summertime when we have the farmers markets and people are interacting directly with a lot of those farmers. But what this bill in particular will do in terms of helping people throughout the state of Connecticut. So thank you.
Great.
Thank you for being here and look forward to continuing to partner with the Farm Bureau.
Thank you.
Next, we have Nathaniel Arroyan, followed by Ellen Andrews.
Good afternoon to all the members of the Human Services Committee. My name is Nate Arroyan. I'm a social work graduate student at UConn, as well as a registered voter and resident of West Hartford. I'm here today as an advocate for families across Connecticut who are struggling with an overlooked yet essential need, diapers, as many have testified here today. I urge you to support Ray's Bill number 6937, an act concerning Medicaid coverage for medically necessary children's diapers. As of right now, I am not a father, but I do plan to be. I imagine myself in the position of thousands of residents in Connecticut who are working hard, supporting their families, and saving up for home. At times in my life, I've worked multiple jobs at once. I know what it feels like to be exhausted and still not be able to pay the bills. When I think about the future that I want my children to grow up in, it's in a state that helps people when they need it. It's a state that supports the American dream that we've all been sold. But the cost of living is too high. The barriers that families face just to meet basic needs are overwhelming. Diapers are not a luxury. They're a basic health necessity, yet thousands of Connecticut families are forced to choose between buying diapers, paying for food, rent, or utilities. Parents right now have to make a decision between diapers for their kids or dinner tonight. This is reality. This is a reality that affects nearly 50% of families with young children in our states. When families don't have enough diapers, the consequences are devastating. Babies are left sitting in soiled diapers for extended periods, leading to severe diaper rash, painful UTIs, and even emergency room visits. Avoidable medical issues that drive up healthcare costs for everybody. The stress of diaper need is so profound that it has been linked to higher rates of maternal depression, even more so than food insecurity, which is also a pervasive issue in this state. What happens when a parents can't send their kid to daycare because they don't have enough required diapers? They miss work, they miss school, they lose income. Families are already struggling to get by and are pushed further into economic hardship. Studies show that this issue alone can cost a working parent up to $6,000 a year in lost wages. Raise Bill number 6937 is a simple, compassionate, and cost-effective solution. Other states like Tennessee and Delaware have already taken steps to address diaper need through Medicaid, recognizing that prevention is far less expensive than treatment. I understand past concerns about cost, but consider the cost of inaction. Preventable illnesses, ER visits, missed work days, the mental health toll on struggling parents. Providing Medicaid coverage is not just the right thing to do, it's a smart investment in public health and economic stability. I ask you all as legislators and as human beings to stand with Connecticut's families. Let's give our kids a healthier start in life. Let's ease the burden on parents who are doing their best. And I wanted to say thank you for your time and opportunity to speak. And I urge you to support this bill, number 6937. Thank you very much.
Thank you for your testimony. Representative Gilchrist would like to say a few words.
Thank you, Senator. Thank you so much for being here, Nathaniel. And it's always nice to see a fellow social worker. Good luck with your studies and thanks for your testimony.
Thank you very much.
Thank you for your testimony. Okay, next we have any other questions from members of the committee? Seeing none, thank you very much. Next we have Ellen Andrews, followed by Janet Alfano-Stolp.
Great, thank you. I am Ellen Andrews. Good afternoon. It is a sort of shady sort of afternoon, but Ellen Andrews, I'm the director of the Connecticut Health Policy Project, and I want to thank you for the opportunity to express our strongest support for SB 985. Since 1999, the Connecticut Health Policy Project has worked to expand access to high-quality, affordable health care for every state resident. Since private insurers or managed care organizations left Connecticut Medicaid in 2012, we lead the nation in both cost control and access to high-quality care. A very efficient program that almost 1 million state residents rely on for their health care would be at grave risk of failing both members and taxpayers if we brought back MCOs. Legislative approval of major changes to our successful Medicaid program is critical to ensuring that we can maintain that progress and meet future challenges. Since MCOs left Husky, our per member costs are lower than and rising more slowly than other Northeastern states, not just the US average. We spend only 22% of our state budget on Medicaid, well below the US average of 29.6, almost 30%. That efficiency frees up $4 billion in our budget for other Connecticut priorities. We are outpacing other states in terms of quality as well. Just one study published last year found the rates of early stage cancer diagnosis and survival among Medicaid members were substantially better in Connecticut without MCOs than in New Jersey, a demographically comparable state that still has MCOs. Rates were comparable between the two states until 2012, but when Connecticut removed MCOs from our Medicaid program, our rates of both diagnosis and survival, people living past cancer, improved. New Jersey's Medicaid rates did not change. We also lead the US in embracing innovations because we don't have middlemen MCOs in the way. So none of this progress would have been possible if MCOs ran Husky. Broad legislative approval is key to continuing that process. The legislative approval in SB 985 is very important to ensuring the continuity and evidence-based policymaking we have built since 2012. However, the bill would be improved by giving every member of the General Assembly a vote on major decisions affecting Medicaid, such as bringing back MCOs. Last spring, the governor was planning to reintroduce MCOs into the Husky program in secret. Reportedly, work had already begun on designing the RFP. We only learned of it when a whistleblower contacted us and advocates raised alarms. State law must be clear that this governor, including future governors, cannot do this unilaterally. Every member of the General Assembly has Husky constituents who need to be represented in the decision-making, and the impact of returning MCOs to Husky transcends just the health-related committees. That $4 billion that we're saving in our state budget is now going to other priorities such as housing, education, and tax relief. So we
Your time
are
is
decided
complete.
to
Please
go beyond.
summarize.
Thank you very much.
Thank you for your testimony and your support of this legislation. Are there questions or comments from members of the committee? Seeing none, it's good to see you, Ellen. Thank you for your testimony.
Thank you.
Next, Janet Alfano Stolfi, followed by Juan Fonseca. For the record, when she said it was a shady afternoon, I didn't think that was directed at us.
Good afternoon, Senator Lesser, Representative Gilchrist, and members of the committee. My name is, it's actually Janet Stolfi Alfano. I could have been typing it incorrectly, but it's flip-flopped. I'm the Chief Executive Officer of the Diaper Bank of Connecticut, and I do appreciate the opportunity to testify before you again for the third year in a row in order to ensure that families have access to diapers in support of HB 6937, an act concerning Medicaid coverage for medically necessary children's diapers. You have my written testimony. I'd like to summarize the key points, and I really first would just like to draw your attention to testimony that was submitted by my friend and colleague, Lieutenant Maurice Mo Edwards. He's a lot of things. He's amazing. He's a New Haven firefighter. He's a dad. He's a former client of our organization from over 10 years ago, and he's also a board member. He hoped to be here today, but he is working, saving lives and homes and property. He'd hoped to be here to share his story about how getting diapers at one of our partners helped he and his family. And much like Representative Butler and Wieslander earlier today, he talks about what that felt like as a parent, not to be able to provide that basic need as a father, and that how he sees it as a strength that he could access diapers through one of our partners at Mount Bethel Missionary Baptist Church. So I just wanted to make sure to please draw your attention, if you get a moment, to please read his testimony. He really hoped to be here today, but again, couldn't. This bill would provide diapers in certain circumstances, medically necessary for specific health conditions. I believe Dr. Osei kind of went through those, so I kind of skipped through that. We've been doing this work for 20 years. We know that we are just scratching the surface of need that exists. If we think about folks who qualify for Medicaid who have young children, roughly from 0 to 3, based on the DSS data portal, it's a little bit under 70,000 children. And we're serving a little over 6,000 children. We know this bill is only talking about supporting those who have a specific medical need, which I think is a wonderful place to start, and will bring parity to how Medicaid coverage exists for older children with special healthcare needs, as well as adults who have incontinence needs who are covered under Medicaid. Because essentially that coverage is provided because they prevent and ameliorate conditions that are caused by having lack of access to those things, whatever the catalyst is. And so we just ask that children 0 to 3 have that same opportunity. We know the economic, physical impacts that not having a lack of, or having a lack of access to diapers has on a family, impacting the health of babies, moms with mental health, and parents and caregivers of all kinds. We know that the economic impact of not being able to bring your child to work because you need to bring a steady supply of diapers to childcare also impacts families. This is a real concrete need that families face at a time where the child's development is at a most critical stage, and the bonding that a parent will have is at its most critical stage. We appreciate the state of Connecticut overall in being a leader in this issue, having supported our organization with a line item. It's simply too much need out there for us to meet on our own, and that's why this is such a critical item. So I ask for your support. I would like to just leave room for some questions if you have any, but thank you for taking up this bill and for taking on the concerns of families across the state, especially those that have young children. Thank you.
Thank you, Janet, for your testimony, and apologies for mangling your name. I just read what I was handed.
Understood.
Just with regard to DSS's testimony,
Yes.
they slapped on a rather hefty fiscal note. And so I didn't know if you'd had a chance to look at that and had thoughts about how we could make this work in the context of our state budget.
Yeah. So, our line item is through DSS, and they're amazing partners, and we are so supportive of their efforts in helping us meet this need for families across the state. In the DSS report, that was a result of the legislation that was passed last year, based on what we were talking about, the total cost of providing these items would be 31 million, but that's not all state of Connecticut funds. That's inclusive of the federal portion of funds. In their report, they state that it would be about 16 million, which again is a lot of money. We understand. What we are saying is that we feel like, you know, infants and toddlers are in the state are worth it, and that we should do what we can to help prevent further health complications, especially at such a critical time. We are already covering these items for people on different ages and with medical need in the state. And we want that same care to be taken for our infants and toddlers as well.
Okay, Representative Gilchrist.
Great, thank you so much. And thank you for your team and all the work you've done on this. I'm going to start with building off what the good senator just said. I did read the report, but it was a while ago and there's a lot of reports. Did they say how they came to that number?
So that's a great question, because we looked at this in depth, and the one data point that I could not figure out how they got to was the sort of, we know the denominator, right? We know that overall around 70,000 kids age 0 to 3 are covered under Medicaid right now. There's some proportion of that they're pulling that figure from, and I don't have the source for that. I couldn't find it anywhere. I'm not necessarily disputing how, you know, what that would be, but I just don't know what that source was. So I could not figure that out. And we had a couple of folks looking through as well. Our colleagues at CHA took a look as well. We just couldn't figure out what that was.
So I'll take that upon myself to connect with our Office of Fiscal Analysis, to have them connect with Department of Social Services to see how they got to that. Because could you explain to I worked with you all, but it would be helpful to explain to folks, I think, kind of how you got to this definition of medical necessity, kind of where the conversation started and then how it got to this place.
Yes. So it started when, really a long time ago, on the corner of my whiteboard in my office, I had a little thing, expand access to diapers, Medicaid coverage, and make sure we can be in all counties in the state. We've gotten two out of 3 of those. But really it's at the efforts of us just talking about this issue over time, where there is a growing body of research and evidence and support. When I used to come to this body, in 2007 to talk about diapers, I don't think the response was quite as welcoming as it has been. But I think, folks really are now understanding the physical health and economic impacts that this can have. A few years ago, we said, hey, if we could wave a magic wand, we would want all Medicaid eligible children 0 to 3 to have diapers. And that, having discussions with DSS over the past several years, we came to the discussion point around, let's talk about medical necessity, especially with our colleagues at CHA and experts who think about these at the state, local, and national level, trying to get to the idea of, let's at least have parity in how we are treating folks of different ages along a continuum.
Thank you. And, as you're saying that, like to hear your whiteboard, thank you for being a visionary. At this point, though, some other states have kind of gotten ahead of us. The conversation's been happening here, but now, so what are those states and what does that look like?
Sure. So 2 states over the past year, actually, 2 states have passed Medicaid coverage of diapers in different ways. And it gets a little weedsy, so apologies. And I'm not an expert, but I will do my best. In Delaware, they have passed basically like a bundle. So they're offering new moms up to 12 weeks postpartum with like a food bundle, and as well as the supply of diapers for their baby. So they're hitting new moms and babies right in those first few months, in those first 3 months. In Tennessee, it is a different model altogether, where they're offering 100 diapers per child per month through age 2. So different models. My understanding of how Tennessee is handling it is that they're using some sort of Medicaid savings that the state has to cover the cost of it. So, but again, it's very early in the process, so I don't know. I don't have the numbers as to how that is working.
Thank you. And my final, since you've been before this committee in the past, some confusion or questions have arisen around, well, if we do this, then would we be good to go on providing the diaper bank with funding? Can you speak to the need in the state and how both are essential?
Yeah. So one thing that we frequently talk about is that there's no diaper coverage. There's no federal existing diaper coverage, food stamps or WIC or any entitlement program. Whereas in the category of, say, food, there's a lot of ways in which families can get, and that is very well needed, get the food that they need with supplements. And yet food banks still exist. So this would be another avenue to create more opportunity for families to have access who have medical need to get diapers. That doesn't mean that we've solved diaper need generally and that we'd like to be doing more. So, during COVID, we had some emergency funding to support basically an additional 4,300 children. The funding is now gone and we've had to pivot. Those families don't have what they need in order to support their diaper need for their family. So we know that the need is out there. And I think someone actually spoke to the statistic of in 2019, it was 1 in 3 families experienced diaper need. It's 1 in 2. So that hasn't lessened. The families that we're serving have not recovered yet from any economic losses that they've had during COVID. And now we're seeing inflation. Diaper pricing has gone up from 2018 to now. It's about 22%. Baby and formula, those are associated costs for babies like formula and other things. Those have gone up like 3 to 9%. So this is at the most critical time of a child's development, and these costs are rising and families aren't able to keep up.
Thank you. Thank you very much.
Thank you.
Thank you, Senator.
Thank you for testimony. Any questions or comments from other members of the committee? Seeing none, thank you for being here this afternoon.
Thank you.
Next, we have Juan Fonseca, followed by Mike Johnson, followed by Claudia Pagnosi Schwam. And if I am mangling anybody or everyone's name, please forgive me. Is Juan here? No one. Is Mike Johnson? Good to know I did not.
Representative.
Is your your microphone was not on, but now it is.
Okay. My name is Mike Johnson. I am a Franciscan station at St. Patrick St. Anthony here in Hartford, and I run the Franciscan Center for Urban Ministry. I'm here today to support HB 6937. You heard a lot of the reasons from somebody that knows a lot more about the intricacies of this bill who just spoke. I'd like to talk about it from a Catholic perspective. For us as Catholics, pro-life does not end at birth. It means providing our children, our people with what they need, especially the most vulnerable. We've all seen the Yale study and the impact on our poorer families, especially single moms, what they're dealing with, the suffering, the anxiety, the depression. And we all know up until 3 years, those years are critical. And if you have a kid sitting in a messy diaper, screaming, it's going to impact, the mother will not be able to bond. And they may get infections, but the danger and the damage is much greater than that. How much more are we going to have to pay for these kids that weren't able to bond, the mothers that weren't able to give them the love and the assurance that they needed? How many more IEPs are we going to have to pay for? We're talking about our special education budget going through the roof. Isn't it more important to make an investment in our kids at this age so that they are set up to thrive, not struggle academically and emotionally and cognitively down the road? For us, a budget is a moral document. It says what we value, and if we don't value our children, especially our most vulnerable children, what are we prizing? What's more important than that? If Tennessee can do this, shouldn't Connecticut be able to? Thank you.
Thank you for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you. Thank you. Next, we have Claudia Pagnosi-Schwam, followed by Tamara Coleman.
Hello, everyone. Hi, my name is Claudia Pagnosi-Schwam, and I have spent nearly 25 years living in Connecticut, which is almost the same amount of time that I have lived with life-threatening food allergies to specifically peanuts and tree nuts. As a graduate of the Yale School of Public Health and a national advocate for the food allergy community, I have seen firsthand the challenges that families face in preventing, diagnosing, and managing this condition, especially when financial constraints limit access to resources and care. So I'm here to talk about a bill that aims to improve access to early allergen introduction for infants. After speaking with several food allergy parents regarding their experiences around trying to implement preventative early exposure to common food allergens, two main issues became evident. The first one is access and affordability. Not all parents can afford or access allergenic foods in the whole form, like nuts, fish, eggs, especially those living in food deserts or low economic households. Some lack the storage space or resources to safely introduce and maintain exposure to these foods. The second is consistency and ease of use. Many parents struggle with dosing, incorporating allergenic foods into the baby's diet consistently, which is key to obtaining the preventative effect. For example, eggs require not just purchasing, but preparation as well, which can be very difficult to sustain. These supplements provide a safe, convenient, measurable way to maintain exposure, ensuring families can follow these evidence-based practices. Lastly, as someone with food allergies who has suffered from life-threatening anaphylaxis and cares not only about individuals, but the population-level impact of this, I can't overstate the long-term impact of this bill. Fewer children developing food allergies would also mean reduced financial burden, less psychological impact, increased social participation, fewer school absences, and ultimately less strain on the healthcare system. Thank you very much, and I urge you to support this bill.
Thank you for your testimony, for being here this afternoon. It was many hours ago, so it's totally okay if the answer is no, but did you happen to hear Commissioner Barton Reeves's testimony and her concerns about this particular section?
I don't believe so. Could you reiterate some main points? That I'd be happy to respond.
I will actually phone a friend and ask Representative Comey in a second to do just that. I think we are really interested in getting allergy prevention policy right. I'm speaking personally. I have my own life-threatening food allergies, and so this is an issue that I am personally committed to working on. But we're just trying to figure out how best to do it within the four walls of our community's jurisdiction and our oversight over the Medicaid program specifically. So I will turn it over to Representative Comey, who I think does have some thoughts, and I'll also.
Thank you.
Thank you, Mr. Chairman. Hello, Claudia. It's great to see you.
Great to see you as well.
Thanks for jumping on this afternoon. Yeah, so the commissioner had a concern about, well, besides the cost, of course, which is really important, but that basically she thought that the whole foods were a better approach, and that supplements may have a variety of allergens in them, or that they're, being a supplement as opposed to, something that is regulated in a more, in a different way, a commercial product as opposed to it. So she just thought that it's actually safer to give food to the infants, and that there may be some mixed messaging as parents try to navigate introducing food allergens into the infant's diet. And so I guess the question to you would be, I really liked, unprompted, without hearing that, that she said that you did talk about the access to food, and especially with food deserts. Do you want to talk about that?
Sure, absolutely. So as we've seen, food costs are quite high. It can be difficult for family to purchase whole foods. These foods, especially when trying to get the preventative effects of early introduction, need to be sustained, and it also needs to be measurable. So if you imagine, a busy mom who's running around trying to work several jobs, trying to make sure her kid is safe while also maybe she has an older child who already has food allergies. There's a lot of things that are being juggled here. And so if having access to certain foods for prolonged periods of time are a burden, then some of these supplement options, many of which are actually contain whole foods, could be an alternative approach. It's not necessarily saying this is the right approach for every single person. It's more so giving them the ability to choose if this is the correct option for them. So I hope that answers the question.
It does. You're absolutely right about it. It might not be the appropriate choice for every child. One thing that we discussed with some other folks that testified was the need for adding an educational element to this bill. What are your thoughts on that as a public health expert?
Yeah, absolutely. I think health communication is key. I think a lot of the times also we kind of assume people's baseline level of knowledge or access to healthcare providers who may help them guide through the process. So just making sure that education is, integrated alongside this prevention strategy, I think would be pretty important. So.
Okay, thank you. And because you have a personal experience with it, and you may be the only person that we'll speak with today with a personal experience of food allergies, can you talk about the psychological impact of living with food allergies?
Oh, I absolutely can. So when I was younger, the guidelines were actually to delay introduction of certain allergens, commonly very prevalent food allergies. So think milk, egg, peanut, tree nut, the top 9 food allergens. My parents followed those guidelines thinking, my parents are also both physicians, thinking they were doing the right thing. Later on, research showed that it was actually better to introduce these allergens early. That said, I developed allergies to peanuts and tree nuts, along with other food allergies I've grown out of. And navigating those food allergies have taken a large psychological toll, including increased social isolation, a lot of mental juggling, risks and balances, in addition to a lot of financial considerations I have to make in terms of whether I want to pursue certain routes of care, or whether it's purchasing food allergy alternatives, even when something may be offered to me at a lower cost, but it's a much riskier option in terms of food allergies. So I would say for people with food allergies, for parents of children with food allergies, there is a constant consideration and vigilance that has to go into it, and it can really take a toll on people if the proper support isn't there, which ultimately puts even more impact on the healthcare system. So I would just like to highlight that this is bigger than just cost to the initial prevention. This is long-term effects as well.
Thank you. Well, thanks for coming out. Thanks for sticking around and listening all day online. And I hope things are going good up there in Boston.
Thank you. I appreciate you all.
Thank you for your testimony. Other questions or comments from members of the committee? Seeing none. Let's see. All right, next we have Tamara Coleman, followed by Paul Towning. Tamara? Or Tamara? Okay, Paul Downing. Michaela Fissel. Hello. I'm sorry, please press the, great, you're on.
Good afternoon. My name is Michaela Fissel. I serve in the role of Executive Director at Advocacy Unlimited, and I'm a voter in Windsor, Connecticut. AU is a nonprofit organization. We provide holistic, peer-led recovery resources in the areas of mental health, addiction, and trauma. I am testifying in opposition to House Bill 7023 because this bill lacks clarity and further marginalizes already disenfranchised professional workforce. The professional peer recovery workforce is not cheap labor. We offer effective, evidence-based services that require fair wages, career advancement opportunities, scope of practice protections, and inclusion of the professional peer workforce in decision-making about our profession. My journey to recovery began at the age of 21. Prior to connecting with the peer recovery community, I chose to try to kill myself because I did not want to remain dependent on state assistance and psychiatric care for the rest of my life. When I first encountered peer support, I recognized a shared lived experience that offered valuable insight and opportunity to reframe my life from dependency to choice. The person providing peer support offered me a mirror through their very existence, and I saw a reflection of the next step in my journey. Peer support offered me a path forward, and I learned effective strategies for moving through the shame, secrecy, and silence that became externalized symptoms of what was diagnosed by psychiatry as an illness. For me, that meant the years of sexual violence I experienced during my childhood, the years of adolescent homelessness from the age of 17 to 19, and involvement in the criminal justice system could become a source of empowerment. I was not broken, and I did not require fixing. I had experienced devastating circumstances that required care, attention, support, guidance, reassurance, and consistency and connection with a person who I could trust with the most difficult moments of my life. So, in finding my way forward as a young adult, I decided to go to school pursuing my undergraduate degree in psychology as a path toward understanding everything I possibly could learn about this thing called mental health. Today, I am a member of the professional peer recovery workforce. There are thousands of us in the state of Connecticut, working, employed, and continuing to remain disenfranchised from decision-making that directly affects us and the community that we serve as people with lived experience. I hold 2 graduate degrees. I have served as an elected official for 3 terms. I'm a yoga instructor and breathwork practitioner. I've advised on the federal level, and I teach a comprehensive multidisciplinary educational curriculum for peer credentialing in Connecticut.
Your time is complete. Please summarize.
With this professional expertise, and as a previously appointed member of the task force that was never convened, I can assure you that we can do better than this bill. And any pressure there may be to push this through is coming from folks who have not included the professional peer recovery workforce in their practices and decision-making. For example, my final comment is, I'm not quite sure what the DSS commissioner and team was speaking to earlier. We are not community mental health workers. We are not. There are many states that have done what you're attempting to do here, and we are not community mental health workers.
Okay, thank you for your testimony and for sharing your story. And glad to know you're doing well. What states would you suggest we look to as examples of whom?
I would be happy to follow up by email, and I can provide you multiple references of other states. The one that comes to mind would be Georgia, Rhode Island, New York, to name a few.
And you're suggesting those states have gotten a good balance in terms of how to roll something out successfully?
Yes. In fact, I did a ton of work with Margaret Watts and other members of a self-convening group from about 2017 to 2020, as we explored peer and reimbursement before the state of Connecticut, Demas, and Perch, Yale, decided to sole source a contract to this Connecticut Certification Board to mandate new credentialing for our professional workforce.
So what specifically would this bill do that you are particularly worried about? What's the
I would say
parade
the
of
word
harm?
may have lived experience. That word may, no, that is bad policy.
So do we need we could change that. We don't need a task force to change that. We could just change it to shall.
No. Yes. And you set precedent. You set precedent as elected officials. There was a task force that was going to have majority representation of the professional peer workforce. It was appointed. That was a huge win, not only for the peer recovery community of Connecticut, the 30% of residents, arguably more, who are not only going to receive a diagnosis, but may also engage in mental health services. That was a huge win for us as a peer recovery community. And also it was an opportunity for us to be given a space to demonstrate that we have the capacity and the capability of participating actively in the decisions that are being made about us. That was a precedent that was going to allow for people to inform decision-making in a way that we have never been allowed to do previously. And I use the word allow because we are working within a system that fundamentally is, this is my graduate degree, but like this idea that like society, right, has framed the idea that if you receive a psychiatric diagnosis, you lack mental competency. Right? This is I would describe this based on the 17 years of my professional experience as a civil rights movement. And the precedent that was set in the establishment of that task force, the appointing of majority people in the professional peer recovery workforce allowed us to see ourselves as something more than an illness, more than a consumer of psychiatric services. And we asked Demas multiple times, why are we not allowed to convene? We reached out to our elected officials. We heard nothing.
So I hear your frustration, and I understand the argument that you made about how people with lived experiences have been historically marginalized and are excluded from conversations about how to best help folks. And obviously our intent with this legislation is trying to reverse that, is to try to say, we want to value your lived experiences in the only way we really do ever value anything in this building, and that's with money, right? We have a state budget and we appropriate money where the programs that we care about, we underfund programs that we don't care about. And so that is an awkward way of doing things, but that is how we do things in state government. And that's true for this state and every other state. So I don't know what the whole ancient history about when, about that, you mentioned the task force, and we could sort of look at what happened or didn't happen. But going forward, the question is, we have a lot of need out there. We've got folks who are, facing all sorts of challenges who could very much benefit from peer support. I hear you that we need to find a way to listen to the community about how best to do that. But if the response is we need to wait one more year, I mean, I've sat through I don't know how many hearings where people have talked about doing peer support. Meanwhile, every other state's figuring this out. And in Connecticut, we seem to be stuck in a rut here. And so if you're saying, hey, we need a task force, and then we come back next year, and maybe next year we'll deal with it, or maybe it'll be the year afterwards, people are, I don't mean to be bit crass here, but people are dying for lack of peer support services.
It's true.
And I would really like to not delay another year if there's a possible way to figure that out. So if there's a way to look at the language of the bill, and also in process of actually setting up a program, create an oversight role or some sort of ongoing task force to advise on implementation. There must be, there's got to be a way to do this and also hear from the community about how to do it. But if all we're hearing from the peer support community is no, we're going too fast, we've been waiting for years and not doing it. So it doesn't feel, whatever we're doing, we're not moving too fast on this issue. I think we've been litigating it at least in this committee for many years. So that's why I'm just struggling here, and I really would hate to have to press pause one more year while we try to get this task force up and running.
May I respond?
Of course, please do.
I really thank you for using the word struggle, because I've also been struggling with this too. I've been involved in the professional peer recovery workforce for at least for 15 years, working at Advocacy Unlimited for 10, previously with NAMI, previously with the regional behavioral health action organizations, whatever, what they were called previously to that. And I've been struggling with this too, because I understand like the importance of investing dollars, because that is like the legislature's way of prioritizing a service, right? A need, right? You invest the dollars. So I also appreciate this idea of convening a task force that I would be humbly open to serving on, to advise and participate in conversations and decision making related to the peer recovery workforce. That would be a really wonderful step forward and towards partnering with the professional peer recovery workforce. I also would ask that you look to already published literature to define peer support, because in the definition, I was able to find it, the DDS, Comp IFS, EDS waiver definition of peer support that guides Medicaid reimbursement here in the state. And the definition actually resembles the role of a caseworker and mental health worker. It doesn't reflect the definition of a peer worker or peer support services as defined by SAMHSA, which is the federal government. So there's confusion there. And I'm open to participating in clarifying roles. That's great. I love that. I've got 2 graduate degrees. Like, I obviously love to nerd out. So I'm here for that. But I also just want to point to that there is a lack of clarity in the bill. And once you pass legislation and you start attaching money to things, right? That makes it becomes increasingly more difficult to go in and change the language that's already been defined, especially if I'm asking as a member of a marginalized community, right, for anything that would then limit the control and power of the people who have been given the money. That's how this works. And so the other point that I would ask is, like, I know you said that you're not appropriations, but I was there until like 12:45 in the morning. So, I'm in it. I've gone into appropriations every single year for 17 years now, and I am there till the very end. And what I would ask for then, if we're considering money, is that to actually itemize, pull out peer recovery services, ask for that within the governor's budget. There is no line item for peer recovery services. That would be an extraordinary act on your part to prioritize peer recovery services through an itemized line item in the budget, because you had asked Quinn, like, how is this currently funded? It's funded through multiple funding sources. I work every day with funded nonprofits and state agencies who explain to me how do they fund peer support. And they pull money from all over the place to fund these positions.
We're talking about creating a dedicated funding stream within DSS, right? That's what this bill is about. It's about getting Medicaid to pay for it. That will be, I guess it'll be within the Medicaid line item, but certainly we can ask, that is a dedicated funding stream, whereas it's right now it's cobbled together between different agencies and different things. So that I understand that there's some issues with the Medicaid funding model. There are some folks in the community who don't believe that it should be a medical model, that we're hourly billing. I understand I've heard that at least 2 previous years that I can remember. So like I have that back in my brain somewhere.
That's right.
So I get all the, I don't get all the issues, but I get that issue. But here I feel like this committee is trying once again to fund this service, and that's why I'm sort of puzzled why I'm not picking on you, but why so many folks seem to be saying once again, no, don't do that. We need to study it some more. Don't give us the funding. Let us figure it out for one more year. Meanwhile, we have heard from, all of our communities that the death toll has just been staggering for substance abuse, for mental health issues, and we are losing folks in all of our communities.
So I don't want, I'm please, no, I am in service to the highest good. Like I am very much committed to dialogic-based practices and finding a way forward together. Co-creation matters to me in all spaces and places in which I enter into. People are not dying because they don't have access to peer support. And to do this well requires the inclusion of the peer recovery community to ensure that the policy that you're writing is going to lift folks, to provide opportunity. Like my area of expertise went from a chemical imbalance treatment approach to exploring serious emotional distress, including what would be diagnosed as schizophrenia in our kind of way of thinking about things. Hearing voices, seeing things. And this idea that we need to put peer services in a treatment model, yes, that concerns me because I've traveled around the world, literally, gone to other communities and living in an indigenous tribal community for 3.5 weeks last summer in Peru. The way that we think about this is just one way of thinking about it. I'm not saying that clinically oriented services don't have a place, but when we're thinking about peer recovery services, the experience of what it means to live through life-altering, devastating circumstances, that's essential to connecting with a person and providing them with an opportunity to create in their own life a different experience, a life worth living for. It is not about just connecting people with primary care. It is not about connecting people with behavioral health services. Peer support is an evidence-based practice that provides a bridge to a different experience where the person recognizes within themselves that they have something to live for. That is not reflected in the current legislation. I'm not against Medicaid reimbursement. I think that this is an important piece to the puzzle, but the peer recovery community has consistently shown up and asked to be included. That is not asking for too much. So putting this, you decide, because I respect your decision 1,000%, I respect you, that moving this forward, you have heard me, you have heard from other peers. We are asking to be meaningfully included in the decisions that are being made about our profession based on our lived expertise. That is what we have consistently asked for. And I'm going to pause there. And I thank you for allowing me the opportunity to provide so much more information than I thought I was going to provide.
You're welcome. Thank you very much for your testimony. Really appreciate it. Any other comments or questions, members of the committee? Seeing none, thank you for being here this afternoon.
Okay.
Next, we have Mary Moberg, followed by Paul Larson.
Good afternoon to all of you on the Human Services Committee. I am Mary Moberg, and I'm talking a little bit about 985 and also about previous things that were discussed in about community health workers and so forth. And that relates to something that happened in October of last year, recommendations about improvement on Medicaid. So as previously, as a care manager, registered nurse for the community health, the community Connecticut home care program for elders, and a present elderly paraplegic recipient of the same program. I advocate for optimizing that program to continue and to thrive. It's always been the premise that services for home care are something that, in lieu of institutionalizing, is a much more cost-effective thing. Say that 3 times fast. Even though I have been very familiar with the process of applying for Medicaid because I help so many people, it was a different thing when I had to do it. It was daunting, tedious, and disheartening to work through all the steps. And so I kept telling other people, keep your foot in the door, put as much documentation as you can in there to meet the requirements and to not have things fall out the door. But I was even asked to provide non-existent contracts to satisfy proof that I had emptied out certain savings. It gets crazy. But luckily I got on the MedConnect program. And, DSS workers did not even know MedConnect was a conduit to the Connecticut home care program. I had finally gotten a hold of a supervisor that said, well, they're all fairly new and they don't know about that. So in the recommendations, it was said, let's have more help with getting people through the application process, facilitate it with the DSS workers. I know too, the Agency on Aging, we would help people with that. So it's in the program. It's good to make it even better. So the thing about the Connecticut, the community health workers working at the Community Health Network. It's hard because I work for both places. Community Health Network of Connecticut. The community health workers are an integral part. Anyone who calls as a Medicaid client is screened for social determinants of health, and it is a very effective program. Trying to find other ways to have it seep into the community, whether it's through the experimental program through doctors' offices or other conduits is well worth it. But the other thing is
Your
that
time is complete. Please summarize.
so, but lastly, please avoid the MCO type management at the Community Health Network of Connecticut type services is justified. And I have personally witnessed how effective and how carefully they have workers screen what they do to make it appropriate. So as Sheldon Trubman had said, please take it out of the equation as some kind of option in the future. It is not desirable. Thank you.
Thank you for your testimony in support of that bill. And also I'll just flag, since you mentioned the MedConnect program, that expanding that program was a priority for this committee under a number of years. We were able to get a major expansion into the budget last year. But in the governor's budget proposal for this year, he's proposed to block that expansion and to press the brakes. And so hopefully we can persuade upon him that the initial expansion of that program is actually really helpful for a lot of folks. Are there questions or comments from members of the committee? Seeing none, thank you for being here this afternoon, Mary.
Good night.
I've never been saluted in this committee before, and thank you for that. But please don't anybody else do that. Paul Larson, followed by Liz Dupontil.
Well, good afternoon. Can you hear me?
We can.
Okay. Well, hello, co-chair Senator Lesser and Representative Gilchrist and members of the Human Services Committee. My name is Paul Larson. I'm the president of Connecticut Farm Bureau. We represent almost 2,000 farming families here in Connecticut. And I'm here to testify in support of Bill 7021, the act concerning funding for nutrition assistance. You heard earlier this afternoon from my executive director, Tracy McDougall. And so I'm not going to repeat everything she said. We might have a little bit of overlap here, but let me just say that when I looked into the situation regarding food assistance in Connecticut, I was actually quite amazed at how the system works and the many ways that we are providing for those who find themselves food insecure. That's not to say there is no need to improve the current situation, but it was especially gratifying to note the contribution that our Connecticut farmers make each year to help those in need. According to Food Share, so it's not our statistics, it's their statistics. Over 310,000 pounds of food was donated to Food Share from our Connecticut fields, farms, and orchards. While only 1% of the food distributed through Food Share is purchased with state funding, the bulk of it is with federal money, the state share is currently set at $10 million. This bill would require the 15% of that funding be used to purchase food from Connecticut farmers, and I believe be indexed annually, if I'm not mistaken. The $1.5 million that would amount to would be a direct investment in our local farms. Production on any farm is managed and scheduled at least a full season ahead of actual production, and it's important for our farmers who plan to grow their products for sale to Food Share, that's part of their business plan. It's important for them to have that security and continuity of knowing that they have that market available to them. So I just think this is a very good program, that we're meeting the needs of people in our state who have that need, and the funding being channeled back to support the Connecticut farmers is just makes it a double benefit. So I support this bill, and I urge you to approve this funding for the or pursue this funding for the Connecticut farmers and for the Food Share program in Connecticut.
Thank you so much for your testimony, and it's great to partner with the Farm Bureau, and you don't frequently come before the Human Services Committee, but we're glad to have you when you're here. Are there comments or questions from members of the committee? Seeing none, thank you very much for your testimony.
You're welcome. You have a good rest of your day.
You too. Liz Dupontil, followed by Cathy Vieira.
Good afternoon, Senator Lesser, Representative Gilchrist.
Don't do that.
Maybe a lot of hard acts to follow here. Good afternoon. Senator Lesser, Representative Gilchrist, members of the committee, thank you for hearing our testimony today. I'm Liz Dupontil, Associate Director of the Connecticut Citizen Action Group, or CCAG. We have worked for more than 50 years to bring about a more fair and just Connecticut. I testified today on behalf of CCAG and our thousands of members. We are in very strong support of SB 985, which addresses current unfortunate statutory authorization for the governor to contract with managed care organizations or MCOs. We'll reiterate the testimony of many of our partners, including Sheldon today. The bill requires that if any governor wants to move back to MCOs, they would have to put forward a proposal and get it approved by a committee of cognizance, though not the whole legislature. Connecticut's current Medicaid Husky system is a great success story, and we often hear from allies in other states who wish they had our system. We have better experiences in cost control as well as quality, made possible by not contracting with wasteful insurance companies and contracting instead with non-risk administrative services organizations. People would be harmed if we went back to the failures of that expensive system, which was also unaccountable. Given this success, allowing this or any other governor to return to capitated managed care as currently authorized would serve neither the taxpayers nor Medicaid enrollees and their providers. SB 985 would make important strides in preventing this, then would be more effective if it required approval by the whole legislature and not merely the committees of cognizance. We also want to speak out in support of our raised bill 6937 and act concerning Medicaid coverage for medically necessary children's diapers. Again, we won't repeat the testimony of many partners, but we're in support of this bill. Thank you so much, and I welcome any questions.
Thank you, Liz, for everything except that salute. Questions or comments from, yes, Representative Gilchrist about the diaper.
No, I thank you for the salute. Thanks.
Thank you for your service.
Well, thank you so much for being with us. All right, next up we have Kathy Vieira, followed by Jennifer Gaines. Jennifer Gaines.
Hello, good afternoon, Madam Chair Gilchrist, Senator Lesser, and distinguished members of the Human Services Committee. My name is Jennifer Gaines, and I am the National Engagement Manager for the National Diaper Bank Network and Alliance for Period Supplies. But first and most importantly, I am a proud mother raising 3 amazing young children, ages 7, 5, and 9 months old, right here in Stratford, Connecticut, still changing diapers every day and also sharing Senator Lesser's earlier sentiment of also having bags under my eyes. I know firsthand the challenges parents face when they try to provide for their children, especially now when families are faced with making difficult choices. That's why I'm here today to testify in strong support of House Bill 6937, an act concerning Medicaid coverage for medically necessary children's diapers. Unfortunately, far too many families throughout Connecticut are not able to afford the diapers they need, and as a mother of 3, that is very concerning to me. Diapers are a necessity, not a luxury. The National Diaper Bank Network was founded and headquartered in New Haven, is committed to ensuring that all families have the basic necessities they need to thrive, like clean, dry diapers, period supplies, and other essential items. Through our network of over 240 diaper banks across the country, including 5 right here in Connecticut, we distribute free diapers to families struggling to make ends meet. In 2023, Connecticut's diaper banks distributed more than 8 million diapers, serving over 13,000 families every month. And yet, the demand continues to grow. Families are forced to make impossible choices. Do I buy diapers or do I buy food? Right now, programs like SNAP and WIC do not cover diapers, leaving parents to rely on diaper banks to fill the gap. But charity alone cannot solve the crisis. According to our Diaper Check in 2024 report, 1 in 2 U.S. families, as you've heard earlier, are experiencing diaper need. And at the same time, diaper banks across the country are seeing unprecedented demand, a clear sign that families need more support. This is not just a financial burden, it's a health issue. So babies left without enough diapers are at greater risk of severe health issues like diaper rashes, urinary tract infections, and more frequently making visits to their pediatricians. And as we think of children having other conditions like autism, for example, that result in an unusual delay in toileting behavior. It causes a further burden on families that are already struggling to support their children's various needs. But the good news is, as you heard earlier, there's a proven solution. There are 2 states right now, Tennessee and Delaware, already providing diapers through Medicaid waivers, improving health outcomes while reducing financial strain on families. Connecticut also has the opportunity to do the same. So HB 6937 is an investment to our precious babies, children, and families across Connecticut that are struggling to care for themselves. Providing Medicaid coverage for medically necessary children's diapers will reduce health risks by ensuring babies and children have enough clean diapers, ease the financial burden and stressors on low-income families across Connecticut, save the state money in long run by preventing costly medical interventions. This legislation is more than just diapers. It's giving families hope. It's about ensuring every child in Connecticut has a healthy start in life. So I urge you to support HB 6937 and give families the resources they need to thrive. Thank you, members of the committee, for your time and dedication to Connecticut's families.
Thank you for your testimony. Are there questions or comments from members of the committee? Representative Shake.
Good evening, Jennifer. Thank you for your testimony, and I just want to say thank you for all the work that you do for our state and your level of advocacy here and down in Washington, D.C. It's appreciated.
Thank you so much.
Anybody else? Seeing none, thank you for being with us this afternoon and for your work nationally.
Thank you.
Next, we're going to go back to Kathy Vieda, who is joining us.
Hi, everyone. Good afternoon. Dear Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee, my name is Catherine Villeda, and I'm the new Coalition Director with the Husky for Immigrants Coalition. Thank you for accepting our testimony in support of HB 6937 and that concerning Medicaid coverage for medically necessary children's diapers on behalf of the coalition. The Husky for Immigrants Coalition is a statewide coalition comprised of over 40 organizations advocating for equitable access to Husky health for all income eligible residents, regardless of their immigration status. And as a coalition, we recognize that access to quality healthcare does not only mean access to medicine, hospitals, and vaccines, but includes access to holistic and comprehensive medical services and resources. Providing diapers when medically necessary is also healthcare. Husky members qualify for the program because of low income, and it's no secret that diapers are very expensive. The Medicaid coverage for medically necessary diapers is an important form of medical and financial support, as it can reduce the financial burden of raising a child with special needs. Without this coverage, families on Husky struggle to afford diapers, which can negatively impact the child's health and quality of life. Not having enough diapers can lead to serious consequences, and it is much more cost-effective to pay for diapers as a preventative measure than it is to pay for more expensive treatment if a child's condition worsens due to inadequate access to diapers. The ability to receive Medicaid benefits such as this can be a key factor in improving both the child's health outcomes and the family's financial well-being. Including essential items like medically necessary diapers as part of the Husky program ensures that children and families receive the standard of care that allows for healthier living conditions for the child, supports their dignity, and eliminates the added stress of unmet medical needs. HB 6937 will allow low-income parents in Connecticut struggling with the cost of diapers that they need to care for their babies or toddlers due to medical necessity, to live a more dignified life. It is critical for our state to enact policies that work to provide these services and resources to families who are most at need. We urge the committee to favorably vote on HB 6937 and appreciate you all for the opportunity to testify.
Thank you for doing so. Are there questions or comments from members of the committee? If not, thank you for being with us.
Thanks, everyone.
Next, Chris Healy, followed by Bruce Stovall.
That's on. Hi, Chairman Gilchrist, Chairman Lesser, thank you for having me. You have my testimony. I just here to lend my name and our organization in support of 6937. A lot of great things have been said here that are painfully obvious about the need to support our young women and our young children around the state, and that this need is great. I point out that I wanted just to commend the great work of the Diaper Bank already, and the numerous pregnancy care centers around the state who provide these diaper services as well. They are going to submit testimony I've heard to also support it, to augment their efforts. But This is obviously a good investment in development of our young children, our safety, well-being, and for the good of the family as we try to promote our life agenda in the church. And we have to do that not just at the birth, but through the early ages and into adulthood. And this is obviously one way to do that. I don't really have much more to add. It already has been added. And I want to commend Brother Johnson as well, who spoke earlier about the issues as it relates to our faith. But that's all I really have. And I know you have a few other people here to get through so that we can all go home tonight.
Very much appreciate your testimony. Thank you.
Absolutely. I think it's a great work you're doing. And obviously we will pass the word through the faithful to reach out to members of this committee and others to move this thing along and put it in our church bulletins to urge passage of this legislation.
That's wonderful. Are there comments or questions from members of the committee? Seeing none, thank you for being here this afternoon.
Very good. Have a good evening.
Bruce Stovall, followed by Megan Gorman. Please don't. Could you press the button though so we can hear you?
There you go. Okay. Good afternoon, Senator Lesser, Senator Gilchrist, and other committee members. My name is Bruce Stovall. I represent Oak Hill. Oak Hill is the largest private provider of disability services in Connecticut. We operate 65 group homes, a specialized ed school, assistive technology center, specialized clinical programs, camps, you name it, we do it. Established in 1893, we're about to celebrate our 142nd birthday. We have about 1,600 employees when fully staffed. It's not the case right now, and operate in about 50 different towns. I'm here to support SB 1358. We call it the COLA bill in the nonprofit world. Part of my history, I'm 36 years into Oak Hill. I've worn a lot of hats, but the first hat I wore in 1988 was a direct care guy. I did a temporary summer job, and I made $9 an hour. Doesn't sound like a lot, but the work caught me. I got captured by it, and here I am. But with $9 an hour, a little bit of overtime, I was able to afford a mortgage for a starter home. I was able to get married, have a couple kids, and get them through school. And I think a colleague before me, maybe in the mid-20s, talked about, we used to get 3% a year, give or take. It wasn't codified anywhere, but it allowed us to pay the bills and retain staff. We don't know what happened in 2007, but that kind of evaporated. And here we are kind of every year saying, it's hard to do this. It's getting harder. And again, if I applied to Oak Hill right now, I made $9 36 years ago. We're going to pay you about $18. DDS, our primary contractor, funds us at $17.45 an hour. We raise $1 more, so we'll give you 18 to change. Out of our 1,000 direct care positions, 400 are vacant right now. 400. We've closed 20 programs over the last 10 years. We have shuttered, vacated group homes right now. We have close to 50 open beds across our system. We could fill them if we could staff them. We've got empty chairs in our classrooms. We've got a waiting list of 70 kids for our school. We could take them if we could staff them. Again, a COLA solves so many issues. It's just common sense. I'll talk about the bill side. Also, I was at the Insurance Commission earlier testifying. Our liability coverage, which 2 years ago was a $25 million umbrella policy, we paid $125,000 for that. New pricing, we had to drop down to $15 million, over $500,000 for that. To go further, the costs keep coming. Typically, we have about 190 vehicles on the road any day. A minivan, which about 2/3 of the fleet are minivans, used to cost us $28,000 pre-COVID. That's $44,000 as we speak now. Wheelchair vans, which we have in abundance, were $74,000.
Your time is complete. Please summarize.
You can do the math, so please do the right thing. Thank you.
Well, we're trying. Thank you for your testimony and for the 37 years you said?
Just about.
Okay. Of work that you put into Oak Hill. Are there comments or questions from Representative Comey?
Thank you, Bruce. you just brought me back talking about, I used to work at an art group home.
Okay.
My father was an executive director.
Okay.
And yeah, I mean, I worked for $11 an hour as, a 20-year-old, and I thought that I had hit the big time.
Yeah. Not like that anymore.
No.
It just isn't. A lot of
Thank you
majority
for-
of our staff are two jobbers, and you know the rest.
Yeah.
Yeah.
Thank you.
Appreciate your time.
Thank you. Other comments or questions from members of the committee? Not seeing none. Thank you.
Yes.
for being- Oh,
Yes.
I am so sorry, Representative.
That's
Schaefer.
okay. Thank you, Mr. Chairman. I just want to say thank you for your testimony. And if you had anything else, I'm curious that you wanted to add for us to know. You were listing off some pretty dire.
I will just say it's not getting better, it's getting worse. And I speak not only for Oak Hill, I speak for our nonprofit colleagues, and you've heard the stories. A COLA is just common sense. Minimum wage has been indexed, for crying out loud. It'll be $17 come January. We're paid $17.45. I mean, it speaks for itself. I think Representative Gilchrist said it best last year, and I still remember this. We are creating the working poor. I remember you saying that, and thank you. It stuck with me. So thank you.
I just want to say thank you for all the work that you do and for everyone who is trying their best just to try and make it work. It's a work of heart. I believe that's my personal belief, but it is appreciated, and hopefully we're able to have a new pathway forward so that we're not stuck in these same positions year after year.
I appreciate that.
All set, Representative? Okay. Thank you. Next, we have Megan Gorman, followed by Ben Shaken. Megan? No, Megan. Ben? After Ben, we have Patty Salgado. After Patty, we'll have Merrill Gay.
Good afternoon, Mr. Chairman, Representative Gilchrist, members of the committee. My name is Ben Shaken. I work for the Connecticut Community Nonprofit Alliance. We are the statewide association representing nonprofits. Don't need to tell all of you, but nonprofits serve 500,000 people across the state every year. Thanks for the opportunity to testify in support of Senate Bill 1358. We are suggesting, as you've heard my members say throughout the day, that the committee change this bill and pass it with substitute language that would index nonprofit rates to inflation. We are proposing languages on my testimony that's identical with the exception of date changes to House Bill 5374, which passed this committee last year. This will be one of our top legislative priorities. You've heard from our folks, so let me just put a couple of quick numbers on it. Since 2007, which is the year before the Great Recession, nonprofit costs have risen by 45%, just inflationary calculation. Since 2018, all of you, your colleagues, have fought for funding increases for nonprofits in the state budget. They've added up cumulatively over the last 6 years. It's about 15%, and that's wonderful. We're extraordinarily grateful for all of your advocacy. But if you're doing some math, we're still 30% behind the buying power that we had before the Great Recession. My colleagues have talked about, back before 2007, we used to receive regular increases. That was not because there was any statute in place. That was just because the legislature prioritized this and the governors prioritized it in their budgets before 2007. Nonprofits are in crisis, and I just wanted to highlight a couple of things, if you're not on the Appropriations Committee, that we've been talking with them about over the last couple of weeks. We know this because we asked, and we talked to 126 different nonprofit providers across the state. Nearly 2/3 report having waiting lists now for essential services, with delays stretching from weeks to months. Almost half have been forced to cut programs, like Bruce just talked about, reduce capacity, turn clients away. And then we started to hear, both from our members and frankly in the press and in the public, about safety incidents and critical incidents. And we asked our members about them in the survey, and we found that they're growing. 54% of nonprofits reported increase of violent or dangerous incidents involving clients. This is a direct result of understaffing and lack of resources for our members. So we usually try not to talk about stuff like that. Our members are often understandably pretty uncomfortable about bringing that up publicly, but we think it's something important to mention. I've heard time and time again, those of you that stuck with the Appropriations Committee on Friday night, heard this time and time again that we've been doing this for a long time, but it's never been like this. And I think it's really definitely showing. As others have mentioned, there's other parts of the law where inflationary increases are built in. And the most relevant recent example and the most impactful for our members is the minimum wage. But there's other things. We spent some time earlier today talking with the DSS commissioner about nursing home rates, the legislator salaries, constitutional officer salaries, campaign election funds have all recently been indexed.
Your time is complete. Please summarize.
Thank you. So we know how difficult it would be to get us back to the buying power of 2007 levels. It would be in excess of $900 million. And that's why we don't ask for it every year. We know it's unrealistic, but we hopefully will look forward to breaking this cycle in the future, stopping us from getting to the place that we're at now as a state where nonprofits have these large appropriations asks. And so thanks for the opportunity to testify in support. I'm happy to talk about the substitute language or even any of the underlying language in the bill. And because we're also working on similar proposals to that, if anyone has any questions. Thank you.
Thank you for your testimony, and then thank you for also noting that this was something we tried to do last year. We got it out of this committee, and then we didn't pass the state budget, but would very much like to get it through the process. Are there comments, questions, members of the committee? Yes, Representative Gilchrist.
Thank you, Mr. Chair. You made me think because I was there Friday night and the comment was made about creating the working poor. And I don't typically do this, but I'll share one story from Friday night. Was a woman working at, I believe, in Oak Hill, trying to serve those with intellectual and developmental disabilities and trying to work there full time. She ended up having to live in her car homeless with her daughter. So yes, we are creating the working poor with this low level of wage. So thank you for your continued advocacy, and ideally we can get this across the finish line.
Yeah.
Thank you. Representative D'Amico.
Thank you, Mr. Chair. Thank you, Ben, for coming. I wish you didn't have to come to any of these of our committees and make this request year after year. So I'm going to give you a softball and let you do something with it. What justification has been offered to you for the underfunding year after year after year?
I don't know that there's been a justification. I think I would say it's widely acknowledged from the legislature, from both parties, from the executive branch, that we need to better support this system. I think the challenge is frankly how we budget as a state, and so I think it's sort of where we're caught every year as an advocacy organization. The Health and Human Services, the state safety net, is about 10% of the state budget. The state is responsible for paying for these services, and a portion of them are, almost half of them we get a federal reimbursement for. IDD services, about half of the cost in the federal government. They're part of the Medicaid program, as are some other pieces. But ultimately, this is the state's responsibility, and so it's a big number. If we had this in statute and it had been implemented over the years, I can say with a great degree of confidence, we would not be here today asking the legislature for a $264 million increase next fiscal year and an additional $237 million in the second year of the biennium. That gets us like halfway there. And so this is one of our sort of structural solutions. There's things that it would do that would help our members budget. And then there's also very state budget insider baseball reasons why this makes sense. And the biggest one being that regular inflationary increases to these services would be built into current service projections that the state does every year as it budgets. Right now, when you look into the out years of the state budget, our costs are flat to what they are currently because there's no provision in statute that increases them. And so if this passed, even though we recognize that we might end up in a similar situation that the DSS commissioner and the nursing home industry have been talking about, where the legislature notwithstands, for budgetary reasons, inflationary rate increases, at the very least, those rate increases are built in to the state's assumptions about what it's going to spend next year and in the next biennium in the out years. And that alone would give us a position to be fighting to keep level funding at inflationary increases rather than starting from flat and going from there and sort of being subject to the political winds, if you will, and to the other obligations and legitimate ones that the state has in its budget. We have $1 billion of spending cap room in FY26 and very, very little room under that cap to increase funding for nonprofits because of the other current services increases obligations that the state has.
Thank you, Ben. I appreciate that. And Mr. Chair, if I may say, since we're remembering phrases that stick in our minds, you fund what you value. So perhaps we should start funding what we claim to value, but that's just my little editorial. Thank you, Ben. Thank you, Mr. Chair.
Okay. Sounds good. Thank you. Couldn't have said it better myself, Representative. All right. Thank you, Mr. Shakin. Good to see you. And
thank you.
We'll move on. Next up, Patty Salgado, followed by Merrill Gay. Is Patty here? Patty is not here. Is Merrill? Merrill was here a few minutes ago. Oh, there's Merrill.
Chairman Lesser, Chairman Gilchrist, members of the committee. My name is Merrill Gay. I'm the Executive Director of the Connecticut Early Childhood Alliance. For the more than 20 years now, the Alliance has brought together organizations that care for and about young children to work for policy change. I am here today in support of House Bill 6937 to have Medicaid cover medically necessary diapers. On behalf of the Alliance members across the state, we want to add our voice to the chorus of organizations you've heard today talking about the importance of this. Most of our members are child care providers, so the intersection on this is that child care providers typically expect parents to bring diapers for their infants. And while this won't solve the problem of diaper need, it will address the problem for those children who are most in need, who have a medical condition now because they're not getting changed enough. And I think this is an important step in the right direction. Just a few of the benefits that would come from addressing this is that, children will be able to be more consistently in early childhood programs. Children's health and development will improve because diseases related to not being changed frequently enough will decline, and parents will be able to work more if they are consistently able to be taking their kids to care and not having to take time off from work to go to the doctor's office because their child has dermatitis or urinary tract infection, etc. Finally, this feels just like a fairness issue. Medicaid already pays for diapers for seniors in nursing homes. It's time that we do this for young children who are experiencing health conditions because they're not getting changed enough. I'd be happy to answer any questions.
Thank you for your testimony. I know that the hour is getting late and we have some other folks who want to testify. I do have a question, though.
Okay.
And it's my mistake for asking it while Representative Gilchrist is out of the room. But we did have a $35 million, I think, fiscal note slapped on this proposal from the commissioner a few hours ago, which is a lot. There's obviously an earnest interest in this building and to figure out what can we do to support families and young children and figure out how we can help address the real fiscal hardships that are out there. Certainly there are other proposals that we're considering, including a permanent child tax credit and other proposals. How do you, given the not insignificant fiscal note, I guess 35 million was the total cost, so half that was the state share, but how should we think about this problem and what to prioritize and what not, and how to best target support for those who most need it, given the resources we have?
So children who are experiencing diaper need are cranky. It's hard for parents to connect with them. I think the Franciscan monk who was here was very eloquent about those problems. Children experiencing those problems are impacted going forward. And we know that when we knock children off of the typical developmental trajectory, the longer we wait to address the problem, the bigger the problem, the resulting problem is. So I would put this pretty high up in the hierarchy of priorities. These are the children who are experiencing harm now. And I'll leave it at that.
Fair. Thank you.
Thank you.
Questions or comments from members of the committee? Seeing none, thank you for being here this afternoon. Next up, we have Nora Duncan from AARP. I didn't see you there, Nora. Good to see you.
I just snuck in. Thank you. It's good to see
Perfect
you.
timing.
I know. Well, it's been a little while, but I've been over at the office listening intently. Thank you for having me here, Senator Lesser, Representative Gilchrist, wherever she is, everybody on the committee. I'm not going to go into everything AARP is. It's in my testimony. I did want to talk today briefly about House Bill 7026, which is the exemption to nursing home bed moratorium. AARP supports nursing home reforms, which support small house, greenhouse nursing home models of care. And this legislation does make a new exception to the nursing home bed moratorium for non-traditional small house style nursing homes. I want to be clear that just because you're in a small footprint doesn't mean you're a small house style or greenhouse style nursing home. I can get you more on this if you want, but there is actually a certification process for being a greenhouse nursing home. But there's a way for the state to move forward with small house nursing homes that don't quite get to the certification level, but start to go with some of the, I would say the values, real home, meaningful life, empowered staff. And some of the goals are really, again, meaningful lives for the people who live in these homes, improved quality of care, improved staff job satisfaction, including staff retention, and cost neutral operations. I did hear a little talk earlier about it's super expensive, but I think actually there's some ways around that. And there is an organization called the Greenhouse Project that has a 400 greenhouse project certified nursing homes over 35 states. I am not an expert in this, but I do know some people who are. So if folks are interested in learning more, the Greenhouse Project has a very elaborate website, and I can always get you guys more information. But this is really a way to start moving away from some of the traditional institutional care models that we have and towards something different. And if we don't take the step to say, this is how we're going to move forward, we're never going to move forward. We just keep not moving forward, right? So as many nursing home reforms as we have passed, we're getting rid of 3, 4, 5 bedroom nursing homes. That's just legislation that passed last session. So I think my point is made. Happy to discuss further. And then Senate Bill 985, which is the approval of changes to the Husky Health Program, reimbursement, and care delivery model. We are definitely in support of Section 1, and we're neutral on sections we don't testify on. But I think the checks and balances that are added here for the legislature to have authority over the state's Medicaid program and moving from fee-for-service back to potentially managed care or back the other way any other time, it's a good place to have checks and balances. I think you've heard from people who do this for a living, literally, this is all they do. And we are doing a lot better. Long-term services and supports for aging and disabled is where we're not doing as well. There's room for improvement, but certainly the General Assembly needs a position on that so that we move forward again in the right direction. And the reason we're paying more is, frankly, we're kind of doing pretty well, but we can do better. And there's a way for you guys to have a hand in that. So wanted to support that piece of legislation. And then in a totally non-AARP related, 26 years ago, I started talking about the nonprofits because that's where I worked before I became anything else in my life. But boy, these guys have been here asking for the same thing for a really long time. I did it. Julia and I used to work together, actually. She's probably the only remaining one. But boy, sitting here and having to wait all day is okay when it's for such a good cause. So any questions, I'm happy to take them or follow up as you guys see fit.
So thank you, Nora, for the testimony. And it's, I don't know, the mood lightens when there's a band playing in the background.
There's quite a party downstairs, actually. It took me a while to get in.
Okay, something for us to look forward to. They're not convened for us though. So you are good with the department's language as is on the greenhouse?
Yeah, I mean, because that came from UConn. It came from a task force. So there's a lot of people who put thought into being able to move forward. You know, we don't want to say there's never going to be another nursing home bed and there's a full moratorium, except for when a few small options, right? So allowing for new models and saying, well, the moratorium is lifted if we can go forward with new models, smaller home models, is good with us.
So Mag Morelli from the Leading Age testified, I don't know, a few hours ago, saying that she wanted, in addition to that, to us to revisit the 15-mile exclusion. Apparently you can't have a nursing home within 50, you have to look at a 15-mile radius. I don't know if you've looked at that before. You want to check on that and get back to us, but.
Is this a CON issue?
Yeah.
You know what? I'd have to look at that because, yeah, it's been a long time since I did a lot of certificate of need work. So I am not familiar with that, but I'll follow up with a few people who I think can help inform me.
That sounds good.
You know, is the answer, is the thing here that like, we can't get a certificate of need if it's within 15 miles of another nursing home? And is the question then, Mag would like to see an exception to that if the nursing home style bed is small house, greenhouse?
That's a good question for her. Yeah, I don't know. She's not here to answer that question,
All right.
but I can
Yeah, I mean,
guess her answer, but I don't know. I think I mean, her other argument was that 15 miles was a cumbersome and not particularly useful metric. Like there are geographical regions, and we spent a lot of time talking about Waterbury and whether or not what's within 15 miles of Waterbury has anything to do with Waterbury, or whether or not there's the river in the way. 15 miles may talk about two different sections of the state that don't have economic or geographic or transportation ties. So
I mean, without knowing it's easy to understand the point of 15 miles in a rural community is different than 15 miles in Fairfield County, maybe. I think in this greater Stanford area. But yeah, so let me take a look at that and see. I'll look back at her testimony and let you know.
Wonderful. Other questions for members of the committee? I'm sure the Nonprofit Alliance appreciates your testimony and support of their agenda.
Not my official, it's just making note for 26 years.
Okay.
Same testimony, but worse. And you know, we're a member of the Nonprofit Alliance, if it helps. And I would say that the people supporting folks with disability in the aging community are represented by them as well. And you know, they all have some good points.
Kumbaya.
Kumbaya.
All right. Any other questions for members of the committee? Seeing none, it's good to see you, Norm.
Thank you, guys.
Next, Julie Flom, followed by William Della Camera. Julie, go ahead.
Thanks. So to the esteemed members of the Human Services Committee, thank you so much for letting me speak today to advocate for House Bill 7024, an act concerning Medicaid coverage for allergy prevention. My name is Julie Flom, and I'm a pediatric allergist and implementation science researcher at Yale. I care for many patients with food allergies and run a food allergy prevention clinic with my colleague, Dr. Stephanie Leeds. I also focus my research on food allergy prevention. Food allergy is a lifelong condition that affects about 1 in 13 children in the US, and I care for kids from infancy through college. And at each stage, I'm really struck by the profound impact that food allergies have on these children and their entire family. Food allergy impacts daily life because each meal carries the risk of accidental exposure, which can lead to hospitalization or potentially fatal anaphylaxis. It has negative impacts on mental health and nutrition during critical developmental periods, and treatment is limited, especially for older children and adults. However, it can be effective in infants and toddlers. And food allergy is expensive. A recent study estimates that the healthcare cost for a single food allergy patient over the course of 1 year is $14,000. So the good news is that we can prevent food allergies. So introducing allergenic foods in the first year of life can prevent food allergy and has been shown in many studies. And US and international experts recently published consensus guidelines that parents should introduce allergenic foods like peanut at age 4 to 6 months and then keep them in the diet. It's especially important in infants at high risk of food allergy because the risk of food allergy can progressively increase with delays in introduction in these kids, especially after age 1. For the children who are allergic, reactions to early peanut introduction tend to be mild, and identifying an allergy early helps us to intervene early because treatment is more likely to cure food allergy when it's implemented in infants and toddlers. Unfortunately, many families don't follow early introduction guidelines due to lack of knowledge, time, and access, and families in homes with lower income and education levels are more likely to delay introduction, which parallels what we see in terms of incidence and morbidity associated with food allergy. Pediatricians are uniquely positioned to help overcome these barriers because babies have regular checkups in the first year of life, including at age 4, 6, 9, and 12 months. And this bill can leverage these existing healthcare interactions by providing pediatricians with easy access to evidence-based information about early allergen introduction and providing necessary supplements to infants who wouldn't be able to get them otherwise. This bill is a common sense, cost-effective way to decrease the lifelong medical, psychological, and economic burden of food allergy for many children and their families. I strongly support the passage of this bill, and my colleagues and I are available to support the planning and implementation of this critical legislation. Thank you.
Thank you for your testimony this afternoon. Are there questions or comments from members of the committee? Yes, Representative Comey.
Of course. Julie, Dr. Flom waited all day to give this, and I appreciate you coming out. I know Dr. Leeds wanted to be here today, but was traveling all the way across the country for a conference about just these types of things. So I appreciate you coming out and giving your input and from a professional, in a pediatrician perspective. Good to see you.
Thank you so much.
So
happy to be.
Yeah, I have a question about you have a clinic at Yale, and can you talk about your the folks you serve, maybe the income levels and things like that, and what you see that sort of stands them apart from, say, folks with private insurance or things like that?
Yeah, absolutely. So we take care of patients with all different insurance statuses, and over 50% of the patients I see do have Medicaid. And, I do notice, in general, it can be harder for them to get referred, to take longer for the referral process to go through and for them to actually be able to access care at the specialist level, especially due to lots of reasons, including transportation issues, the ability to even, take time off work, care for other children if they don't have assistance with childcare, and the whole, logistics of even, making the appointment can be challenging, especially for our non-English speaking patients. So all of those things are barriers. And I definitely have seen children. I had a patient recently, an 18-month-old who came to me and at 8 months had been eating peanut and had what was thought to be maybe a reaction, which actually was probably a virus. They stopped eating peanut and came to me and had a severe allergy that now, we're going to try to treat. But I see that all the time where there's so much going on that it's hard for families to focus on this early introduction. It can be hard for them to access the correct foods or supplements. And so I think this bill would really be just an incredible way to help and also advocate for kind of food allergy prevention being part of general medical care.
Thank you. And is there anyone that this treatment might not be appropriate for?
Yeah, so guidelines and experience, most infants will benefit from this. To be able to introduce allergenic foods, we do need infants to be tolerating a couple of other foods. So there can be delays in food introduction for different reasons, including neurodevelopmental disorders. So there are a subset of infants that wouldn't be able to have this. There's also might be some patients who do have very severe eczema who are under the care of dermatology or allergy or their pediatrician who might want to engage in further discussion and shared decision making. And so for those patients, we would be available and pediatricians would also have that information. But the majority of infants, would really benefit from this.
Yeah, and earlier in the day, we talked about the importance of an education arm of this approach to early to prevention. And I think just your comments would reflect that need to make sure that it is in close, the introduction is being done in close work with and in partnership with the child's doctor and the pediatrician, and the allergist
Yeah, no, and
then,
yeah, oh, sorry.
And then one other question, last question, Mr. Chair, thank you. Can you discuss the strain of having food allergies on parents and on the medical system overall, actually on medical systems, emergency rooms, those sorts of things. And as a doctor, you have a perspective on that. We might be important to hear. Thank you.
Yeah, no, absolutely. So, there's an incredible strain that's just kind of pervasive for food allergy patients and their families. Every year, about 40% of patients with food allergy have reaction, and about at least half of those end up in the emergency room, which obviously has a lot of associated costs. We can see things like even, trauma in kids who have experienced really severe reactions, especially repeatedly. Parents are, even the way parents talk around their kids about, it's like there's this constant fear that the child could have fatal anaphylaxis, and it just really permeates everything. So I think from just a psychological perspective, it's a huge issue. The majority of patients have anxiety. Medically also, I see my food allergy patients usually every 6 months to a year, and try to see them more often when they're having more reactions, and try to kind of get on top of it. But it can be very, very hard for families.
Thank you so much. And, I tell my son, and we would talk about it with our friends and our network of folks, other families with food allergies. And, it's important to have the children understand that food allergies don't define them, and I think that can go a long way, and, making them feel like, they're included and not an outsider like everyone else. I mean, like, outside of everyone. So thank you so much for coming today. Almost set, Mr. Chair. Thank you.
Thank you, Representative. Any other comments or questions from members of the committee? Seeing none, thank you for being here this afternoon and for your work in New Haven. Next, we have William Della Camera, followed by Joseph Edwards, followed by Barbara Ciambathi, followed by Mike, and I will get Mike's name right. William?
Thank you, Chairman Lesser and other members of the committee, to listen to my testimony here today about Bill 7021. I'm a farmer from Northford, Connecticut, and being 6 miles away from Connecticut Food Bank, when they're in East Haven and now they're in Wallingford, we've always been very generous to donating to the food bank. So over the past 20 years, 25 years, we've donated thousands and thousands of pounds of food to them. In 2020, when COVID-19 hit, my farm, we packed fresh produce boxes for delivery around the state of Connecticut to whoever needed them through. The United States had a Farmers to Families Food Box program. And that's when, it became very evident that the food bank was underfunded and overpressured. Working with them through the food box program, that food box program was then, at a federal level, it was abolished. And in 2021, working with Representative Rosa DeLauro, came up with that LFPA program that was mentioned earlier in the testimony today. So that whole LFPA program was really hatched on my farm with me pushing for Rosa to do something for us, and they came up with that Local Food Procurement Act. After that money, we still, to this day, I do pack some boxes directly for delivery, but also that has given the food bank money to purchase produce from local farmers, which was really good for us. And at the time, our bottom line, to be able to sell some produce that is, not generally sellable somewhere else. We might not have a market for it. So a lot of us farmers had leaned on food bank for, here we have a, good local healthy produce we could sell. And it was a beautiful program. And it's a shame that it is now going to be underfunded, apparently. So it leaves us in a place where I feel that from the state giving the food bank the money they're asking for, and the food bank saying that they're going to spend X amount of percentage, which is 15% to the local farmers, is really a help for us, and for us to have, a place to go to and just another customer. This past year, we ran into a few little things, and it's a funding thing where at sometimes the food bank can't give us what we really need to get for that produce. So sometimes, we have to then look elsewhere. So hopefully that with that funding, they could become more competitive. I know that some of the testimony before had alluded to that they can't always pay a market price to us. When, I say that they can't pay the market price to us, but then, we want to be able to be part of these programs, but when we can't even get enough to break even, we can't really afford to go out there and pack or ship this stuff. So I really encourage you guys to see this bill go through. And I hope that even though there is, monetary funding attached to it, I hope we can get it through, not only for us as farmers, but it's hard to see your neighbors in that much of a need of produce, so it would be a real good thing to see this bill go through. And if you guys have any questions for how we work with the food bank, I'd be happy to answer them.
Well, thank you for coming up here and for your testimony. It's a hard job being a farmer, but also coming up to advocate for those who are hungry is, on top of that, is laudable. So thank you for doing that. And we are hoping to do more to support the food bank, and that's something that I'm hoping we can get across the finish line. Representative Shank.
Thank you, Mr. Chairman. William, I want to say thank you for taking the time. Thank you for waiting all day for sharing with us why this is so important to you and the impact that you've seen directly in your community and in your region of the state. Is there anything else that you would want to suggest, of how this could be a stronger partnership between farmers, the Connecticut Food Bank, and the state, and serving and alleviating the dire issue of food insecurity?
So on the whole, coming up here and sitting here all day, in case I lost my whole farm to hail this year, and I'm the crazy farmer that drove to DC.
Yeah.
So sitting a few hours here is nothing compared to spending 91 hours in a tractor. But so that's where I came up with this. Like everybody says now, oh, you're doing all this fighting for farmers now. And I talked to all my friends and they appreciate that I'm fighting, but the agriculture industry is in an epidemic right now. It's not just me. It's not just my friends and all representatives here, all your farmer constituents. A lot of myself and a core group of us farmers, all we do is farm. There's a whole bunch of farmers in the state that work a full-time job and then farm on the side. And we're all in the same boat. Our cost to do business in the state, and it's not just us in this state, it's all over the United States, is just astronomical. It's hard for us to make any money, but this is to see the money be able to stay within us is a nice thing. To see the money stay in Connecticut and not go to the factory farms that are overproducing, and that are putting us out of business, small farmers. It's nice to see that you guys want to help do this. The Connecticut Food Bank, Don Pacini that runs it, he's got a beautiful system. He's had beautiful systems going. He knows how to move produce. A lot of times at the end of the day, he doesn't have the money. We still donate to them. We still give to them. I mean, I don't know. I tell people I want to be part of the solution, not part of the problem. And all of us farmers are willing to work with lawmakers, with the food bank, is how we could do this and do it good. And Paul had mentioned before that, and when we're this time of year, when we're starting to seed in our greenhouse, we only have a certain amount of time to start those plants. So if we know that the food bank has the money, is going to have $1.5 million every year to spend, so we try to figure out what we have customers for from last year, or what the market might be, and how much we want to plant. And if we plant just an extra row or two, knowing that the food bank is going to be a good customer to us, and it's not going to, it's not like working with a ruthless wholesaler here in Hartford or Boston or New York, wherever it may be, someone that's going to care for the farmer and is going to work with us, then it's in the planting tool, it's easy for us to plant that extra row, and it just becomes part of the system. It would help us a lot, not just myself, but every other farmer in the state, whether, you know, it's corn or tomatoes or eggplant, or we might grow some specialty crop that we didn't really have a market for. We send it to the food bank, and then we hear that when they brought it to a food distribution, that those people loved it so much because they've never seen it fresh in Connecticut. You know, something maybe like kohlrabi or something you don't see a lot of. When I was delivering those farm boxes, those food boxes to the families, it wouldn't be uncommon for me to get a letter or a call from someone. And, you know, people that have never, one lady called me to thank me that she got the freshest head of cabbage she ever got. She you know, so it's touching stuff like that. And no, they do it every day, and we just want to support them. And you support the food bank and support them, and you know, we all support each other. In the end, we could have something very successful.
Thank you for sharing that. I think that was very insightful. And to your point, you know, of it sounds like it's more of a sustainable plan, right? Where if this is able to move forward, where we're directly helping our farmers, our food bank, the people here, Connecticut, and truly keeping it local. So thank you for all that you do.
Thank you, Representative. Representative Coney.
Yeah, I just wanted to say thank you. You're my neighbor to the north. I'm in Branford. So I drove by your property the other day, and the tractor was on the hill, I guess, that you took to DC and around. Thank you very much. And I am worried about our future food systems, you know, and I think that having our farmers that are doing our vegetables and, you know, the non-meat products is going to be really key to our future. And I'm just wondering if you have any thoughts on what you see from your side of that story, because I do worry about the future of our food sources.
Not to be like not to try to be a bearer of bad news, but without mentioning names, I can mention you at least 8 farmers right now in the state of Connecticut that we'd have no idea how we're going to go on this year. We have to go find money, whether it's finding it the wrong way through a hard money lender or trying to get a loan through the USDA. And we've been left in a precarious spot because of the disasters and the weather events we've had over the past few years. That's going to be our most dangerous part of this whole making our local food system viable. First off, we have a shortened growing season, obviously, because of our weather. But then when we grow something and we have a awful natural disaster, whether it be the river flooding or the hail that I got, which we're going to get more of, and we know it. And I mean, there's no way to change that stuff. But the way to change it for we're stuck right now is to have a disaster program and I know it's not your committee that does that, but to be able to bail us out a lot faster. Because right now, even though whatever work that I had done or did or got this money to come here, we're still looking at months and months to get it away. And June is not the answer. The bills, unfortunately, a lot of us still have bills from last year that aren't paid. And some of us, maybe they might be $20,000 or $30,000, but we're only a 20-acre farm. Some of us, they might be a couple $100,000 and we're a 100-acre farm. But how do we go ahead? Because most of that's debt to whether it's a fertilizer or a seed salesman. Where are we going to get that from? So there's some big farms right now in the state of Connecticut that are in that position, and it's going to be harder for us to go on. And I'm not telling you that we're going to park our tractors, but it's a possibility that it's coming a lot sooner than it is later. And there's no replacing that. There's no replacing the local farmer. It's just, there's not.
Thank you so much. Thanks for your activism and sharing your story with us, staying here all day with us.
Thank you, Representative Comey. You're an incredible advocate for farmers and for food insecurity. So we are very lucky to have you, and what you've done with Congresswoman DeLauro is incredible. So thank you for being here.
Thank you.
We will do what we can. Thank you. Next, we have Joseph Edwards, followed by Barbara Siompathi. Joseph? No, Joseph. Is Barbara here? No, Barbara. Okay. Is Mike Van Vlanden here? Excellent. Great. I believe you're closing us out.
Good evening by now, members of the Human Service Committee. My name is Mike Van Vlanderen. I worked for Reliance Health, a nonprofit in Eastern Connecticut for the past 33 years. And I'm here to speak in favor of Senate Bill 1358 with the amended language for indexing for nonprofits. I'm not going to pretend to speak as eloquently as Bruce did or Ben just did, which was fabulous, or my boss, our CEO, Carrie Dyer, earlier in the day. But I want to say two things. I'm going to begin with the premise that because you're on the Human Service Committee, you're friends and allies. And you've heard the stories year in and year out, the struggles of nonprofits. So what I'd like to do is provide some clarity on the data you've heard and sometimes seen in writing that isn't quite accurate. And as a teaser, in case I run out of time, I want to point to a bit of a roadmap for dealing with the elephant that will be in the room once you leave here, which is guardrails and volatility caps, which I can't believe guardrails only came up once all day, and volatility cap came up not at all. So that's amazing, unless it happened when I went to use the bathroom. Anyway, clarifying numbers. I was looking at an OPM written testimony that spoke against this bill and cited numbers such as that the nonprofits got 26%, where they will have over the last since 2021 and going through to 2027, including the governor's budget. I'm not sure where that number is from. As Ben stated earlier, it's closer to 15%, and depending on your funding source, whether it's DMS or DDS or any of the other state agencies, it can be closer to 11% in terms of annualized funding. There has been some one-time funding, but as you know, that can't be put towards staffing and any sort of ongoing costs. Which gets me to the timing issue. Are you all aware that the last appropriations for ARPA funds from the last legislative session, the 50 million, has not gotten to the nonprofits yet? Are any of you aware of that? It has not. We got letters, today's Thursday, we got letters last Friday saying that we needed to sign an amendment and the check would be in the mail soon. But as of right now, we have not seen that money. That's a year away. That's the timing issue, right? This bill, as it's written, to the DSS commissioner's point about 30 days for this, 30 days for that, it does require nuance, right? Depending on what your contract is. But it's the intention of the bill is good. Indexing would make it stronger. But these are things you probably know. My second and last point, if you don't already know this or aren't aware of this, there was a study done by Yale, the in-depth review of Connecticut budget guardrails analysis. It came out in December of 2024, so it's only 2 months old. This should be mandatory reading for anybody on the General Assembly in terms of dealing with guardrails and volatility caps. I see some nods, so some of you are aware of it, I'm sure.
Your time is complete. Please summarize.
I will. If you can get your colleagues to read it, it speaks to a static approach, a dynamic approach to dealing with guardrails and all the challenges. It's long and it's boring, and I know that because I read it twice. But again, it should be mandatory reading for anybody that is going to be dealing with financial issues for the state. Thank you for your time. Thank you for staying here all day, and thank you for letting me testify. Any questions, I'm happy to answer.
Thank you for your testimony. Well, certainly we are very much aware of the ongoing discussion about the guardrails that is largely happening in the committee other than this one. But I think that is something not lost on the members of this committee. Are there questions or comments? Seeing none, thank you for being here this afternoon.
Thank you.
We actually do have one additional person I have listed, Alex Perfetto.
Appreciate you. I guess there's some technical difficulties with me signing up last night, but thank you guys for your time staying. Thank you, Senator Lesser and everybody from the Human Service Committee. I live and vote in Middletown, Connecticut, so thank you for everything you have done for Middletown around the neighbors, as well as Christy Carpino. My name is Alex Perfetto. I'm a recovery support specialist for the Department of Mental Health and Addiction Services. I will be quick because many things are touched upon. I want to make sure you guys have the rest of your night, but I think I can answer some of the questions you've been asking all night, in all honesty. So to briefly explain my background, I was diagnosed with bipolar disorder at the age of 10. I was hospitalized 27 times from the age of 10 to 19. I went into DCF custody at 15, went to 4 different residentials and a supervised apartment before aging out into young adult services at 19. In totality, this equated to 27 hospitalizations, 4 assisted group homes, and a supervised apartment. At 30 years old, I now been working for the state for over 4 years. I've worked as an RSS in the nonprofit world. I worked in inpatient services for a little bit over 2 years, and now I currently work in outpatient services. So I have a very unique perspective as far as the peer support role and how it's utilized and allocated. I've collaborated with Michelle Cook, the representative of Torrington, who's a big advocate on mental health. I've collaborated with members of the Office of the Commissioner. I have a very close relationship with Nancy Navarrete, as well as Amy Maricino. I've traveled around to a bunch of different young adult services to speak on their programs. For about 5 or 6 years, the Commissioner and Amy have been asking my feedback on what is beneficial to our young adults. How can we get them engaged? What different wraparound services can we bring into the community? How can we stop people from isolation? And I basically kind of described peer support, that there's a lot of versatility with it, which is why it's catered to direct lived experience. So I would rather just open up to questions to you guys, if there's anything I can answer. And if not, I just want to thank you for staying here for the entire day and hearing us out. So thank you.
Thank you. Thanks for your work and for leveraging your experiences to try to help other people. I think it's really powerful. Are there questions or comments from members of the committee? Seeing none, thank you for being here with us this afternoon.
Anytime. Have a good night, people. Thank you.
Are there any other persons, members of the public who wish to testify at this time? Seeing none, want to thank folks for attending this public hearing this evening, and wish you a pleasant evening, and we will be back next week. Thank you very much. We are now adjourned.